very good morning, everyone. Welcome to our day 2 session of Gynec Oncology. I am Dr. Sushma, oncology resident, a newborn in your oncology family. It's been less than 1 month I had joined this institute, but I'm very grateful I got an opportunity to meet you all. To start with our session, I would I would like to say something actually. If you want to see a quality like a decent, there is a person who is very decent, humble, but still bold and can put her point here in front of everyone. That person we have is our principal director, Department of Gynec Oncology, Fortis Hospital, Dr. Rama Joshi ma'am. I would like to welcome her on the stage and give a brief introduction about our session today.
I think these are great words, maybe that I don't deserve these. Uh, Welcome you all to the Fortis Cancers Summit session on gynec oncology. And we are so happy to see a dedicated GYN oncologist in this session. And I think it's a proud privilege on behalf of the organizers. I welcome you all and thankful for really taking out the time out of your busy schedules and joining for this program to make it a grand success. Thank you all.
Thank you so much, ma'am. So, rather than wasting our time, I would like to proceed with our first session. So, I would like to call on chair Dr. Gayatri Kamath, ma'am, Additional Director, Department Gynecology, Fortis Hospital, Bangalore. Dr. Rupinder Shekhon, sir, Chairman, Department of Gynecology, Artemis Hospital, Gurgaon. Dr. Abraham Pedikail, sir, sorry for if I'm spelling wrong. Senior Consultant, Department of Gynecology, Vellore. Please, sir. I would like to introduce our first speaker. He is going to speak on the topic New FIGO Staging of Endometrial Cancer and its Clinical Implication. Dr. Shalini Rajaram. Please, ma'am. She is a Managing Director and Professor, Department of Obs and Gynecology, University Medical College, Science, Delhi. I think that's wrong. I introduced myself. A very good morning to all of you. Yeah, that'll be there on my slide, doesn't matter. I thank Dr. Rama Joshi for the invitation to this mega conference and with so many tracks, and I hope we have a dedicated session like she said today. But she's given me only 10 minutes, so 10 wickets in 10 minutes as an opening batsman. Let's see what I can do in 10 minutes. The previous slide. Yeah. So basically, I'm at AIIMS Rishikesh. I had the Gynae Oncology MCH program at AIIMS Rishikesh. And I'll be speaking on the new FIGO staging of endometrial cancer and its clinical implications. So basically, when we talk about staging, it was anatomical and pathological staging. So the extent of disease, it was a simple staging system. And we taught our MBBS students the staging systems. It was easy to remember. But now I think there's a change towards a more complicated system incorporating a lot of molecular subtypes of molecular oncology. So it's become more precision-based and more personalized now at the cost of being not simple any longer. So there was this furor after the publication of this the staging in 2023 June by Dr. Jonathan Berwick, and there's been confusion, there's been a lot of apprehension, there's been a lot of discussion on how are we going to incorporate it into our daily day-to-day practice because of the intricacies and the complexities of the staging system. But we know that change is necessary, and over the last decade or so, we've seen new treatments, new trials, prognosis being much better with molecular typing. We are all familiar with it over the last 10 years or so. And even TNM classification, which was supposed to be very, very anatomy-based or surgical staging-based, depending upon the spread of disease, has incorporated molecular staging in its classification because of breast cancer having so many other molecular markers and prostate cancers. So FIGO is also changed to incorporate some molecular subtypes, basically to define various prognostic groups and create substages for appropriate therapy, that is surgical, radiation, or even immunotherapy. So the important aspect is that they borrowed from ESGO guidelines, which we have used over the last 10 years. We didn't know how to incorporate it and how to manage it, but ESGO had already set in the template, and this is the same template that FIGO is following. So with the molecular classification, remember that it applies only to stage 1 and 2. So you have the surgical, anatomical, and histological classification, which we used earlier, and they say where feasible, incorporate the molecular staging. But that's going to be a little difficult if some people start using the molecular staging, some people use only the anatomical staging. So let's see how that's going to pan out over the years on how you can. I think there'll be a tend to using molecular classification because that's common, but FIGO says use it when it's feasible. And in case of molecular classification, only pole mutations and P53 are taken into substaging early stage cancers, in stage 1 and 2 only. In stage 3 and 4, it's recorded, but does not change the stage. It is recorded because MMRD and NSMP does not come into the molecular substaging when you use it for stage 1 and stage 2, but it does help in your treatment modalities. So stage 3 and 4, they don't actually incorporate molecular staging. So we now again, FIGO has simplified it. You have only 2 types now. You have non-aggressive and aggressive. So non-aggressive would be endometrial cancer grade 1 and 2, and low grade, that is low grade, that's it. And the rest of it, serous, clear cell, mixed cell, undifferentiated, etc., becomes aggressive. So it's become very easy now. Non-aggressive is low grade, grade 1 and 2, and aggressive is all the others, right? Then again, tumor grade still retains can retain the 3-tier system, that is grade 1, grade 2, grade 3, when you're talking about fertility preservation. So you would like low-grade cancers without myometrial invasion for fertility preservation. So the binary grade is used for all other cancers, and for fertility preservation, you can still use the 3-tier system. Because between 5% to 50% of the solid growth, I think when we learned the FIGO staging in 2009 and 88, it used to be modular growth pattern, which I never understood. But now it's that solid growth pattern. So if you have a solid growth pattern of 50% or more, then that is a grade 3. So coming to the new endometrial staging, stage 1A now again has gone back to the 1988, where it is confined to the endometrium. 1A2 would be non-aggressive. Both 1A1 and 1A2 are non-aggressive histological types, showing either confined to the endometrium or less than 1/2 of the endometrium. And 1A3 is a low-grade endometrioid carcinoma, along with the low-grade endometrioid carcinoma of the ovary. Earlier we said once the ovary was involved, it was stage 3. But now this is a clonal development which occurs synchronously in both the endometrium and in the ovary. And 1B is non-aggressive histological types with myometrial invasion more than 50%. 1C becomes all aggressive histopathological types confined to the endometrium. Okay? So these are still the surgical, anatomical, pathological classification. Molecular subtypes have not come in. So myometrial invasion, when there's none, again we come back to the 1988, less than 50% becomes A2, and more than 50% becomes stage 1B. So coming to stage 2, again stage 2 was very simple earlier, it was just cervical stromal invasion. But now it's become stage, if there is cervical stromal invasion with LVSI, substantial LVSI, we'll talk about what is substantial LVSI, and aggressive histopathological types with myometrial invasion, it becomes stage 2. So stage 2A is our original cervical stromal invasion. Stage 2 would be substantial LVSI, which I'll just show you on one slide later on, of non-aggressive histopathological types, and 2C. So whenever it's aggressive and there's myometrial invasion, it becomes 2C. So this is still the surgical or anatomical class of staging. So when you talk about lymph vascular space invasion, I was very confused. So I talked to Santosh yesterday and asked him. They just give numbers like 0, less than 5, substantial, more than 5. So he said it is per slide. In the whole slide that you scan, and if you don't see any LVSI, or you see a lot of LVSI, a lot of lymph vascular spaces with the infiltration, and then it is only at the advancing edge of the tumor that the LVSI is counted. So I think we'll have to discuss with the pathologist more, and he says that sometimes you can miss it at all if you only see 1 or 2 slides. So that's one aspect. So coming to the endometrial cancer stage with molecular typing, so when feasible, use it, allows better prediction of prognosis, and encouraged in all stages. You do it in all stages, but you use it to substage stage 1 and 2, when M and an M notation is used, and it is best used for the management of stage 1 and 2. Stage 3 and 4 is your management based on risk types. And even stage 1 and 2 will be on risk types. So some clinical tips, they say you must do the molecular classification the beginning itself in your biopsy specimen and not in a final fixed specimen. It has to be in the biopsy specimen. And you can use a simplified surrogate markers, which is P53, MHS6, and PMS2 for the MSI instability, and a poll if you can do. In our institution, we do everything except poll. So introducing poll may be a little expensive, but at some point of time, that will be done. And poll mutation, they call it ultra mutated. They say high mutational burden, but it has the best prognosis. So I can't understand the high mutational burden and the favorable prognosis. MMRD and the NSMP are intermediate. And P53 abnormality, they say low mutational rate, but it is most aggressive. Okay? So a small subset of tumors, about 5%, are multiple classifiers. Multiple classifiers, you will need poll then for it. Poll and P53 and MMRD and P53. So if P53 is found with these, you actually don't disregard the P53 and you call it poll mutated or MMRD mutation. Because P53 comes in the pathway of mutation at some point of time. So it is not classified as P53, but it is poll mutated or MMRD. And for tumors with both poll mutation and MMRD, we do not know exactly what to do about it because the data is limited. So multiple classifiers will be these two. Now coming to the stage with molecular classification. So once there's poll mutation, be it stage 1 or stage 2, be it cervical stromal invasion or substantial LVSI or the histological type or myometrial invasion, she becomes stage 1A, which becomes a low-risk group, and you can de-escalate treatment, but I'm not very sure if you see write substantial LVSI and you write myometrial invasion, whether we are going to do it or not. Can I get 2-3 minutes more? Yeah. So 2C is P53 abnormal, and 2C is P53 abnormal. So they become 2C regardless of histopathological type, and it is confined to the endometrium with any myometrial invasion. So stage 3A, 3B, 3C, again, I think you can go through the books because the time is short. And I'll just say a few words about low grade. Once there's adnexal involvement, substantial, it becomes 3A. But specific criteria for calling it 1A3 would be myometrial invasion less than 50%, absence of substantial LVSI, absence of additional metastasis, ovarian tumors unilateral, limited to the ovary with no breach in the capsule. So fallopian tube also would be classified as 3A. And this uterine subserosal involvement, again, the pathologist has to come in. I don't know if it's called deep or it's called serosal involvement, which becomes 3A2. And lymph node status, again, you have the C1, C2, etc. Then stage 4 endometrial cancer, this you can look up in the books. And Dr. S.K. Giri said that increased number of substages from 10 to 23. Now you have 23 substages. And so the advanced stages you have from 6 to 11 substages, because even a para-aortic above the renal vessels, below the renal vessels gets a different stage. So it's become definitely much more complex. So maybe I'll stop here because I've crossed my time. And so you can stratify them according to the risk stratification for management. And yeah. So it is more complicated. You can use molecular typing when feasible, applicable only to stage 1 and 2, and presence of MMRD or NSMP does not modify stage 3 and 4. The molecular stage is recorded and may help in directing therapy. Thank you so much. I had to rush because Rama gave me only 10 minutes, and thank you.
Yeah, thanks, Shalini. That was a very extensive explanation of the whole new FIGO staging. So in interest of time, we'll not take questions. Only one small comment, that there was a paper which has been written by the pathologists. And they have said very nicely, the gynae pathologists and all, the gynae oncologists, they have come up with this new classification without including any pathologist in their panel. So, only one, but he was not a member of their International Society of Gynae Pathology. So, and they're saying they're basing everything on pathology without really understanding the whole of it, which includes all this solid tumor, not solid, this, that, and the other. I mean, what are they calling solid and what are they calling not solid? And also the fact that it has now become so extensive for why do we have a staging at all? So that we can have a kind of a universal statistical module. Yeah, so I mean, when this is not happening, this cannot happen with this kind of classification, obviously. So we don't know how successful this would be, and I think most of us would perhaps have to stick to the previous anatomic classification.
By the time we get used to it, it might change again.
Yeah, most likely.
Dr. Shalini, I think you did a brilliant job being an opening batsman. Well done.
Any question from audience?
Or any comment?
This is a very complicated staging, and I don't think the therapeutic guidelines are based on the present staging. All the therapeutic guidelines are based on risk stratification. Okay, for that we still use old staging system. So present staging system is going to be only theoretical, and most centers across the globe are still not happy with this kind of system. I think high time. I think this system is removed.
It was an excellent presentation, and I think the time you have already addressed the practical issues, which are very, very important. I think we have to be more conversant so far as the pathology is concerned. Now, pathological work has definitely increased in this particular staging. So I think you should have a very, very strong pathologist dedicated to maybe the GYN oncology to make this staging success.
Yeah, I just one, sorry.
Main implication of this 2023 is many ones will become twos because all aggressive have become two now. So I think we will, as gynae oncology, will have to counsel patient कि आप पहले one में थे अभी आप two में हो गए. So that's the problem in this. And poly has got implications because any aggressive with poly becomes stage 1A, so you don't give escalation in them. So that also is a problematic thing. And like madam, you pointed out, only one pathologist was part of this staging, so it's too early. So there is a big article in IJ, International Journal of Gynae Cancer, which says it's too early and too much.
No, I have just one technical question, because normally when we have incomplete information about anything, we say suboptimal staging done. So if we don't have all the 4 molecular markers, should we include that in our molecular staging, or we should say molecular staging incomplete? Because if you are doing 3 and not doing 1, you have multiple classifiers, it changes the whole thing. So whether we should stick to not available, or we should use incomplete molecular staging.
Are we having any pathologists here? Yeah. So I have a doubt with the pathologist. Now, being a benign gynecologist, when we have postmenopausal ladies with thickened endometrium, can we use pupil biopsy and try to do molecular marking? Does it make any sense? Yeah? Yeah, so now if there's very minimal material between histopathology and molecular marking, what would you choose? on as a adjuvant thing when we are doing assessment? Thank you.
Salini ma'am, excellent staging. I'm hearing this for the first, like you said, like before it was so simple, and the students used to be very happy about this endometrial staging because it's the most simple and easiest. But now it has become complicated, and I just want to know, like in the previous staging, we used to see that while staging, we keep the sample saying. It is the fluid, while staging we take out the fluid, and whether it is positive or negative we just have to mention in the previous one. Now do we do that? Is still there? Mentioned, but it does not matter in the staging, no? Okay, now also it's the same.
Okay, I think
Okay,
for
thank
lack
you.
of time, I think we should go on to the next one.
Yes, thank you so much, ma'am, for making it very clear and structured. Yes, ma'am.
They will call the panelist, I think.
Your moderator. Yeah, we will. Yes, ma'am.
I think we'll move down and the panelists
So,
can come.
Let's
sit in
let's
front.
proceed with our next discussion. Thank you so much, ma'am, sir, for joining the session. So we have our next session, a panel discussion on impact of molecular subtyping, redefining the adjuvant treatment in endometrial cancer. I would like to call on stage to moderate this session Dr. Neha Kumar, Senior Consultant Department of Oncology, Delhi, and Dr. Vinota Thomas, ma'am, Senior Consultant, Department of Gynecology, Vellore. Thank you, ma'am.
We hope to grab many more wickets than Dr. Shalini in that record time. Welcome to this panel discussion. And we would like to invite our panelists, Dr. Parisima from Gujarat, Dr. Narendra Kumar Bala, a radiation oncologist, on the panel from Mohali.
It's not getting transmitted to the screen. Yeah, thank you.
Dr. Jaideep Bomik from Kolkata, and Dr. Kanika Gupta from Delhi. So thank you so much for joining us. A brief preview of what has brought us to this discussion. So in 2013, TCGA brought about the sub-classification, and what made it very easy in 2015 and 16 was the realization that this TCGA could be interpreted with immunohistochemistry. And in 2017, we had approval of pembrolizumab. In 2020, we had molecular insights from POTEC 3, which made the clinical relevance of these molecular subtypes. And this was incorporated in the ESGO-ESTRO ESP treatment guidelines. And we also realized in 2020, we could use trastuzumab in HER2-positive tumors. In 2021, we could add lenvatinib for MMR-proficient tumors along with pembro. And then in 2023, we had approval of immune checkpoint inhibitors in first-line therapy. And we already have poured much angst into the FIGO 2023 staging. So the objectives of this panel is to discuss when to use molecular diagnostics in endometrial cancer and to interpret leads from molecular testing to help aid therapeutics. So we know why we require molecular diagnostics. It allows us to make objective diagnosis and help overcome errors in interpretation by histology. But on the downside, we need to carefully interpret MMR and P53, and there are costs involved. So I'll ask our panelists. I'll ask Dr. Parisima from the public sector, when do you perform a molecular diagnostics, like we had the discussion on the endometrial specimen, or in the final histopath, or do you use it in all cases, or in those which are pathological high risk? Because we need to cut down on costs. It comes to almost 20,000 in our hospital for just molecular testing.
Yeah, for us, now it has become comparatively easier because most of the things have been included in many yojnas and all. So we can order either on specimen or on biopsy, both. I mean, anyone, whatever we want to. But as of today, they are doing mainly on the specimen, because many a times, they come with the slides and all, so they are just reviewed. So as of today, we are doing on the main specimen, and we have MMRD, all 4 proteins, and as we have P53.
You do poly also?
No.
Okay.
That is available only on request and if patient can afford it.
Okay.
Uh,
So it's
and
not free in your hospital?
No, that particular is
Poly is not free.
Not
The rest are
free.
free. Okay.
That is, the other things are free. And yes, we have ERPR also.
Okay.
And no, PLD1, no.
You don't do L1 cam and beat. Okay, get it. I'll ask Dr. Jaydeep from, you work in Tata Medical Center. What is your practice? Do you?
So this is actually an evolving process. We are still evolving. And the standard practice was, of course, we will do the standard histopathology with P53 at the beginning on an eventual biopsy specimen or the block review if you
So
get
in
that.
all, across all grades?
Yes, yes.
Okay.
We'll do that at first, and then MMR was assessed in the main specimen. Now it is evolving to, now we do all the MMR and the P53 on the first specimen to start with, and pole mutation is tested in the main specimen. But again, it's evolving. So hopefully in the next few months, we will be shifting to doing all the tests at the very beginning. But there are like logistic issues. I mean, patients have to pay, patients do not continue treatment in the same institution, they move. So there are other issues why you have to take these things into consideration.
I think what is to be considered is we have to figure out what works best for our institution, for our patients, for our workflow. So we'll go to the...
I like to add here because, still, even if you do on a biopsy, all this molecular testing, there's no guidelines how you have to proceed with the surgical staging. Even if she is P53 abnormal positive, am I going to do anything? There are no still guidelines. And in private, sometimes patient, once being declared that she is a cancer patient, they are in a hurry. So they don't want to wait for this molecular 4 or 5 days extra to come in.
So agreed, ma'am. So you have to really make out what works
you
best.
have to tailor-make them. I mean, you cannot have a policy of institute. They are coming from outside. You are doing them. So you have to make accordingly.
So we'll go on to our first case. This is a 45-year-old lady who came to us following a hysterectomy done 5 months ago for a presumed fibroid uterus with discharge per vaginum. On clinical examination, there was just a transverse scar, suprapubic scar. On the speculum examination, there's a 0.5 centimeter growth at the vault. Per vaginum, there's a hard irregular mass with bilateral parametrial involvement. So the MRI findings showed the same with bilateral pelvic adenopathy. So the biopsy by the pathologist called it an adenocarcinoma, but they could not conclude whether it's an endocervical or an endometrial origin because it was diffuse, patchy P16, positive for Vimentin, focally positive for ER, negative for WT1P, Fortis, and they said this is a dilemma. It could be an endometrioid carcinoma, but points against it is that there was no squamite differentiation, focal ER, negative PR. It could be an endocervical adenocarcinoma, but against it was positive Vimentin, negative CA, and patchy P16. So I'll ask Dr. Narendra, because very often these patients post-hysterectomy land up in your OPD first and not our surgical oncology OPD. How would you manage her?
Anyway, we have to discuss all the cases in the tumor board and take the opinion from even the gynae oncologists and the medical oncologists. In that, if with the immunohistochemistry can differentiate, it is from cervical or from the endometrium first, and then we have to make a decision because if lymph node is positive, we have to be then stage 3C1. So in stage 3, you have a two approach. Either you have to go with the radiation with concurrent RT, and if surgery is possible in this case, then we have to go for surgery.
So will you ask for any other tests, or we'll just happy with this biopsy?
No, we can have immunohistochemistry to differentiate it. It is from the endometrial or from the cervical. Like
so this was the immunohistochemistry done.
Yeah. So then if it is even endometrial or endocervical, the treatment is not going to be changed. Treatment will be with the same. Okay. Treatment not going to be changed. Either we have to give the chemotherapy 4-cycle carbopacly first, or give the CTRT first, followed by the carbopacly.
Okay. Dr. Joydeep, how do we treat this patient? Would we add radiation, chemo, radiation with chemo?
I would insist on a proper diagnosis here again, because I think there will be some subtle differences in the management of an endometrial cancer recurrence and a cervical cancer recurrence. So approaches could be different. So the other test I was thinking about is if we can do the HPV-ish study on the specimen. So if that HPV is there, then it points more towards the cervical adenocarcinoma.
But this was patchy P16.
Yeah, there's patchy P16, P53, again, that was also patchy, wasn't it?
Yeah. So what actually gave us this clue was she came back to us and gave us this essential family history that her sister was treated with metachronous colon and endometrial cancer. And we pulled
You
out
can
the
do an
sister's
MMR, yeah.
records, and her biopsy was MMR deficient.
So that points towards an endometrial cancer.
And these MMR positive deficient tumors are usually estrogen receptor negative. And so we requested for MMR IHC, and similar to her sister's biopsy, she was proficient for MLH1 and PMS2, but deficient for MSH2 and MSH6. So if we think this is an MMR deficient tumor with pelvic lymph nodes enlarged, Dr. Parisima, how would you treat her? Would you again give chemotherapy, chemoradiation, radiation alone in an MMR deficient tumor with pelvic adenopathy post-hysterectomy?
We normally resort for sandwich therapy kind of thing, chemotherapy, radiotherapy, and then completion of chemotherapy.
Okay.
So chemotherapy is usually, since it's pointing towards the Lynch syndrome, so accordingly it will be decided. In our institute, usually they go for carboplatin and that combination.
Okay. So we got this from the POTEC3, the molecular insights that in MMR deficient tumors, chemotherapy has no added value, but we don't have randomized control trials about treatment escalation. So this patient received just chemoradiation, the other arm of POTEC3, cisplatin versus radiation. She is doing well 1 year after treatment, and she's been diagnosed to have MSH2 germline mutation in October, along with the same as her sister. And the learning points, we did CT thorax, pelvis with thorax.
Can I add here, Vinita? I would probably also go for a biopsy from the lymph node, because an enlarged node on the MMR, although it's very suggestive, but my treatment will probably change, because if the nodes are negative, then a radiation only may be an option in certain cases. But if it's positive, it's upstaged, and when it's upstaged, of course, you need chemotherapy, radiation, both. So these are the things we should be very careful about. Make a proper. It was initially unstaged, so go back to the lymph node, make sure that the lymph node is positive, and if it's positive, then there is definite indication to give radiation with chemotherapy for this patient.
So in her, so our MMR, so MRI pelvis. So as I started off first, this patient went to the radiation oncology OPD first. At the end of treatment, she came to OPD and said, "You treated my sister." Then pull out the records, you found her to be MMR deficient. Then we went back and tested after finishing the CTRT. But when you're looking back, when you look at the POTEC3 molecular insights, stage 3, stage-wise, CTRT, chemotherapy didn't have so much benefit if you look at these two arms. But then we don't have randomized control trials. We still don't have data about de-escalation, and hopefully we will know from the Rainbow trial. I'll go on to my quick 13 minutes, 59 seconds more. So MMR, testing for MMR really has a diagnostic role, a prognostic role, though quite a number of them might be hypermethylated, and the current recommendation is universal testing. So second case is a 56-year-old lady who came with irregular bleeding with watery discharge for bleeding for 4 years, watery discharge for 5 months. On a clinical examination, the uterus was enlarged to 12 to 16 weeks. There was a growth in the cervix. And besides that, there was also a growth at the level of the urethra, and bilateral parametrium was medially involved. We thought it was CS cervix, but the punch biopsy came back as moderately differentiated endometrial cancer, carcinoma, endometrioid carcinoma. Uh, it's P53 wild type, MMR proficient. Therapeutic options, Dr. Narendra. Obviously, advanced case, not surgically resectable because the urethral mass also had involvement of the pubo-vaginalis.
If it's surgically not possible, then then we can give the chemo first or the CTRT, and the, if we give the chemo first, maybe surgically possible after that. So then we can do the surgery and do the CTRT, or in the beginning we can do the CTRT followed by surgery if it's possible.
Very often if you do add radiation, then surgical resection becomes, I know we do that with rectum, but with endometrium, we don't usually add radiation upfront, interval, for an interval.
That's why if we give the chemotherapy, even the 4-cycle carboplatin, it can be resectable easier later on. Then we can continue the treatment like that.
Dr. Kanika, would you?
I think as we have discussed last case also, the staging has to be done first. The PET CT, MR or something has been done.
So she had a CT thorax abdomen. She came with an MRI pelvis. We had done thorax abdomen pelvis.
And they were all clear, no lymphadenopathy.
No other. No, she had pelvic lymph nodes, no para-aortic.
The PET CT always help to see the lymphatic involvement in the para-aortic area, all those instead of like CT. I always seeing the PET always help than CT comparatively.
Okay. Yeah.
Normally they say that you have to see the epicenter of the tumor, even though your tumor may become an.
So it was, ma'am, it was an endometrial because if you look at this lesion, the whole endometrium is involved. So I'll.
Sometimes you have only a cervical mass and then you have this picture of.
The endometrium was involved, clearly involved. So it kind of concluded. So.
Can I make a small comment about
yes,
the imaging? I mean, we follow the same policy as you do. We don't do PET scan because none of the studies have actually shown any advantage of PET scan over and above a properly done CT scan. And we have a very high false positive PET scan results in India. We are endemic country for tuberculosis, and tuberculosis is very often picked up as a false signal on PET scan. So I would stick to a CT scan. And if there are nodes are enlarged, of course we can biopsy it, do a laparoscopic dissection, and do the staging first. Once you have done the staging, then of course, if there is extra abdominal disease, there will not be a role of surgery.
So in the sense like she had come with obvious lower 1/3 vaginal involvement, urethral involvement. So she came to us in August. In June, the trial results of this NRGGY018 along with Ruby trial were published. So she came soon after the aftermath, and she had Pembro along with carboplatin paclitaxel. And from this, after 4 cycles, she responded well. And this is after 6 cycles because she said after Pembro, she had severe financial toxicity, could not continue it, and she had no residual disease, even on the pathology specimen. So if finances permit, please add Pembro. I'll hand over to Neha.
Thank you so much. I have less than 10 minutes, and I have 2 cases. So these are both multiple classifiers. So I hope I can do justice. So this was a 64-year-old lady who presented with postmenopausal bleeding and a large endometrial lesion, which was also involving the endocervix. The biopsy was done outside. That showed grade 2 endometrioid adeno-CA. Molecular testing was not done on the pre-op biopsy. Staging laparotomy with a type 2 radical lymph node dissection omentectomy was done. So this is the histopathology. It showed grade 2 endometrioid adenocarcinoma, more than 50% myometrial invasion, no LVSI. And all the lymph nodes were free. On immunohistochemistry, ER was positive, P53 was mutated, and there was loss of nuclear expression of MLH1 and PMS2. So, Dr. Kanika, what would be your further management? This is a multiple classifier. Yeah.
Multiple classifier, and as MLH1, we will take it as a boss. Either P53 or POL. So POL is positive. Have we done POL in this case?
So yes, in this case, POLI was not done. Patient was advised POLI, but because this was a stage 2 disease with involvement of cervical stroma, no LVSI. So our radiation oncologist and tumor board was of the opinion that in any case, she will require RT because as of now, we don't have any prospective trials to show to de-escalate the treatment. So this is an older case. This is a, so that is what. So, ma'am, there is a retrospective analysis of POL-E cases. It is not a prospective trial where it has shown that POL-E is the leader mutation, but it is a retrospective trial. Considering that this is stage 2, grade 2, and the radiation oncologist was of the opinion that she, in any case, will require RT. Our dilemma. So so this was earlier on. This was a case in 2020 where we were not too well versed of how to handle multiple classifiers. We are now more wise. So P53 was mutated, and there was loss of nuclear expression of MLH1 and PMS2. So it was MMR deficient and P53 mutated.
But I think as nodes are negative, brachytherapy should be good enough. You don't need external radiotherapy in her case.
Okay, so now the dilemma was this. So in the ESMO-ESGO guideline, if we were to consider this stage 2 as and MMR deficient, disregarding the P53 mutation, this would come as high intermediate. And stage 2, still the POTEC 4A trial still says that in stage 2, EBRT should be given. We have already done a type 2 radical, so if we have to give radiation, I think it should be EBRT. The other dilemma was, should we consider P53? Now we know we are wiser, but at that point of time, P53 mutation in an MMR deficient stage 2 cancer fumbled us. What should we do? If we considered it as high, considering that it was P53 abnormal, this would come in high risk. So there was a dilemma whether we should add chemotherapy or not. Because obviously the treatment would change. If it was a high intermediate risk, she would get EBRT. If, on the other hand, due to P53 abnormality, we would consider it under high risk, then she would also require concurrent and systemic adjuvant chemotherapy. So patient was actually, this was in 2020, a patient was actually started on systemic chemotherapy with the plan of giving radiation thereafter. However, she had a spontaneous jejunal perforation after third cycle of chemotherapy, which required 2 surgeries, and finally a stoma reversal after 3 months, due to which she could not receive RT. So this is the paper which says multiple classifier. If there is a multiple classifier, if on a tissue specimen you have P53 abnormality along with POLE or MMR deficient or all three, P53 is not the driver mutation, it is the passenger mutation, and all of these cases, when it is an MMR deficient P53 abnormal case, it would behave more like MMR, and if it was a POLE mutated P53 abnormal case, then it would behave more like POLE. So these are basically the figures where it shows P53 mutation. So the D column which you see is the subclonal P53 expression, and this is what is common in these cases. Wherever we have multiple classifiers, almost 60% of them may have a subclonal P53 presentation, and this should actually point us to the fact that this can be a multiple classifier and this may not be a driver mutation. So about 10 minutes after the surgery, she presented with a small growth in the lower 1/3 of the vagina, not in the upper vault, not in the upper 2/3, in the lower third of the vagina near the introitus. PET CT, there was no distant spread. The biopsy was done. This was mismatch repair deficient endometrioid carcinoma, ER positive, P53 wild. So that's exactly what I mean by subclonal, because it is subclonal and these are heterogenic tumors, it can come as P53 mutated and some tissue can come as P53 wild, which is why P53 is not the driver mutation, it is the MMR deficiency. So going back, I think EBRT would probably have been enough. Chemotherapy with jejunal perforation. She's received 3 cycles of chemo, did not receive RT as was planned earlier, has had 3 surgeries for intestinal perforation, and now has presented with a small growth at introitus. PET CT is normal.
So of course we'll have to do a biopsy,
Yeah.
Confirm that if there is any, whether it's a recurrence or not.
Yes, we've done that.
And if the biopsy confirms there's a recurrence, then we have to see if it's surgically resectable, first of all. And secondly, if it is not resectable, then So how many months later?
10
how
months.
10 months, okay. So the option of repeating radiotherapy is not there anymore. If we can resect it surgically. Oh, sorry.
She's not received RT.
Then in that case, of course, okay. So if it's radiotherapy naive, then of course, yeah, radiotherapy, maybe I'm confused on
Okay.
that. Yeah, then of course, radiotherapy is a good
Any
option.
other opinion, Dr. Bhalla?
If it is interstitial, possible, we can do that, and that will be a better option. Or otherwise, the external plus, vaginal brachytherapy.
Okay. So because she's had multiple surgeries, she had lost 10 kgs of weight in this period. Our tumor board decided she was not fit for EBRD, and it was excised, followed by vaginal brachytherapy, and now it's been 4 or 5 months and she's disease-free at this moment. That was our decision. But yes, this is subject to, yes, correct. So the second case, this is a 57-year-old woman, CA endometrium, on initial biopsy, grade 1 endometrioid adenocarcinoma. Surgery was done. This was the final histopathology. Grade 1 endometrioid carcinoma, more than 50% myometrial invasion, no LVSI, all lymph nodes are free. On immunohistochemistry, ER was strongly positive, PR strongly positive, P53 mutated, and no loss of nuclear expression of mismatch repair proteins. Dr. Dave, what would be your further management?
Can you go back to this?
Yes, please.
1B grade
1B grade 1.
1B grade 1. Yeah, P53. Yeah. Yeah. So definitely she required adjuvant treatment.
Dr. Kanika or Dr. Bhombek, anything else would you want to see in this patient before advising treatment?
To check for pole mutation?
Correct. Yes. So we did do a polling testing by PCR and there was no mutation found. Now, anyone, Dr. Dave, Dr. Kanika, what would be your plan of action?
I think I like to just keep her under observation as she's grade 1 only, although P53 positive. There are no guidelines as such that you need to...
But it is 1B.
1B, we can give the BBT. We can give the BBT even the old guideline and new guideline P53 abnormal, so we can give the BBT.
I think breakish.
Yes. So,
1B it is.
correct. So now, because P53 was mutated and MMR, there was no loss of MMR proteins, poly was normal. According to the ESMO guidelines, this still fell in the high risk, but the patient refused chemotherapy because as of now, we don't have any prospective data. So she received vaginal brachytherapy and is currently on letrozole. Thank you. So ma'am, that's what. So we do have retrospective data of de-escalation. So this is the retrospective data where they have shown that even in high-grade cancers, if it was a poly-mutated cancer, if you do not give any adjuvant treatment, they found that the survival-free and the recurrence was very less and there was good survival. But this is all retrospective data. Till the time we get prospective data, we cannot incorporate it, and that is the dilemma.
So the other side of this is that you require a lot of courage, that if it is grade 3 tumor and poly-mutated, yet you don't give adjuvant therapy.
So that's why our tumor board comes into play, and
Madam,
that is why we have to
I think the answer
collectively.
is to sit and discuss with them. If they are educated, the literature is there to support you, and you take in...
You can't discuss this with anyone. You have to take the brunt yourself. Nobody, the tumor board will say, okay, what do you say? And nobody has gone through the amount you have gone through because it is your specialty. And as far as the patient is concerned, they will say, humko bas theek kar do. So you cannot, and our patients are not that educated. They're going through the nitty-gritty of it, and if the cancer comes back, it's your neck.
I think it's a matter of the guidelines to be followed and the protocols,
Yes.
which you understand, depends from institution to institution in this transitional phase where we are considering molecular. It depends actually based on your experience as well as the institutional guidelines which we require to follow, that how we are going to treat them when we have the evidence available. Dr. Bhalla, any comment from your
Yeah,
side?
actually, after these new guidelines, I don't know how many institutions will changing. It's gonna maybe slowly changing. So they start from, let's say, from TMH or AIMS, they start gonna changing. So all institutions maybe still change, taking the treatment from old guideline. But new guideline, we have to explain the patient, we're gonna do these testing, and some patient cannot afford it. every patient then stage 1 and 2, we have to do all this, testing, but affordability also issue. And the government setup and the private setup, they both are different. But changing guideline, I don't know, like 20% institution changing or not. I think Dr. Umesh is here, can give the comment on this, like these new guideline changing all over the India in that way, it going.
But my question is, if we don't incorporate the newer one and we keep on giving the older one, how we will come to know?
So
That whether
actually, we
it
would
is
conclude
helpful
that
or not.
there is no point doing molecular testing. That's the last point on the conclusion. If we don't let it change our practice, and we will only get evidence. So far, we have evidence based on non-randomized control trials, or we have retrospective evidence. And the role of molecular testing will be evident only if we let it guide our clinical practice, and it will be definitely the road ahead.
I have a question from Dr. Umesh. How in India, with the new guideline, how many institutions, everybody changing with that or still using the old one?
So my first comment is, I know you should not be so pessimistic, because we should always embrace new technology for sure. And surgeons have embraced new technology, going from open to lab to now robotic. Why not embrace molecular classification? Well, we are in the transition period. That is unfortunate. But then that doesn't mean that we just dump it. No, that's not progressive science. Number two, molecular markers is a big word. Everybody gets scared of molecular markers. But in reality, what are we doing? We are doing an immunohistochemistry. And 3 immunohistochemistries can help you decide at least 80% of the times. And I would put it 90, because poly mutation is seen in 5%, 7%. So those are clinical dilemmas where one can take a pragmatic approach, and if there is a treatment versus no treatment, so much cost versus treatment cost, diagnostic cost is this much, treatment cost is this much, would you like to decide? Leave it to patients. Sharing decision making is very important for this group of patients. But rest of the patients, I think it is very simple. The risk stratification, the molecular classification, and treatment which has evolved is excellent. Third point, entire world believes in POTEC data. Nobody can question, because every single pathology has been reviewed, central pathology review of all the patients in POTEC 1, POTEC 2, POTEC 3, POTEC 4 as well. So I don't think there is any comprehensive, robust data, clean data like POTEC studies. And we have to believe that data. And you see, they have gone progressive from not only doing molecular testing, but now they're also showing that what treatment can be tailored for those patients. And from their experience, we should now evolve further, trying to generate newer data with new molecular classification, newer, let's say, multiply classifiers, newer molecules, has to be implemented in these patients, because please remember, endometrial cancer, on an average, the outcome is excellent across all stages. It is just that only 5–10% who don't do well because of the virtue of advanced disease or metastatic disease at presentation. Thank you.
Thank you so much, sir. Thank
All,
you so much, ma'am,
all
for
medical
presenting.
oncologists doing NGS for every patient, every solid tumor, or they're doing
And the last point is, I think Agoy can also vouch for this. We had recently Pan-Asian adaptation of the newer guidelines for molecular classification. In that we have mentioned, well, poly may not be possible in all of the patients, all the societies, but definitely MSI, P53, ER positive, L1 CAM is plus or minus, should be done for all endometrial cancer patients. And seriously.
Yeah, one query or a comment. Yeah, it is. See, we are talking. We are, I think, mixing up the staging and the guidelines. The staging has changed. We have not got new guidelines based on the staging. We are still following the risk stratification there. Now we have to align the new staging system to the same risk stratification. So there is no change in the guidelines as such. It doesn't change in the staging.
Yes, so I think that's true. In advanced stages, we are still giving, we are still focusing on the histopathological aspect. And in early stages, the de-escalation actually happens in the early stages where we can actually choose between what treatment to give. Thank you very much, and we would like to thank Fortis Cancer Summit, the organizers, and especially Dr. Rama Joshi for inviting us.
Thank you so much, ma'am, and we are really sorry for the time frame. Actually, it was very beautiful presentation and very interactive. It is being said the knowledge is the king of the education and the most secret of the secret, but we have a time frame. We are sorry for that. To proceed with our next session, we have a debate on a minimal access surgery in cervical cancer. We have one presenter in favor of it and another is no. So to begin with the session, I would like to invite our chairpersons on the stage. Dr. U.D. Bafna, sir, Consultant Department of Gynecology, Bhagwan Manveer Jain Hospital, Bangalore. Dr. Meena Singh, Consultant Department Gynecology, Tanveer Hospital, Hyderabad. Dr. Shweta Talhan, ma'am, Consultant Department Surgical Gynecology, Fortis Hospital, Mohali. Please, ma'am. To begin with our first session, in favor of the surgery, I would like to call Dr. Rohit Ranade, Consultant Department Gynecology, Bangalore.
Morning to all. I think this is a topic which has been quite extensively discussed. So at the outset, I thank Dr. Amma, Madam, and the Fortis Cancer Institute for this invitation. So I'll be talking about minimal access surgery, and Dr. Umesh has already said that we have to embrace technology. Technology is in the form of better surgical quality, either a laparoscopic surgery or a robotic surgery, and we see if that will benefit our patients. So in today's era, especially after the evidence, talking for minimal access surgery in cervical cancer is like climbing a steep mountain, but at the end we expect this, and for that I require the help of my judges. So whether I'll be able to debate this. Now, we know that cervical cancer is still second most common cancer in women in India. We see about 1 lakh cases. And for early cervical cancer, though Dr. Umesh may not agree, radical hysterectomy is still the standard of care and has excellent results. We know why we are also concerned about minimal access. One is all because of the benefits like less blood loss, better post-operative pain scores. Nobody wants to be in pain after surgery. All of this means that patients get discharged out of the hospital. They don't receive blood transfusions as well. Now, the initial safety technical feasibility was established by numerous case series, and you see that they're all investigators of repute which have established the safety of a laparoscopic assisted radical hysterectomy. Again, this is again a single institutional series from institutes of people who have some good repute in the GYN oncology faculty, which have established the feasibility and effectiveness of a laparoscopic radical hysterectomy as compared to an abdominal radical hysterectomy in terms of complication rates and oncological outcome. Now, this was one meta-analysis which looked at around a large number of around 1,600 cases of abdominal versus a laparoscopic were around 200 odd, and there was no difference in the intra-op complications. The abdominal route stayed longer time in the hospital, and there was no difference in the surgical site infection. This was one of a propensity matched study from Korea, which looked at around 260 odd cases, and the main aim was to look at 5-year recurrence-free survival and overall survival, and there was no difference in survival. So everybody felt that it's all the same. The data from the LAP2 trial had just come, and in endometrial cancer, minimal access surgery had become standard of care. The data from the colon trial had come, and minimal access was established as the standard of care. So everybody felt that you can offer it to our patients. This was another meta-analysis from China at a large number of 3,000 patients, lower complication rates in the laparoscopic arm, and there was no difference in the 5-year DFS. This is few data from the robotic, from the sector, mainly single institutional retrospective data, which supported the benefits of minimal access. This was another data from the SERDS group, which looked at around 250 odd robotic and open cases, all benefits of minimal access. They had a good median follow-up of nearly 40 months, and there was a comparable disease recurrence and survival. This is another meta-analysis which looked at around 12 studies comparing open versus lap versus a robotic radical hysterectomy, and there was no difference in the recurrence in these two groups. Now, this is the trial which probably changed everything. This is one of the trial which has been most dissected or most debated about when this was presented as a presentation in the 2018 SGO meeting and then subsequently a publication. So this is essentially a trial between minimal access surgery and open surgery, and you can see the survival rates are excellent in the open arm. Never has any historical cohorts given us such excellent survivals what open arm has given. And even the survival, if you look at it as compared to the minimal access, as compared to the historical data, they're not that bad in minimal access as well. We have historical survivals are around between somewhere around 85%. This survival is around 93%, which is also quite good. But because the open has favored so excellently well, it has come probably as an inferior survival. Again, you need to know that this was a trial comparing 85% of patients were laparoscopic arm. So it was essentially a trial between the laparoscopic surgery and open surgery. Robotic surgery has still not been tested in a randomized trial. Again, surgeons had to send 10 cases and 2 unedited videos. We all know what learning curve is. That's why probably the recurrences were only in 14 out of 33 centers and not in all the centers. So if you eliminate those 14 centers, it is as equal to the open surgical arm. Now, this is why the learning curve is something important. Now, radical hysterectomy is a very skillful procedure. All of us who have done it, we know, and to do it laparoscopically using a straight stick laparoscopy is technically challenging. You can do it, but you may not reproduce it all the times. That is why there is something associated with learning curve. It takes at least 18 cases for a surgeon to gain proficiency in a laparoscopic radical hysterectomy, and we still don't know, we know that your first case will not be as good as what your 20th case is. Again, so there is also a question of volumes. What was the volume in the centers that were part of the trial? If you're doing just one case in 6 months, it takes a longer time to pass your learning curve. The hospital volume is also plays and definitely plays a prognostic factor in early stage cervical cancer. I think you can say not pitfalls. At the end of the day, it's a randomized trial, but something about the LAC trial, there was no central pathology review. Pathological information is missing in some cases. There was no preoperative MRI, and again, it was not adequately powered to tell us about tumors which are less than 2 centimeters. Again, this is something which I have told. The survival outcomes are best ever in the open arm. Never have we seen such excellent survivals in historical data. And if you look at the pre-statistical analysis, what was written in the trial manuscript, they estimated a 4.5-year DFS of only 90% in the open arm. So the open arm has fared excellently well. Also, are the recurrences because of the technical aspects, such as the use of uterine manipulator, the use of an uncontrolled colpotomy, or the use of a CO2 gas, which can cause a centripetal metastasis because of the gas effect? Now, this is another, subsequently, a lot of investigators went and published their data. This was another data mainly from the United States, which looked at around 80% of patients underwent a robotic radical hysterectomy, and there was a significant high-cause mortality in the MIS arm as compared. Again, if you go into the details, there is no data on the cumulative survival of DFS available. Also, the investigators, when they were unable to confirm the accuracy of the clinical, pathological, and follow-up data, the adoption of MIS was very slow. So it probably suggests that the many surgeons who had performed robotic minimal access were not in the peak of their learning curve. So that was probably the reason why you had inferior survival in this year. This was another meta-analysis published in JAMA Oncology. This was mainly 15 studies, but most of them, except the LACC, are all observational studies, and MIS was associated with worse survival. This was another data, again from the United States, which was again the retrospective multi-institutional study. MIS has shown inferior DFS, but there was no difference in survival. So if you picked up those recurrences early, probably you would be able to salvage those patients. That is what it says. Now, because of the LACC, primarily because of the LACC, the NCCN and ESGO have released a guideline saying that minimal access surgery should not be offered to patients outside a clinical trial in tumors more than 2 centimeter. This was another paper from China which looked at specifically tumors less than 2 centimeter, a very, very good patient number of around 900 cases, and there was no difference in 5-year OS and DFS. Now, this was 3 papers from the Scandinavian countries, the Sweden, Denmark, and Netherlands. All of them have a excellent referral system. Most of the cervical cancer patients are operated only in those centers, and this was a Swedish quality register study. Treatment is centralized only to 7 centers, and only few GYN oncs perform robotic radical hysterectomy. And uterine manipulators were not used in this. Around 236 patients underwent open surgery and about 628 robotic. And if you look at 5-year DFS and a propensity matched DFS, there was no difference in between the curves. This is another trial, again, the study again from Netherlands, similar methodology, about 740 open radical hysterectomies versus 370 robotic radical hysterectomies. Again, no difference in the overall survival, no manipulators and protective
Rohit, I
colpotomy.
think
Yeah, I'll
the
just
time is
finish.
getting up.
Yeah. This was another so this is just one paper from trachelectomy, which has said that there was no difference in survival between the minimal access surgery and laparotomy. So when you have to do a trachelectomy, you can do it minimal access, but even when you have to do an open radical hysterectomy or a radical hysterectomy, you have to do it open. That's what is the inference. This was a Sukkar study which said that if you don't use a uterine manipulator and you do a protective colpotomy, there was no difference in the survival. And this is what we do, a protective colpotomy. So you can use a stapler and not expose the tumor to the pneumoperitoneum. Yeah, so just for the want of time, I'll skip this. This was the data from Tata. This is probably one of the largest data from India. This was a retrospective studies which said that there was no difference in the minimal access surgery and the open surgery. This was the memory study which again showed the same thing. 75% of cases were robotic. There was no difference in survival. And this is one trial which probably will change or looks to change the way we think. This says that probably whatever you are debating is probably may not be necessary for tumors which are less than 2 centimeter. But again, you need to know that there was 75% of patients underwent surgery by minimal access in this route. So there are 3 trials for which we still have to wait. There is only one randomized trial which has shown that minimal access surgery, essentially laparoscopic surgery, is inferior to open surgery. So this is the Chinese trial which compares robotic and minimal and open radical hysterectomy. The RACC trial which has completed recruitment and the results are expected, and the ROC trial which has recruited about 150 patients. So I thank you for a patient hearing, and thank you.
Next, I would like to invite Dr. Pallavi. Says,
Thank you so much, sir. I would like to invite Dr. Pallavi ma'am, Consultant Department Gynecology, Kidwai Memorial Hospital. She is going to talk against the minimal access surgery in cervical cancer.
Good morning, respected chairpersons and my dear colleagues. I think Rohit has done my job easy. He has quoted most of the studies. So, as you all know, this has been debating for over a thing. And over the years, gynae oncology has revolutionized with the invent of laparoscopic surgery. And this has been a topic of arguments for decades. However, as we all know that not all surgeons are comfortable doing this, and not all institutions are favorable to do this. We have the facilities to do these things, the minimally access. So till today, the gold standard is abdominal radical hysterectomy with pelvic node dissection. And as we all know, after the outcome of these trials, LAP2 and LSE trial, the gynae oncologists tried to exploit these results into cervical cancers after the endometrial outcomes were favorable for minimally invasive surgeries. But then there were many limitations with minimally invasive, like as Dr. Rohit has told, that it has a steep learning curve, and the team is very important in such cases. And selection of cases. Most important is the selection of cases. Not everybody can do a minimally invasive surgery, because the outcome of the quality of minimally invasive surgery is more important than whether you can do it, whether you should do it or not do it. So let's see if minimally invasive has any effect on the oncological outcomes. We're all bothered about the oncological outcomes, not whether you can do for 1 or 2 cases and say this should be the standard of care. So as he said rightly, that over the years it has been minimally invasive has been used, and it is shown that it is it was favorable or can be considered. But after 2018 with the LAC trial, the whole scenario changed. Following this publication, the safety of minimally invasive approach for radical for early cervical cancer was significantly challenged by many of the surgeons in many of the centers. So all of you are well aware with the LAC trial. And this was the largest randomized multicentric study. So we don't have any other randomized trial to say that minimally invasive surgery can be used in cervical cancer. So this study showed that there were higher rates of loco-regional recurrence, as well as there were poor survival, overall survival, and disease-free survival. So you can see here that abdominal radical hysterectomy had a better loco-regional control than when compared to MIS, and the overall survival also was better with open radical hysterectomy. So when you see the final results, whether it is disease-free survival or loco-regional recurrence or the risk of death after the surgery, you can see open surgery had a better prognosis or significant p-values when compared to minimally invasive. So finally, the study was concluded that there was risk of recurrence and death with minimally invasive when compared to the open surgeries when compared to minimally invasive surgeries. There were several other studies which looked into these things. There were either multicentric study or a cohort study, which most of the studies showed that they were either it was inferior with the disease-free survival or the overall survival. So I'll just run fast through these studies because some of the studies were quoted by Dr. Rohit as well. So most of these studies showed that loco-regional recurrence was higher with MIS, or disease-free survival was higher with MIS when compared to the open surgeries. So there was a meta-analysis and systemic review of about 15 cohort studies, which Rohit had mentioned. And this also, the pooled conclusion in this was that hazard of death in the minimally invasive was, and the recurrence was almost 70% higher when compared to the open surgeries. So they had looked into the thing where the growth of the cervical growth was less than 2 centimeters also. In these also, they showed that there was some amount of inferior results when compared to disease-free survival. So all we're talking, okay, the technique is okay, it is only the other techniques what we are using, like the uterine manipulators, or the way you remove the specimen, or you cover the vaginal cuff and then remove, so the results will be better with that. Then you look into, and many of the studies have shown that uterine manipulators did not make much difference. But when it comes to carbon dioxide pneumoperitoneum, studies have shown that the cell colony formation increased significantly after stimulation of carbon dioxide, and acidosis in the intra-abdominal environment suppresses the peritoneal immune system, which causes damage to the peritoneum, making the additions and implantations of the tumor cells significantly higher, and mitosis activity promoting the growth. So coming to, after all this thing, the recommendations by various societies also changed. Coming to these recommendations, you know that NCCN guidelines still says that the standard on recommendation for cervical cancer is still the open radical hysterectomy. And the FIGO statement on this minimally invasive cervical cancer also says that the gold standard is again open surgeries in early cervical cancers. And the woman should be carefully counseled in case you are deciding to do minimally invasive surgeries in tumor less than 2 centimeters. And even the British Gynecological Society also says counseling and open surgery is still the standard of care. The take-home message from these studies is that conducted by for cervical cancer is it shows that MIS is associated with high risk of recurrence and poorer DFS and overall survival when compared to open surgeries. The NCCN and as well as the ESGO states that open radical hysterectomy is a standard of care, and more studies are needed to ensure that safety of cervical minimally invasive in case of cervical cancer. So we should not go overboard with exotic or complex ways of paint. Stick to simple solution unless there is a good reason to do otherwise. It's like when you have a new hammer, you always tend to see every problem as a nail and you want to use it. But you should use it very cautiously, and and we have to wait for this RACC trial to say whether which is better. So I think, thank you for your patience here.
Thank you, Pallavi, for a very nice presentation. Do we have time for rebuttal? Yes. Yeah, 2 minutes. I think rebuttal. You want to give a rebuttal? Something? I think otherwise.
Yeah. So there is a randomized trial which is against minimal access surgery in cervical cancer. But whatever the guidelines are there, they are all based on one randomized trial. Rest of all studies are observational. There are a lot of other observational studies also which are in favor of minimal access surgery. So, but if you have to take randomized evidence, yes, minimal access surgery, especially for tumors more than 2 centimeters, should not be offered outside a trial setting. And whenever, even if you are doing for 2 centimeters, you should do protective measures like a protective colpotomy, avoid a uterine manipulator, and whatever other factors are there which might have which might be the reason for recurrence. We still don't know what is the reason for recurrence. And again, we'll have to wait for the results of the trial, the RACC and the ROC trial, to finally, whether it will be the final nail in the coffin.
Yeah, exactly. We should still wait for the trial to say which is better, because we don't know what is the recurrence, what are the reasons for exact recurrence. So each one is telling, if I'm a laparoscopic surgeon, I want to say laparoscopy is better. And my results, I try to put it as it has to come as better. But if you're an open surgeon, you want to prove yourself and say no open surgeries. And you know, open surgeries are time-tested surgery. It's been done for ages. And many of the stalwarts have done, and you're more used to your open surgeries than this. You don't need a teamwork to do open surgery. So we'll have to wait for the results to see exactly, like if all the fallacies of, if you think there is a lot of fallacies in LAC trial, the RACC trial should, if it has corrected everything, we should see what will be the results.
Yeah, good. I think all the data which is available after the publication of LAC trial, after 2018, I think most of the trials, most of the studies and publications support open surgery. Okay, of course there are some studies which support minimally invasive surgery, and irrespective of the tumor size, 2 centimeter, more than 2 centimeter, I think there are results for and results against. I think what is most important is, like you said, that colpotomy. I think the most important risk factor is that tumor spillage can occur during colpotomy. Intracorporeal colpotomy is the most important risk factor. If you can prevent that by any method, like he is using stapler, which is, I think, very not possible to use in all the circumstances.
Cost again.
So minimally invasive surgery right now, I think the evidence is in favor of open surgery unless you are doing a protective colpotomy and prevent spillage.
So I think the common things that both of the senior speakers have said this. One is it all depends on the skill of surgeon also. So radical is such a complex procedure that the learning curve to do it laparoscopically or even robotically will take time. And then the second thing, the SHAPE trial and other trials have shown that probably in early cancer, the extent of radicality is not the deciding factor for survival. And as Sir said, as soon as they colpotomy, the cervix is exposed to peritoneum, and the unexpected and the sad peritoneal mets that we seen in the LACC trial and the other studies after that were against the use of minimal access. So that's why we don't see the peritoneal mets in endometrium. It's protected by a covering. There is serosa, myometrium, but it's not the case with cervix probably.
Yeah, after listening to for and against it because of this 2018 LAC trial, I think we should keep the patient centered. Of course, we have to progress like anything. Always it is in a trial process, and with research it will come, and like doctor said, like this ROC trial and RCC is still awaiting. But I think in those centers where volume is adequate, where learning curve, where surgery expertise is there, I think we should do minimum surgery, because it has been proved that minimum surgery, there's less blood loss and patients are more comfortable. So I think we should go for it.
I think number of cervical cancer which are coming for surgery is going to become less and less. So it's going to become very difficult to conduct this kind of trials. Okay, thank you. Thank you for the speakers. And thank you. Thank you.
Thank you so much, sir. Thank you so much, ma'am, for being part of it. So proceeding to our next session, I would like to call on chair Dr. Parisima Dave, ma'am, Professor HOD of Department Gynecological Oncology. Dr. Usha Bislali, ma'am, Professor in Obstetric and Gynecology. Dr. Sabera Khatun, ma'am, Professor in Gynecological Oncology. Please, ma'am, on the chair. request ma'am to call upon stage our next speaker, Dr. Dr. Arunaya Roy, for his next topic, video endoscopic inguinal lymphadenectomy in valvular cancer.
Good morning, respected chairpersons, respected senior dear friends. First of all, I will thank the organizing committee for giving me this invite and the opportunity. I will thank Rama ma'am. So my job here today is not a mason with a hammer trying to nail everything. So I am going to define that, yes, there is a specific role for it. Just, I don't have a hammer and trying to nail everything. And this procedure, my data, personal data is rare. It is up in IGJC for publication as a video abstract because vulva cases are rare and the patients are mostly from the lower strata and majority of the government schemes still do not cover robotic surgery. So in my state, it still doesn't matter. So it's really difficult to get patients who can afford these surgeries because they come from a different strata of the society. So my initial data is of 15 cases, which has not gone up to 20 cases. So, and pardon me for having to zip 90 to 100 minutes video into 6 minutes. As Madam said, you must complete in time. So why are we thinking? So every surgeon that have done, open groin dissections had faced this in a particular phase of their life. And many of us have, ended up asking help from our plastic surgeon colleagues. And your radiation oncologist is not happy, if the patient requires a radiation and the groin looks like this. So that is the main reason why we shifted to minimally invasive groin node dissection. Started with laparoscopy, then it went to robotic. It was conventional robotic, then we moved to veil. So what are the advantages of video endoscopic groin node dissection? Reduced incidence of wound adhesions, flap necrosis, wound infection, resurgery. Very simple. It is mainly skin benefits that we derive. However, complications like lymphoria, lymphocyst, pedaledema are universal. Though in my small experience, what I found is the removal of drain and the incidence of seroma is less when I'm doing with robotic. The majority of data that is available in India from gynecology, there are very few people who are doing it. There are two distinguished guests amongst us who has published, Yogesh sir and Madam from Rupinder Madam. They have published it. So, but the majority of the data comes from the urosurgeons, and the leader in this field is Dr. S.P. Nayak. You can find a lot of literature from him about veil and L-veil. So this is the small video about it. I have to compress it to, 6 minutes. This is the conventional camera port position where you triangulate it, and this is the lateral port position. And it has distinct advantages. Why lateral veil? Why not the conventional? Better ergonomic, more range of camera movement, lesser collision of arms, and it's easier to identify and preserve the stiffness now. This is the surface marking, and you see the tangential line to the triangle. That is where the 3 ports are placed. So first you create the optical port. That's by a finger, like you do extraperitoneal lymph node dissection, same as that. You do a finger dissection and go up to the fascia lata of the thigh. You can see that white fascia there over the sartorius muscle. Then you extend your finger dissection with a very Indianized bulb. That's a NG tube with the cut middle finger of a 7-size gloves. And then you infuse saline into it, normal saline. It can go up to 150 ml, and then your assistant have to guide it to and keep it in the area where you want the dissection to be. So deflate it, reposition it, inflate it, and create the plane. That is the most important step in this surgery. If you mess up with that plane, it will open up and do the surgery. So you create that plane, put in the port. This surgery is from when I was using the SI, so it's a 12 mm port. And then there are 2 lateral ports on those 2 markings, and this is how it looks after final docking. It's on the lateral side of the thigh, and the lower port, 5 is the assistant port. Once you are inside, you are bang on the sartorius muscle, and the first step you do is picking up the fat containing the nodes from the sartorius, and you move from lateral sartorius muscle to the medial margin, which is the adductor longus. So on this movement, on the way from when you are going from sartorius to adductor longus, the first structure that you will identify on the roof is the great saphenous vein. So that's why it becomes very easier. So to preserve this vein, and if you preserve this vein, the incidence of lymphedema is less. So you go on continuing on dissecting it, and on deep dissection you will find the femoral artery, you can see it there, and you continue in this plane. This is a fantastic, nice plane. So first you lift up all the nodes. Remember, this surgery has its own learning curve. By the definition of the robotic company, it's a TR300 procedure. So you have to, it's equally, as important as para-aortic dissection. So that's the apex, that's the femoral artery of the triangle. Once you have defined the apex between the two muscles, then you dissect and drop the saphenous vein and follow the saphenous vein to the siphonofemoral junction. That's the easiest way to identify the the femoral vein without injuring it. So you go down, follow it, and you'll find some small veins joining the saphenous vein at near the junction. Carefully clip and ligate and cut them and dissect, and you find the siphonofemoral T junction. That is the junction, and you identify the femoral vein. Once that is done, then you dissect cranially towards the base of the triangle, which is the inguinal ligament. And by definition, for oncological clearance, you have to overshoot the inguinal ligament by another 1.5 to 2 centimeter up to the external oblique aponeurosis, and get the entire fatty tissue, including the nodes, removed from there. So once you have defined that up to the external oblique aponeurosis, you will see it in a moment. You see it there, that's the external oblique. You stop. That's the upper margin of your dissection. So this is done. You have lifted it up entirely from the floor. Now you drill it down. So then it's the drop method. You drop the entire fatty tissue down with only one word of caution. Do it below the scarpa's fascia. That will preserve. Believe me, it's much easier to identify this scarpa's fascia on the robot or any minimal invasive procedure. Preserve the scarpa's fascia. Take the entire fatty tissue with the nodes down from there, and your surgery is done. So you finish it there and try to clip and remove all the nodes. Put it in a bag. Before you take out the specimen, do not forget to put in the drain. I prefer to put in a flat drain, which is the JP drain, Jackson Pratt drain, and remove it, and the end results are beautiful. So that is the drain coming in through one of the assistant ports. You place the drain inside properly and take out the specimen by increasing one of the ports a bit. And the studies have till now have claimed that's the end result of the surgery. On day one, that is a specimen which included around 18 nodes. That is the patient on postoperative day 7, on which the drain was removed. And that is the end result at 3 weeks. So this is how beautiful the groin looks, and your radiation oncologist will be very happy if they get a groin such like this to radiate. And all the data till now which exists for minimally invasive inguinal lymph node dissection have pronounced that it is oncologically safe, and there is equal amount of nodal yield if you are doing it minimally invasive. You are not interfering with the oncological principles of the surgery. This is the data I have till date. There are 5 more patients that have been added. It was from 2021 when I was working in Tata Medical Center till 2023. There are 15 patients with SCC vulva. Mean time was about 100 minutes. Minimal blood loss, very, very minimal blood loss, and no conversions to open. Mean time for drain removal was about 7 days, and one of the women developed bilateral seroma. There were 2 patients who were diagnosed with metastatic nodes and received radiation. So to conclude, lateral veil is a feasible procedure and can be used as an alternative to conventional well, where you triangulate it. There is more chances of instrument collision, and there you end up directly onto the saphenous vein. So identification of the saphenous vein is easier with lateral well. That's all about it. Thank you for a patient hearing. Oh, just in time.
Yeah, excellent presentation, and of course, well before time. And as you said, it even for, good robotic surgeon, it requires a learning curve.
It has its own learning curve.
Even for the good robotic surgeons. And rightly, Dr. Pallavi said it depends on, who has the gun. So you are a master of it. It's not everyone's cup of tea. So thank you very much for the excellent presentation.
Thank you, ma'am. Yes, yes. Sir, please. Sir? Yes, sir. Yes, sir. Yes, sir. The patient tolerates it much better than 3 incisions on the groin, 1 on the vulva and 2 on the groin. Same day, sir. For one side, ma'am. It requires 1.5 hours approximately. When I started, it was about 3 hours. It has now come down to about 1.5 hours now.
Yeah, I have a question. So the question is, what are your exclusion criteria for this? And second question is, do you combine sentinel and lymph node, or you're doing for all the cases, or you're doing it only for positive sentinel lymph node cases?
No, sir. Till now, I'm not practicing sentinel lymph node in vulval malignancy. One, this is for early cases. If the exclusion criteria is if the woman has evident involved lymph nodes on the scan, preoperative scan, definitely I will do an open surgery than this, because there will be more chance of spillage if I tamper with the nodes inside, and there can be local recurrences. Ma'am, expert opinion. Ashmadi is also wanting to ask.
No, I just missed out on your video, but I'm sure it must have been beautiful. I just wanted to ask one question, that if you get a positive lymph node.
Yes, ma'am. Two cases came out to be positive.
So what is your principle? Do you redo opening guinal lymphadenectomy, because that is what is the guideline? Or do you just subject the patient to...
Ma'am, it is oncologically the same margins. This entire nodal chunk has been taken out.
Yeah, I know, but then, if you read...
Then we send them for radiation, ma'am.
For radiation.
Yes.
Thank you. I think time is short, so...
Ma'am, there was a question, I believe.
Dr. Excellent presentation.
Okay.
Can we know what was the learning curve? Roughly how many procedures after which you were very confidently doing
yes,
this? What's the new technique?
I will say it took me at least 10 cases, at least 10, but I believe there is no defined learning curve because it's not a very common procedure done. But I believe to confidently do this, will require to have at least 15 cases. Those are hard to come by.
Major adverse events that you had in the learning curve?
None. I had no conversions. And believe me, you need, for these procedures to start in your career, you need a mentor. And my mentor was a neurosurgeon. I have no shame in saying that, but he was excellent. And he trained me in starting this because it was new for me. He had converted from lab to robotic recently, and he was doing very good. So you need a mentor. You may have a neurosurgeon as your mentor because their numbers are more. Penile cancer, their numbers are more. There is one question. Yes, that's the open surgery is the mother of all surgery. You have to be confident in open surgery.
So I think, Arunava, it was an excellent presentation, and
Thank
I
you,
think
ma'am.
you have already addressed the issue. You can definitely look into a smaller lesions where you don't have to go for the complete node dissection. You can even come up with that of the sentinel node.
Absolutely.
So
I'm
actually,
not
one
yet
can
doing
really
sentinel node.
look into that. It's excellent.
Thank you.
So Arnav, nice video. I have just 2 questions.
Yes, ma'am.
You see, for less than 4 centimeter tumors, unifocal, right? Then
Lateral.
you should do lateral. You should do
Sentinel
sentinel
node.
nodes.
I
Right?
understand, yeah.
So this will not replace the benefit of sentinel
Sentinel
node.
node, yes.
Right? So then this is a replacement or an alternative for a tumor which is more than 4 centimeter, which is SCC.
And you declare,
Multifocal,
yes,
perhaps,
and you
right?
declare.
So I'm just kind of, it's a very nice, technique. Of course, I can see the principle like a Centicom study, morbidity reduction and all. But after LAC, I kind of really think that SCC is a very bad tumor for dissemination with the gas. And I am just kind of not, if you do under a research setting, trial setting,
Yeah.
if you've done 20, but if you done a randomized phase to 10 and 10, because I'm just kind of thinking that, like with a bigger tumor, when you are likely to have more lymphovascular permeation, embolization, then from the lateral you are putting gas. And does it not actually cause any change in the fields? And yeah, I'm just kind of asking because I think these are the type of questions you perhaps need to address prospectively.
Absolutely.
Possibly do a randomized study and think about all these as well because, for smaller tumors, you will be doing sentinel. It's for the larger tumors whether you can do this technique.
Thank you very much for your comments. Yeah, that really inspires us for a randomized trial. So it's open house now. There are ACOI members here. So people who are doing it, we can start it in India. Yes. Yeah, I understand. Yeah. Inguinal nodes. But to answer your first point about LAC, let us wait for RAC and see whether actually carbon dioxide dissemination, it really...
I want to say one thing.
Yes, ma'am.
Aruna,
I should leave the stage.
yeah, one quick question. What was the morbidity of your open groin when you were doing? I mean, I don't see
madam,
the way you showed some, extraordinary pictures in the starting. What's the morbidity of your groin wound?
Ma'am, the data, if I combine, in my experience, were around 15 to 20%. Yes, because there, ma'am, it's not only that open wound, it's morbidity. It starts from, seroma aspiration to drain.
To do with, it has something to do with number of limbs.
Number of, yes.
So ours, the morbidity of groin wound per se is not that high. Yeah, I don't know, maybe. Yeah, absolutely.
Thank you.
Just a follow-up to Dr. Asima's comment. Here we are having a very defined surgical field which is enclosed, and the dissemination microscopy would happen if it has to happen in that field. And all positive nodes you are radiating. So how much, I don't know whether recurrence would be more in these cases. That's all.
Thank you. Thank you. Yes, ma'am.
As per, just a fallout of what Asima is saying, I too have done a few of these whales. So, the surgical field is very restricted. The gas does not go there. If the gas were to go into the mons and this and all that, and also again, then it can also permeate down to the vulva, all these spaces and all of it can swell up. You will never get that small area which you need, which is inflated with gas, to be able to do your dissection. It doesn't go.
I think Ashima will do the
and we do it at a lesser
that trial and will give the answer of all the questions. Ashima will do the trial and will give the answer of all the questions.
Thank you,
we
ma'am.
should stop here.
Thank you so much, sir. Like your surgery, your presentation was also very clean and fine. So next speaker we have is, I don't need any introduction for her, Dr. Rama Joshi ma'am. The topic of presentation is sentinel node mapping and pelvic lymphadenectomy in CA endometrium.
Good morning, all. So actually, it's a small presentation, and basically I just took it from the live workshop which we did actually under the AGRS. And this was a patient where stage 1A disease, grade 2 endometrioid carcinoma, endometrium. And this is where I just straight away go to the presentation. So basically, this is what I was describing about the case, and I think there is no volume in it. I just can't see that. Anyway, so that's how the plan was to go for the sentinel lymph node mapping, and we are doing it in general in our as a matter of the study as well. And this was a uterus confined disease, as you could see, and that's how, after actually looking at whether there was anything around and all that, there was no adnexal mass or anything, everything was clean. Using the ICG dye, we used ICG dye, and here you can see that we are opening the peritoneum. The only addition, if I modified this, was slightly the change in the speed by 1.5. And what we could see that how we could identify these sentinel nodes in this. And before going to that, we are actually dissecting the retroperitoneum by opening the spaces and actually managing to identify the lymphatics. And it's important to identify the anatomy, what I believe in. And once we follow the lymphatics, then we can definitely know where the sentinel node is. It requires the complete, actually, delineation of the nearby anatomy once it is in the obturator fossa, as was in this case. So it's important to identify the nerve so that we are very clear where to go and how to go. And it's important that not to actually cut the lymphatics before we dissect the node totally, so that we are sure that this is the way the sentinel lymph node can be dissected in the proper way. So that's how you can see the dissection within the obturator fossa. I'm just keeping the lymphatic going to the node very clear. Another important point which I feel is that we should not be cutting onto the node. Always have the nearby tissues and cut those nodes so that we are not even holding the node using the bipolar. And it is the surrounding tissue which we are using so that actually we can submit the entire node for the assessment. That's how the sentinel node is being dissected. This is just a part of the live workshop, and there is no editing in it. And we save it, we just put it into the bag, we clip it. Right and left side we mark with 1 and 2 clips. This is what is the retroperitoneum, which you can see, where the ureter is being dissected, and this is what is the bifurcation of the iliac. And we started with that of the pelvic nodes in this, because actually as a part of our own study also, I think we have done 110 cases, and then we came rather to the conclusion that one case which we missed of the sentinel node, that was in our initial 10 cases, and then we proposed basically the learning curve for doing the sentinel lymph node as that minimum of the 10 cases. Then we should really start counting, and we can know that what we are doing in the sentinel node so far as the mapping is concerned and the accuracy, we can really take up the sentinel node. Here you can see that there is a dissection of the external iliac nodes. The genitofemoral nerves can be delineated, and what you can see is the psoas. And that's how we are approaching to that of the distal limit. And it's very easy. So when you are using the robotic as a platform, you have the very good, actually, the you can say the cautery system, as well as the kind of the dexterity. And what is important is your camera, which really takes you very nicely to whichever the part you feel like. So you can see the external iliac vessels, and we can delineate all the nerves. And coming to the distal boundary of it, that is the deep circumflex iliac vein that's coming right into the field. You can very well see it. Again, the similar principle, what is important is we should not sever any of the nodes. We do not know whether they have the microscopic metastasis or not, and we can remove them completely. So this is where the distal limit of the pelvic lymph node dissection, and that's how we are coming on to, I think, dissecting from the deep circumflex iliac vein, going on to the iliac vein, and the things become actually easy and complete dissection. Definitely you can very well understand. And that's how, coming onto the medial side, it depends. You can even go for the lateral approach as well as the medial approach of entering into the obturator fossa. And here, I think none of the assistant is in the field, but once I will require the assistance, you will see the assistant is coming from the assistant port and is going to give the traction, especially that will really give comparatively a traction, and the dissection can become very, very easy. But here you can see the dissection of the nodes from the external iliac, interiliac, and that's how we are completing the node dissection. And you'll be able to see that since we have already taken out the sentinel node from that of the obturator fossa, whatever the nodes remaining, that will be taken out, and I think we'll be able to complete the lymph node dissection. And it is important to actually, what I feel, to have the boundaries made very clearly dissected right in the beginning so that we know all the anatomy, and there is no actually any kind of the problem which we usually minimize, and it is the proper visibility of that area that's very, very important, and the placement of the ports, the instruments, and also the assistant, which can, here you can see the assistant, and Rashmi is actually assisting me here. And after doing all the external iliac and this is where the node dissection, and these are the medial nodes, which were the medial obturator nodes, including the gland of Cloquet, which is important, and that will complete the pelvic lymph node dissection. So we have saved the sentinel node separately, and we are giving the pelvic nodes as well. And this was also the part of our study, and that's how we can see the pelvic vein which is coming in between. You can see the lateral pelvic wall, which is very clear, and one can completely dissect the lymphofatty, lymphovascular, you can say, fibrous tissues surrounding the vessels, and that's how we can complete the pelvic lymph node dissection by the robot. I think this makes the dissection very easy. You can see that that's how we can take very less time, as well as precisely we can remove all the lymphatic tissues. With this, we complete the pelvic lymph node dissection. And just to show you the anatomy, you can very well see now, this is what is the obturator fossa, and this is the deep circumflex iliac vein, and these are the genitofemoral nerves and psoas muscle. This actually, the lateral approach can also be used. It depends the way you are more trained and you follow. You can see the obturator nerve, artery, and then the vein. So sometimes the node may be there very much deep. We can dissect these and we can take the nodes out. And this is how the complete, after the anatomy, after the complete lymph node dissection. With this, I thank you all, and this is what is the final anatomy after completing the dissection. Thank you. Yeah, I like it the most. The moment you have any bleeding, you just use the gauze piece. Don't go for any suction. You don't require suction at all. Yeah. But I love to use Maryland.
Dr. Raman,
I absolutely agree with you. I was using bipolar initially, but I think what I feel fineness of the dissection can be done by using the Maryland. This is the way I think I shifted to the Maryland.
Dr. Rama, excellent and very clean surgical video. I congratulate you for that.
Thank you so much. Thank you. Yeah.
Ma'am, excellent surgical demonstration, ma'am. Wonderful video. I know there are a lot of robotic stalwarts in the hall here. Any tips that you could give, especially to prevent, now that you're doing paralytic lymphadenectomy, to prevent a vascular injury? Or in such a case, in a robotic surgery, if you really happen to encounter?
See, this is a patient where it is endometrioid grade 2. This falls into the low intermediate risk group, and we go for only the sentinel node. But
even
otherwise,
with, pelvic lymphadenectomy as well, any major vascular
no,
injury?
this pelvic lymphadenectomy, basically, I had taken up as a part of the, you can say, the demonstration.
Tips to prevent.
Okay, I didn't hear you then.
Yeah,
I think
tips
what
to
you were
prevent
asking?
tips to prevent vascular injuries.
Of course, definitely. I just, the way you are doing it in open, kindly follow those actually steps. Using the minimal access doesn't change any kind of the surgical principles. What is important is this. It is the meticulous use of the cautery. And what I suggest is that you have to actually dissect the lymphatic tissue and cut it, whatever the fibers you are able to see, which are attached, if you just buzz them, definitely the dissection keeps on going. So you don't have to use the cautery very close to the vessel. It's very, very important. And use the cautery after the dissecting the tissue away from the vessel. This is what is my tip.
My question, is it for the presentation, or is it a part of your any experience, that is trial or any?
Yeah, no. We did the trial only to see how accurately we are diagnosing the microscopic
And it is
metastasis
a trial.
on the lymph
What is
node.
the question of your trial?
So
What is the
actually
research
we
question?
have
Research
come up,
question.
We have come up now, and in the low intermediate risk group, we are following only the sentinel nodes. We are not going for the lymphadenectomy, but we select our patients where the nodes are enlarged or suspicious. Even while during the surgery they are looking suspicious, we actually take them out. And also, we don't take up any grossly suspicious nodes for the sentinel node mapping. We go for the lymphadenectomy in these patients.
Yes, thank you.
Can I ask
It's
two
very
questions?
nice presentation, and it's very clear anatomic description. Thank you very much.
Yeah, two questions, a little technical questions only. Like, how often have you to use ICG injection twice for non-visualization? And do you prefer the fluorescence mode to the SPY mode? I have an open striker SPY camera, and I somehow prefer the SPY mode to the fluorescence mode. And how often do you repeat your ICG injection? Did you have to repeat it, if at all?
In this particular cases of 110, we did not repeat any ICG. But later on, what we could see, sometimes when you are not able to identify the nodes, in these cases, we reuse the ICG. and you will be able to identify the node where you feel that, yes, you are not able to see any kind of the lighted nodes.
That's my experience. In a few
Yeah.
cases, I have had to use it the second time. And I don't know, I find the SPY mode very nice to identify the lymph nodes rather than fluorescence.
So one can use it.
Yeah.
How often do you encounter para-aortic sentinel node? And what is the location
Yeah,
exactly?
I think we have found it in 6% of the cases, the periaortic node dissection. I mean, a sentinel node in the periaortic region. And also the sacral node.
Inframesenteric or supramesenteric?
It was supramesenteric.
Which sacral? You're saying
No. I'm saying the sides
Yeah.
in the experience.
No,
In 6% of the patients.
Above the inframesenteric artery or below?
Yeah, it was above the inferior mesenteric artery. It was especially what we found that was onto the right side. That's how. That is the interaortocaval node. And in one case, we found in the sacral region as well.
Personally, I find it very, very rarely. I find it.
The rarely means you have to do 110 cases to find it.
No, I've been doing so many cases, but
Yeah.
rarely I encounter aortic.
We have found in 6%.
Yeah, I think.
That is the only time when I look for the paraortic, and yes.
Yeah.
Rarely one does find.
Yeah, true.
Thank you so much, ma'am. Thank you so much.
Thank you.
It was really, really very beautiful presentation. The way we see, if you tell me, I will forget. If you show me, I may remember. But if you involve me, I will learn. Here is the combination of everything. We are telling you, we are showing you, and you all are involved here. So to call next up on the stage, I would like to involve Dr. Yogesh Kulkarni, Head and Consultant Department of Surgical Oncology, Kokilaben Dhirubhai Ambani Medical College, Mumbai. Topic of presentation is robotic para-aortic lymph node dissection. Thank you, sir.
Can somebody come and help me? I'm not able to. No, I'm not able to pull back. Wait. Where is my folder? Can that guy come in here? I want to open this folder. No, that laptop is not working. He is, I think, controlling from there. Yes, this and then open the first video also. Okay. Thank you at the outset. Thanks, Rama, for inviting me. With the permission of the chairperson, I'll take a couple of minutes extra than the allotted time, okay? So I just want to highlight a few things, in terms of port placement, how do we dock? I have a separate approach to approaching lower para-aortic versus exposing the upper para-aortic area, and how do you troubleshoot? So in my practice, I do the hysterectomy, pelvic node, and inframesenteric para-aortic lymph node dissection with a single docking, and then we either turn the boom or redock the robot to do the supramesenteric para-aortic dissection. I think you have a better control, when do a dual docking, especially when you are working close to the major vessels, and can avoid a vascular injury. So this is our primary port placements for the pelvic surgery. We put an umbilical port about 3 centimeters above the umbilicus, and all the rest of the ports are in the same line at the level of umbilicus. And then for the upper para-aortic node, we just change the camera port, exactly a mirror image of what it does. It just comes 3 or 4 centimeters below the umbilicus, so that you can have access, to the upper para-aortic node. And then, it sort of, you divide it into 4 compartments, inframesenteric aortocable and pre-cable nodes, inframesenteric para-aortic nodes, supramesenteric paracable nodes, and supramesenteric para-aortic nodes. So this is how you approach. So you make it into a compartment so that sort of helps you in terms of dissecting it. So I think the video is not opening here. Just open the video separately. Yeah. Yes. So this is, we have already done the pelvic part, the hysterectomy, and the right common iliac artery is the area from I usually prefer to start, because that's a more fixed point. You can access both the sides easily. The first thing is you go on to the left side, try to identify the left ureter, define the left common iliac vessels. So that's the left ureter in the picture and the left common iliac artery. Then you go cranially to sort of reach up to the inferior mesenteric vessel, and then you start doing the lymph nodes. So this is basically taking out the left common iliac nodes. So that's the left common iliac vein exposed. Then you come, onto the right side, inframesenteric, pre-cable, aortocable, and paracable nodes. So this is pre-cable nodes, inframesenteric. So the key is to identify the structures that you want to preserve, both common iliac arteries, IVC, aorta, and both the ureters. I think unless you have identified this structure, it's very difficult, to reach the margins of your lymph node dissection. So here you are going paracavally. And so you just reach a point where you have left your pelvic lymph node dissection. So that's it. That's where we had stopped our pelvic lymph node dissection. So you can just ask your assistant to retract the ureter. That's the right common iliac artery and the right external iliac artery. Once this is done, then you focus your attention to the left inframesenteric para-aortic nodes. So I think your third arm, does a good job. Obviously you have to be extremely careful. There have been injuries that are associated with giving over traction because with the third arm, especially to the inferior mesenteric artery. I have had one case, where we have actually avulsed the IMA because the traction on the third arm became a bit too much. So what did you do then? We just clipped it. We were lucky to have a little bit of stump. No, it depends on where it gets avulsed. So if it gets avulsed very close to the aorta, you may not have adequate area to clip it. So you have to be lucky. It's difficult. Yeah. So this is the inframesenteric, para-aortic nodes. And once you do this, at this point of time, you just turn the robot around. So if you have an XI, you just change the boom. If you have an X or SI, you have to, sort of change the position of the robot completely. So now here we have changed the position. Now the camera is facing the duodenum basically. So I think again here, identify the structures that you are worried about, identify the duodenum, identify the left renal vein, and then you can proceed with your dissection. So as you grow cranially along the interaortic cable nodes, there is likelihood that you will encounter the right gonadal artery there. So you can see the right gonadal artery there. So I think the key here is to retract the mesentery. Now there are a variety of ways by which you can retract the mesentery. You can use a T-lift, you can take mesenteric sutures, or you can just put one additional port, okay, for the assistant to help you retract. In this case, we just put an extra port, to retract the mesentery. No, it may not be possible always because progress will hold one side. The other side somebody has to hold or lift it up for you. Yes, so that's the left renal vein that you can see there. And then you try to go on to the right side. Usually there are not many nodes on the right paracaval side, but that is just to help you identify the right gonadal vein. So that's the right ureter, and you can see the right gonadal vein there inserting into the IVC. Once this is done, then the most probably technically difficult part of the para-aortic node dissection is doing the left para-aortic supramesenteric nodes between the renal vessels and the IMA. So this was part of the nodal tissue which was left behind. And the IMA can be an hindrance, okay, because you have to go around, the IMA many of the times, and the traction that sometimes you give, especially when it is already being held by prografts, can lead to IMA, injuries. So that's the part of the lymph nodes between the renal vein and the IMA. And you can see very well the gonadal vein joining the renal vein there. Supine, head low, tread length. And then here, the other structure that you will have to take care is one is lumbar vein, which comes sometimes from the renal vein, and the left gonadal artery. So that's the left gonadal artery. And that's the left gonadal vein joining the renal vein. So I think that's the uppermost part of the dissection. Then there is one lymph node which is right, above and below the IMA. So here you can see there was a branch of the lumbar artery, or a lumbar artery which was singed. So try to preserve it. I'm just done. 1 minute more. that's the end result. You can see all the anatomical landmarks that you would require, in order to do a complete para-aortic node dissection. Now, how relevant it is in today's day and age, we all can debate, okay? I mean, there are ways. I mean, we all have learnt it by mistakes, okay? But this is something which I find the dual docking allows you the best control, especially when you are doing a supramesenteric lymph node dissection. Thank you.
Thank you, Dr. Kulkarni, and also thanks for finishing actually within time limit.
Yeah, thank you.
And it was an excellent presentation and excellent demonstration of your dual docking technique and very well anatomical dissection. Thank you. We will be taking maybe 1 or 2 expert comments, that's all. Yeah.
I think as of now, we are doing it for all high-risk endometrial cancers, okay? We are working on our data and our accuracy of doing, so we are doing sentinel node and complete lymph node dissection in high-risk endometrial cancers. We have done about 65 cases. So we will evaluate our data at some point of time, and even the data suggests, okay, at some point of time you may have to, sort of not do it, okay, if your sentinel data is accurate.
Yogesh, why are you waiting for 65 cases? 30 cases is enough to analyze your data?
No, it's not the question. See, I think as I said, our sentinel node learning curve and para-aortic node learning curve went simultaneously. Okay, so I think, sometimes you may not be doing the right thing. So in my view, I would wait till at least 100 cases before I totally omit, doing lymph node dissection in high-risk endometrial cancers.
Yeah, final comment from final.
I mean, it would vary. I mean, I have absolutely no problem if somebody says that I'm happy to do a sentinel node in high-risk endometrial cancers. As of now, I am not comfortable with it. Low risk,
Final comment
intermediate
from
risk,
Dr.
fair
Rama.
enough.
Final comment.
It was an excellent presentation and the excellent surgery which you have done and you have shown actually. So I think, so far as the debate is concerned of the indications is fine, but what we are looking at, yes, there is an indication which nobody can say that no, it is not indicated at all. It depends on the kind of the cases which you choose, but at the same time, if you have the high-risk patients where you are not able to identify the sentinel node, you can even choose going for that of the para-aortic lymph node dissection. I think the way you had shown the boundaries and the presentation, you made it very clear technically that how the parametrial node dissection can be done. So actually, one question, why don't you apply the clips? I don't know. Though this was a comment.
The problem is because the problem is, here you are totally dependent on assistants to apply the clips, okay? Because you take your progress spout and you are out of sync. So you can't use your robotic clip applicator to apply clips. And for assistant, it's a very awkward angle, okay, to reach there and apply the clip. So unless it comes here, I would not want the assistant to apply clips because it can cause more problems because of the angle at which they are coming in.
But definitely you can present in your experience, and it was an excellent presentation once again. Thank you.
Thank you. One question to you. Can you use this para-aortic lymphadenectomy to stage 4, to differentiate the stage 4A and stage 4B disease, cervical cancer, to limit the extension of the radiotherapy? I don't know whether there is any.
No, I don't think we are doing staging for cervical cancer. This is basically for endometrial. Yeah.
The X is available in the most of the centers because I do a lot of robotic surgeries. The X machine is economical, and a lot of centers have got. But XI machine, as you said, single docking and you can rotate the boom and you can do either of the side. But when we have the X machine, we are giving the head low and then coming back for the suprarenal part or the that again, little tilt or head up position, how does it matter for
I think I do most of my cases on X because our urologist does not allow me to do XI. So XI is more of a luxury for me. So most of the cases that I do is on X. So it takes another 15-20 minutes. Obviously, you have to put the port, redock, bring the robot from the head end of the patient. So it takes 15-20 minutes more, but it's perfectly feasible. We have done it on SI and we are doing it on X.
Okay, thank you.
Thank you so much, sir. Thank you so much. It is being said a visual image in the hand of an artist is merely a tool to trigger a mental image. Thank you so much to all my chairpersons for involving and your participants. To proceed with our next session, I would like to involve our chairperson, Dr. Elizabeth Waligad ma'am, Senior Consultant, Department Gynecology, St. Martha's Hospital, Bangalore. Dr. Shabira Khatun ma'am, Professor, Department Gynecology, Bangabandhun Sheikh Mujib Medical University, Bangladesh. Dr. Vijay K. Ahuja, Senior Consultant, Department Gynecology, Aster CMI, Bangalore. Our next presentation is on hereditary gynecological cancer syndrome in Indian perspective by Dr. Amita Maheshwari, Professor, Department of Gynec-Oncology, Tata Memorial Hospital, Mumbai. Thank you, ma'am. Should I start? Okay. Very good morning. I am Amita Maheshwari. I am a GYN oncologist at Tata Memorial Hospital, Mumbai. And thank you very much, Dr. Rama Joshi and organizers of this meeting for the opportunity and wonderful hospitality. So from exotic videos, now we move on to something much simpler. And the discussion on Indian perspective on hereditary gynecological cancer syndromes, I'll start with a clinical scenario. A young lady recently married nulliparous, apparently healthy. The only thing was her grandmother died at the age of 55 with some abdominal malignancy, and mother was diagnosed with ovarian cancer at 50 years of age, is our patient. And we did test her for germline testing, which is our routine practice. Mother was found to have mutation in BRCA1 gene. After pre-test counseling, this young lady was also decided to undergo testing, and she was also found to have deleterious mutation in the same BRCA1 gene. So she was essentially a mutation carrier. So before I discuss her story further, what we did, let's just discuss some important issues pertaining to the topic. So these are what is the germline profile of Indian women with ovarian cancer. Genetic counseling and testing in India, what are challenges and limitations, and where do we stand? What are risk-reducing procedures, why, when, and how? So hereditary gynec cancer syndromes, we know the most common is hereditary breast ovarian cancer syndrome, followed by Lynch, and then some rarely Framingham, Cowden, and Peutz-Jeghers syndromes. But the focus for today's discussion is on hereditary breast and ovarian cancer syndrome. So ovarian cancer is the third most common cancer in Indian women. We see nearly 45,000 new cases. This is the rough estimate. And we know that individuals having mutation in BRCA1 or 2 genes are at very, very high increased risk of developing ovarian cancer. So although we have very limited data on germline profile of Indian women with ovarian cancer, but recently we do have some publications. So this, I would say, a landmark publication came in 2021, a multicentric Indian study looking at the prevalence of BRCA1 and 2 gene mutations in unselected population of ovarian cancer. And what this study showed that nearly 21% women had
deleterious mutation in BRCA1 or 2 genes. And what is also interesting to note that more than 2/3 patients, there was no family history of related cancers. So if we select patients for testing based on family history, we are going to miss a substantial proportion of women. We also know that besides BRCA1 and 2, there are many moderate penetrance genes, including RED51, CD, BRIP, CHEK, MMR, PALB2, and they have substantial risk of developing ovarian cancer. So what is Indian data on these genes in women who have ovarian cancer? So this is a study of 1,000 women with breast or ovarian cancer. Overall mutation rates found were 30%. BRCA was, of course, the most common type, but 15% women had non-BRCA mutation, mutant genetic mutations, including mainly was RED51, CD, and other genes. Similar results were from a small study from All India Institute of Medical Sciences. So overall, mutation rates were 44%. This was somewhat selected population, and nearly 50% women had non-BRCA gene mutation. We looked at our data. These are 91 patients from our center recently accrued on our HIPEC trial. So what is interesting that pathogenic or likely pathogenic mutation in our population, this population is 38%, which is pretty high, and surprisingly, because these are unselected patients. And in our, around 11% have non-BRCA mutation. So what I want to highlight here is that instead of doing only BRCA1 and 2 testing, we should try to do multi-panel gene testing if feasible, because we will pick up another 10 to 15% mutations. So as we know, we can make out, because such high prevalence of mutation in ovarian cancer patient, there is a huge number of women who are candidates for genetic testing and counseling. But what is the current scenario in our country? So we have many limitations when we talk about genetic counseling and testing facilities in India. It starts right from the lack of awareness both amongst healthcare providers as well as patients. There is a shortage of trained and experienced counselors. There is limited access to laboratories, cost of the testing, and there are many socio-economic and cultural issues. However, I think the general awareness level is going up, and as a result, we do see a lot of women undergo counseling as well as testing. So once a healthy individual is diagnosed with germline mutation, a big but challenge for clinicians how to manage them further. We know that screening and chemo prevention, although available, but they have very limited or effective, they are very less effective in preventing ovarian cancer especially. And the main preventive measure for ovarian cancer remains risk-reducing surgeries in the form of bilateral salpingo-oophorectomy. So the further discussion is about bilateral salpingo-oophorectomy, why, when, and how. So when we look at the data, this is Cochrane meta-analysis, which included 9 studies over nearly 1,000 women who underwent RRSO versus who did not, and what this meta-analysis showed. And as expected also, there was a substantial 83% reduction in high-grade serous ovarian cancer incidence, also 94% reduction in ovarian cancer-related mortality, and benefit goes beyond. There was 68% reduction in all-cause mortality, as well as additional advantage in terms of 36% breast cancer reduction in breast cancer incidence, as well as 42% reduction in breast cancer-associated mortality. So I think there is no doubt or confusion that risk-reducing surgeries are the best way to prevent ovarian cancer in high-risk population who is having mutation in high-risk genes. So the next question is, when do we all advise this surgery? The recommended age is once family is completed, between 35 to 40 in BRCA1 mutant carriers and 5 to 10 years later in BRCA2 gene and other moderate penetrance gene mutation carriers. Pre-operative counseling, I think this is extremely important, unlike our curative surgeries where counseling is not so difficult. Here counseling is extremely important because we are offering surgery to an apparently healthy individual. So a detailed counseling describing pros and cons of the procedure, as well as updated screening for other cancers, the need for subsequent long-term screening, all of these have to be explained in detail. So a breast cancer in screening must always be done before we offer risk-reducing surgery, because you don't want to pick up a breast lump after doing this procedure. And of course, informed consent. We do face a lot of challenges in our genetic clinic when we counsel these women, and some of the issues which we regularly face are that in general there is low comprehension and acceptance of real risk, and I think that's how our mindset has been. We are not really very preventive oriented society as such. We always go for treatment when there is some issue. The other points are risk of undergoing surgery. There is risk or fear of loss of childbearing ability, early menopause, loss of sexuality. Also do have poor social support. Some of them are bread earner and undergoing another surgery and being away from the work is very challenging. And of course, cost of the surgeries. But despite that, I think women do opt for risk-reducing surgery. The only thing is we often need multiple visits. It's not that one single visit counseling is good enough. So about the procedure, very straightforward, simple, but what is important that we must adhere to the guidelines, which includes collection of cytology, thorough evaluation of entire abdominopelvic cavity for any occult disease, and complete removal of both tubes and ovaries. And also extremely important to label this specimen properly for pathologists to tell that what was the purpose of this procedure, because what we need to follow is CFIM protocol, which essentially includes extensive sectioning of the fallopian tube. So this is a video provided me by Dr. Santosh. I don't know if he's around. And that's how CFIM protocol is being done. This little cute thing is actually fallopian tube on pathologist table. That's how it becomes.
We didn't think it was a flower.
Yeah, okay. So the fimbrial end is cut longitudinally at 1 to 2 millimeters, and the rest of tube is cut transversely again at 1 to 2 millimeters. The idea is to extensively study the tube, and the reason is because there can be occult cancer or precancerous lesion in the fallopian tube, which can be seen in up to 5 to 7% of cases. And the idea is to pick up those cases. And we do have some cases where cancer was detected in the tube. So this is the rest of the tube, which is cut transversely, and everything is submitted entirely. So a lot of job for pathologists here. The next question is, do we do hysterectomy when we do RRS? So this is always, thoughts come whether to do or not to do type situation. So it's not mandatory. However, if there is pre-existing disease or some other problem, always decision is easy. But the advantages of removing a uterus is, one, we are sure that fallopian tube is removed completely, and it simplifies further hormonal treatment, may it be tamoxifen or estrogen replacement therapy. And there is theoretically a small risk of primary uterine serous cancer in BRCA mutation carrier. So these are the, if we want to discuss with patient, these are the points, but ultimately it's patient's decision whether to undergo hysterectomy or not. What about early self-injectomy and delayed oophorectomy in this high-risk population? So we know in general population there are some evidence from population-based studies suggesting that opportunistic self-injectomy may reduce the risk of ovarian cancer. But currently in this high-risk population, there is no evidence to suggest that it is as effective as self-ingo oophorectomy. In fact, there are at least three prospective studies ongoing addressing this issue. Protractor UK trial, Dutch study, and NRG study. But until the results from these studies are available in high-risk population, the one with mutation carrier, the standard surgical procedure is self-ingo oophorectomy and not early self-injectomy and delayed oophorectomy. I'll share our experience with risk-reducing surgery. So we had 77 women over 10 years period. Actually, our uptake is around 25 to 30% only after counseling. The median age at the time of surgery was 43, maybe somewhat more than what is reported in Western literature. Most women were premenopausal. The most common mutation was BRCA1 followed by BRCA2, but there were few others, and two patients actually there was no mutation found, but surgery was offered in view of very strong family history. So in our series, actually only a fourth patient had hysterectomy. So that's how, after counseling and after decision making, we just had only 1/4 of the patient who had hysterectomy. There were no serious perioperative complications. Anyway, they were not expected also. But what is interesting to look at histology. So 6.5% patient had some some histological abnormality either in the tube or ovaries, including cyst adenoma, mature teratoma, stick lesion, and two patients had actually occult high-grade serous carcinoma. So, and that's again highlight the importance of extensive histopathological evaluation. We actually went in again, did complete surgery, and these women also required adjuvant treatment. So before I summarize, actually, one of those, the patient I started my case, she was married but nulliparous at the time of detection. So she was counseled, she completed her family, and then we actually offered her the option of PGD, which she refused. She had 2 kids, and at 42, she decided to undergo risk-reducing surgery, and she's the one who had stick lesion. But she is doing well. So to summarize, I think we all need to be aware that substantial number of Indian ovarian cancer patients have hereditary predisposition. Incidence, if we take all genes, maybe 30 to 35%. Genetic counseling and testing for hereditary cancer is still evolving in the country. We know we have a severe limitation of counselors and testing facilities. We need to have more low-cost multi-gene panel testing, and maybe mainstreaming of genetic counseling may be the way forward, because we really don't have adequate counselor, and that should not be the rate-limiting step, not advising testing. We also need country-specific guidelines and genetic data on long-term outcomes, because there are some evidence suggesting that there may be genetic as well as racial variations in Indian population. So studies do suggest that there are some novel mutations which we see only in Indian population. So that's why it's important that we kind of have a registry, Indian registry. We also need guidelines. This is one consensus document which was published by IJMPO, but I think it's time that we, maybe AGOI, can think of coming out with guidelines on this issue. So at the end, it's multidisciplinary teamwork, and I'm really fortunate to have such a big, all facilities, but even if it's not available, I think one can always have association and collaboration with other labs and help the patient. So with this, I'll thank you all.
Any questions?
So thank you very much.
I can just ask one thing.
Yeah,
it was an excellent presentation. So my question is that for this moderate penetration non-BRCA1 and BRCA2, do we have enough data on their absolute risk and the age at occurrence, and whether whether it justifies prophylactic surgery.
So we do have, and most of these have shown more than 10% risk, and the age for risk-reducing surgery is same as BRCA2. So it's around 50 years, not 30 to 35 to 40. And all of them have more than 10%, RED51CD more than 10%, MMR also more than 10%, and PALB2 I think is around 6%. We do have data.
The other thing is, what percentage of your patients after RRSO do you advise hormone replacement therapy?
That I was hoping you don't ask this question. So median age in our population was 43 years. So generally, I think we are very poor at advising hormone replacement therapy. But theoretically speaking, it is okay to advise HRT to these women unless there is a history of breast cancer in the individual, especially receptor positive. But I don't know how many of us generally advise HRT. So we do advise for lifestyle changes, calcium, exercise, all of that. But very few actually we have advised HRT. I don't remember offhand, what exactly, but yeah, I must admit. But yes, theoretically you can give HRT to these individuals. So, and also I think we have little concern about breast cancer in these women, or maybe generally also we don't prescribe HRT. We don't prescribe HRT after treatment for cervical cancer, young women. I don't know how many of us actually giving HRT to these patients. So
Thank you. Thank you, Dr. Amita Maheshwari. I think we should proceed to the next lecture.
Thank you. Actually, thank you so much.
It was an excellent talk, and it is comprehensive.
We are really
to learn
honored
everything.
By your presence, ma'am. Thank you so much, ma'am. We are honored by your presence. It was really beautiful lecture. So I would like to call our speaker on the stage, Dr. Ashwin KR, Senior Consultant, Department of Surgical Oncology. Topic of presentation is PIPAC in ovarian cancer.
Thank you. So I'll be talking about a novel technique of PIPAC that we use at our center. So greeting from Aster Institute of Oncology. A brief introduction of PIPAC. So PIPAC is a way of giving intraperitoneal chemotherapy. You must have heard of normotherapic IP, NIBS, and HIPEC, and now is the PIPAC. PIPAC is basically giving chemotherapy into the abdomen using a pressure. So what we use is capnopen. So the capnopen, what it does is the chemotherapy agent is aerosolized to 9 mm to 30 microns, and the chemotherapy is injected into the abdomen. So this is the capnopen, which is injected through a laparoscopic method, and the entire chemotherapy is aerosolized to 30 microns. So the premise is we reduce the size of the chemotherapy, we use pressure, and we have found that this has better distribution in the abdomen and also higher penetration. So just like any other diagnostic lab, we use the same thing, access to the abdomen either through Hassan method or through Palmer method. We take our safety very important because of the aerosolized chemotherapy. The doctors and to the nurses. So this is the basically the safety that we take. Then the abdominal access, like I said, can be either as an open access, or we prefer to use the Palmer's technique, because most patients that come to us have multiple surgeries, would have had since we are a center of excellence for HIPEC, we do a lot of extensive peritonectomy, so we are worried about the adhesions, and we have had issues of entering into the bowel also while having access. So we always use a double balloon trocar, because when we use pressure, we have found that the cancer can get implanted into the subcutaneous area, and we have in 2 patients we have had implantation. So always use a balloon trocar and wash the abdomen, wash the wound multiple times before closing. So as soon as we do a diagnostic lab, the PCI index is recorded, and here very important, no additional access has to be done when we enter. And we always do, after PCI, we always take biopsies at least from 4 quadrants, because we know we will know the response of the PIPAC once this is done. And once we have done the biopsy, diagnostic lab is done, agent is injected. Always again, safety is important, that we know the name, drug and the dose, and always confirmed by two of our agents. And this is basically our setup. So this is the angio injector you can see, which is available in most radiology department or in the CT scan and our cath lab. So we have injected at a specific pressure of 300 psi at 0.6 ml per second, and then all the doctors and everybody have to be outside, and this is done remotely outside. So coming to my talk on PIPAC and ovarian cancer, why? Because everybody knows the recurrence is so common. It's almost 60 to 85% within a span of 5 years, and most of them recur in the peritoneal mets. Yes, iterative laparotomy can be done in the recurrent cases, but it depends upon the completion of CRS. Can we do CC0, the platinum resistant, and also the operability. Platinum resistant is a big issue, as most of us know, and medical oncologists vouch for that, is the progression-free survival is dismal. Even with the addition of targeted agents, we have found that the Aurelia trial showed that the addition of PF is only about a matter of months. So PIPAC is that's where we come. In a palliative setting, because of the unique pharmacokinetic, because of aerosolization, higher pressure, higher penetration, better distribution, and because of lower absorption, we are able to achieve response in them. So the PIPAC study started because of one person called Dr. Mark Raymond from Germany, who was the one who invented and has a patent on this capnopen, and he was the one who, based on trial basis, started using PIPAC. So it was started first in 2011, and it was a multi-centric European trial, which were basically for ovarian, colorectal, gastric, mesothelioma. He did feasibility studies. So as you can see, the first study was basically, most of them were retrospective studies to find out is it feasible to do. Then came the actual proper phase 2 studies, where they did 1,800 PIPAC procedures in more than 800 patients, and most of them were ovarian cancer. And we're happy to say our team was a part of this study. As you can see, most of these patients who came to this study had multiple lines of chemotherapy. So basically, they were burnt out patients who came to us to see what will PIPAC help. So, and we are happy to say that in this study, most of the patients were able to undergo 2 to 3 cycles of PIPAC with very less complications and side effects. So again, how do we, in the studies also showed that the response was not only based on RECIST criteria, that is the radiological criteria, but also we could find response in most of the patient in histological. As you can see, the response after 2 to 3 cycles of PIPAC is very good. More than 60 to 70% of the patients responded to this PIPAC treatment. So this study concluded that yes, PCI improvement and also pathological response does happen between 64 to 100% of the patients, and complete response is also common. That is, complete PCR is also available. But yes, survival was not analyzed completely, but in ovarian cancer patients, between 9 to 14 months was the survival advantage. But in this patient, they were not divided into platinum sensitive or resistant. And most important, we found that the quality of life, all these procedures are done in a daycare procedure. That is, they come in the morning, undergo a diagnostic lab, finish chemotherapy, and then they can go back. What are the indications right now that we use PIPAC in ovarian cancer? Most of the patients that come to us are recurrent peritoneal cancers after completing second or third line of chemotherapy. We also can use it in first line if they're unresectable disease, that is extensive bowel involvement or involvement of the porta hepatis or a very high upper abdomen disease, and the patient is not performance is not good enough for us to do, and where CRS IPIC cannot be done. Refractive ascites patients who come with persistent ascites respond very well to PIPAC, and patients who don't want any more chemotherapy because of the lesser side effects and the lower dose, again PIPAC can be given. And upfront intervention, right now we have started doing trials where patients, after giving systemic chemotherapy, when we do a diagnostic lab, they're found inoperable. We can try to do it as an NACT setting, but again, strictly I need to mention that This is only being started as part of a trial, and we have started this trial. We are not sure if PIPAC can be used therapeutically right now. So the thing is, PIPAC is feasible, it is safe, it is effective. Multiple applications can be done in a period of 6 weeks. Every interval that we give is 6 weeks. Since it is a simple procedure of doing a laparoscopy, it's a very fast learning curve. The quality of life is very good, since they don't have the side effects of the systemic chemotherapy. And more importantly, it can not only be used as monotherapy, but it can also be administered with concurrently with systemic chemotherapy if your patient is fit and the medical oncologist deems it can be done. Again, contraindication for doing PIPAC is don't do it in any patient who has an bowel obstruction, because we have found that because of the pressure, most of them will have some kind of perforation. And other contraindications are mainly systemic, if they have any renal or hepatic impairment or myocardial insufficiency, immunodeficiency, pregnancy, or if they have very high cumulative dose of chemotherapy, or obviously if they have any allergy to any of these drugs. There are 2 studies that we have been involved with. Mainly we knew in platinum sensitive patients have a lot of options. What are the treatment that we're giving for platinum resistant patients? Because these are the patients that come to us in the OPD, and where they have so much of issues with quality of life, recurrent obstruction, ascites, and they don't want any more chemo. Chemo don't work. This is where we wanted to see in our study if PIPAC has any role here. So this was basically a part of the trial. So the primary objective to see was through RESIST criteria to see if there is a response, and the secondary outcome of our study was to see the quality of life and what is it feasible and what are the side effects. So all the patients who came to us on platinum resistant had an MRI, and after that we randomized them either to the standard method of treatment, that is IV chemotherapy, or we put them to the new novel drug of PIPAC. The demographics were the same. Most of the patients were in more than 50 years, and almost all of them had multiple surgeries done, and most of them had more than two lines of chemotherapy done. Following the PIPAC and IV, yes, obviously because of the systemic effect of chemotherapy, the CTCA and what we the CTCAE criteria, we found the systemic side effects were much more in the IV arm. The RESIST criteria, that is every patient who came to us underwent an MRI before the cycle of PIPAC. We found that the RESIST criteria, the response was much better in platinum resistant agents when they underwent PIPAC, and this was also confirmed by the peritoneal regression grading score. What is peritoneal regression grading score? It's a way where we take a biopsy after each PIPAC. The pathologist sees the biopsies and see what is the response to chemotherapy. So we are happy to say that most of the patients, out of the patients, 10 patients had complete response, 14 patients had major response, while 10 and 6 had minimal response. Most important, what we are trying to say, yes, apart from the clinical outcome, is the quality of life is really good for these patients, because not only when we do the diagnostic lab and we do PIPAC, we are able to remove the ascites, which is a major issue. They tolerate treatment so well that they prefer not to take IV chemotherapy. Then the second study, now once we established that PIPAC was feasible, the other issue is what are the dose that we give. Again, this was a study, this was a dose escalation study that we give. So in ovarian cancer, we give combination of cisplatin and doxorubicin. So we used a dose escalation study of increase the cisplatin to 15 milligram and doxorubicin to 3 milligram. Again, in our study, we did not have any major effects, and the PRGS score, in fact, was much better when we had dose escalation, and the quality of life, again, was better. So basically, increasing the dose did not have any major side effects or major issues. And again, our dose escalation study was part of our meta-analysis, which was done by Dr. Tempfer and Dr. Mark Raymond. Again, this is a study which has been, which is part of the meta-analysis, again, which showed that increasing the dose to doubling the dose did not have any major side effect. In fact, what's the most important, was to select the patients properly and give it at the right time. And right now yeah, like I said, we are in the trial of using PIPAC in a therapeutic role. That is for patients who have after an NACT, if we do a diagnostic lab, and if we found that in this patient we did not since the CC score is very high, we thought that it won't be possible to do complete CRS and HIPEC. We went ahead after talking to the patient and enrolled them into the trial, and we did PIPAC in them. As you can see, after 3 PIPAC, the response was very, very good, and this patient underwent complete cytoreductive surgery and HIPEC. I do understand this was done only as a trial basis, but I think we are optimistic that PIPAC can be used in a therapeutic role. Right now, take-home message, PIPAC, please do it only if you have a good team and you have a multidisciplinary team. Use it only in the recurrent ovarian cancer, patients who are having refractory ascites, those who cannot tolerate chemotherapy or those who don't want chemotherapy, and upfront can be done, but again, we need more trials. And the drugs right now that we use, we are escalating it to higher dose and getting better response. Right now, we are not sure what dose we are going to achieve ultimately after 2 years or 3 years. But yes, patients are tolerating them better. And most important take-home message is, it is such a simple procedure, daycare, no major cost compared to the addition of multiple target agents. Quality of life is amazing. Thank you. We have given 6, but on an average, most up till 3 to 4 is we advise. But for patients who have had refractory ascites and who don't want systemic chemotherapy, we till 6 we give them and we stop.
Yeah, thank you, Dr. Ashwin, for the excellent presentation. I think organizers say lack of time, so no more questions.
We are
Thank
really
you.
sorry for that, sir. We are actually sorry. We wanted, but due to so the next session is research and capacity building in gynec oncology in India. We would like to call on stage Dr. Asima Mukhopadhyay, Consultant Department of Gynecology, Tata Medical Center, Kolkata.
Sorry, can I have my presentation? So I know 10 minutes I've got maybe. So we will try and rush through the slides and maybe not do all of them. So thank you, Rama ma'am, for calling me to speak today here. Where is mine? Fortis, this one. And of course the organizers as well. I think what I would want to do, because we have very limited time, I think I like to do within 8 minutes or something. And so just kind of give a little bit of a highlights about what we have been doing from the Kolkata Gynae Oncology Group, because it's a very new group, and maybe after listening to all of you, I think there are scope for doing collaborative work. So as you can see, a lot of the things that I am working both across UK and in India, but two of the main things which are very important for me to do what I'm doing today is my master's in clinical trials and then a PhD in cancer biology, and that I trained myself to do research, and that is important, and a lot of work, right? So for the time being, my areas of interest is cytoreductive surgery and research, translational research, DNA repair and health equality. But again, I have been enlightened today listening about endometrial cancer, vulval cancer, but in real practice, in my brain, I actually don't read those. I just follow what you say. I just concentrate on BRCA, HRD, and ovary cytoreduction. That's it. So a little bit about the Kolkata Gynae Oncology Trials Translational Research Group. We thought that we wanted to do some collaborative research, be a part of GCIG. So we started off with 3 centers in Kolkata. But as you can see in the list over here, we have more and more centers across India joining us in our studies or being members. And we have a lot of external collaborators. This is how we started as a UK DST UK grant, as a registered society. Then the royalty payment, which I got from my Rukaparib story, helped with flourishing. We became an IGCS partnering organization, a GCIG group from India, and now we are an ICMR Collaborating Center for Excellence, and it is a standalone research organization. It's a CIRO, it's a Scientific Industrial Research Organization with its own legal status. And we have our patient survivor group called Sharpajaya. So this is how it looks like, the GCIG groups across the world. You've got a lot of groups from, like GOG and others from, Canada, Europe, a lot of groups. This is the Asia Pacific groups. And from India, we are the one called GOTRG, so we have to send twice a year, 6-member delegation representing India. And we are participating in a lot of the GCIG studies one by one. It takes time to open up. HOVI HIPIC we are doing with Som's team. So one by one, gradually rainbow into 3, but it takes time, so we're getting slow and steady. But most important, it's not only about participating in other studies, right? What we are trying to do is to develop made in India studies where the other participants in the world will participate. And a lot of them, I cannot talk about these things, but the range is from prevention to intervention. But most of my studies are mainly proof of concept clinical, so biological basis, at least 10 years of lab work. We have found something, a lead, and we are taking into clinical trials. So this is for the group, so we have a clinical trials unit, we have a translational unit building up, and a statistical unit, and we're trying to kind of develop all these things, PKPD study, trial design, innovative study designs, biobank, and all these things to deliver education, and mainly a methodological research unit, which is what we really want to do for doing studies specific to low middle income countries. And these are all the facets, which I'm not going to go through all the details. But just to kind of give an idea, after doing, PARP, HRD, surgery, I really believe that good biology does not compensate for a bad quality surgery. No matter PARP and all, you have to do your first thing first, right? And it should apply for any cancer. Therefore, your standard of care reference arm is important. And the other thing I've coined a term called RCT. We really do not have the resources all the time to do a big fat RCT. So I called RCT is rationalizing and reducing the cost of running randomized controlled trials. So that is why you really need to have innovative trial designs to be able to do that. So just to give a very small example, on the left-hand side on the column, you can see a usual journey of an ovarian cancer, surgery, HIPEC, BRCA, HRD, PARP, recurrence, treatment of recurrence and all. So when I work in the UK, 6 months of the year, everything is falling. I don't face any problem. But when you come to a low resource setting, I have also worked in CNCI. Now I am mentoring All India Institute of Medical Sciences. So this is the normal journey. This is what you do in a high resource setting. You have everything covered. When you come to a low resource setting, when it's patchy, you have to have an alternative strategy. And this is what I have done for each of them. For cytoreductive surgery, we have surgery. For HIPEC, I don't believe you should be giving everybody, so I called a targeted HIPEC trial based on biology. Counseling, Amita nicely mentioned about genetic counseling, so we have a trial going on for Nugena, training nurses for nurse-led genetic counseling. Low-cost academic HRD assay, the HRD assay which I developed in 2008, the functional, it has stood the test of time, and it's still the most, I would say, the most cost-effective HRD assay in the world today. So I'm now developing it through the BIRAC as a made-in-India solution. And will bring down the cost for a functional HRD to less than 10,000 or 5,000 rupees. Instead of giving PARP every day, 20 years of research work has done into now to put a proof of concept that we can give rucaparib once in 72 hours. And this is the type of trial that I'm trying to do. And I can't go through all these things, but this is just a patient. I did a surgery with the HIPEC under the HIPEC HR trial. Then she underwent genetic counseling and testing through the Nugena study. Then went into the EPIDOC study with the intermittent PARP, then a survivorship and all. So this is how, and very important that we have something called a central trial MDT. We call it a ROC MDT, regional ovarian cancer, so that you can have not only clinical MDT, but a trial MDT and a precision medicine MDT. And hopefully this rock will now become a standalone ovarian cancer center in some years' time, hopefully. So just another 3 minutes time I have got. So basically this is all you need, improving the standard of care reference sum. This takes about 3 to 4 years initial time to really benchmark your standard of care before you can think about any intervention to control, to compare against your standard of care. And then this is how for the ovarian studies, they have a nomenclature called PROVAR. For cervix, it's PROCERN, endometrial is PROEN, something like that. So training everybody, I just have to really go very fast here. So every patient should fit one or the other bill to get into a trial. Either it will improve survival, or it will be improve strategies, or it will impact on policy making or quality of life. If nothing, if it helps in developing your capacity, again, you should enroll a patient in a clinical trial. And this is what we did. Quality improvement. I was in Tata by this time when I was doing this, build up a team, grant after grant to develop the 25 big fat team then. Then, now, of course, with the IGCS mentorship, and I'm the research and publication co-lead, co-chair, so I have an access to 70 fellows across the world. So it's easy to do these things, but database, biobanking, and just to last 1 minute, I think this is where I started developing a test and a drug, a smart drug. The test is today's HRD test, as you know, and the drug is rucaparib, right? So, but it's a 30-year of history of developing rucaparib, right? And you can see my name in between, so, middle. So what I did, develop this HRD assay before TCGA showing that 50% of ovarian cancers are HRD. So that's the first study in the world, right? But I have not stopped working since then. And then, so this functional assay, now we are taking into an Indian HRD assay consortium. I wouldn't go through all the studies, but as I say, I have worked in HRD, so all the trials which I'm trying to do are based on HRD versus this, HRD versus that, something like that. HRD in cervical cancer, using PARP as a radiosensitizer in cervical cancer. Again, 10, 15 years of lab work behind that work, right? So this is the type of studies, Prabhat, I called it, that we are trying to do through our Colgo TRJ consortium. Hopefully, I will reach out to one of you, or all of you, maybe one by one. As I say again, this is through a BIRA proposal we're doing. And then this is for the hyperthermia work. Again, I have worked in the lab for 7 years on heat and PARP and BRCA before designing my study on HIPIC in HR trials, HR, so it's called HR HIPIC. Again, intermittent PARP inhibitor trial, which is ongoing, and I will send out an expression of interest call. As I say, the nurse-led genetic counseling study has got an ASCO International Innovation Grant Award and others. But if you kind of want to be a part of this, now we have the capacity to involve more and more centers. Initially, we were small, so just reach out to us. And as I say, that is a lot of people have contributed over the years, internationally, nationally, but I think it is time that we now build up our own portfolio. That's it. Thank you.
Thank you, Dr. Ashima. Thank you for your incorporation of Bangladesh in the new study, that is training of the nurses for genetic counseling. You are working with Bangladesh. Thank you for this.
Thank you so much, ma'am. Without any delay, I would like to proceed to our next session. It is Thank you so much to all my panelists. I'm extremely sorry. Chairperson. Let's proceed to our next session. We have a multidisciplinary gynecologic oncology case-based panel. I would like to call on stage my panelists first. Dr. U.D. Bafna, Dr. Rupinder Shekhon, Dr. Preeti Jain, Dr. V. Annapurna, Dr. Shruti Bhatia, Dr. Ishita Sen, Dr. Parimala Devi, Dr. Umesh Mahan Shetty, Dr. Bowman Dhabar. would like to call on the stage our first speaker, Dr. Bindya Gupta, Professor, Department Gynecology, GTB Hospital, Delhi.
So, at the outset, thank you, Rama ma'am, for giving this opportunity. And welcome to all the esteemed panelists. And we have to be very quick in this discussion. I'm given just 10 minutes for this case. So, the first we'll be discussing CA endometrium. So, she's a 64 years old lady with postmenopausal bleeding, hypertensive, diabetic, COPD on treatment, morbid obesity, 43 BMI. The entire systemic abdominal examination is normal. On PV examination, uterus was bulky, and histopathology was done, which revealed a well-differentiated endometrioid adenocarcinoma. And as you can see the MRI here, there's a growth around 4 centimeters in the uterine cavity. Cervix was normal, no enlarged pelvic or para-aortic nodes. Rest of the upper abdomen was normal. So at the outset, our first question, Dr. Preeti, our oncopathologist, that what is the role of IHC markers in endometrial biopsy samples? How do you proceed whenever you're doing an
basically, there are various scenarios where IHC plays a role in endometrial biopsy. First of all, it is helpful in subtyping of the tumor, whether it's a serous or an endometrioid carcinoma, because it has got diagnostic and prognostic implications for the patient. Also, like for endometrioid carcinoma, which is the most common endometrial carcinoma, the IHC is helpful in subgrouping of the molecular, like 2 molecular subtypes, the B53 mutant and the MMR deficient tumors are identified by IHC. Also, IHC is helpful when the tumor is located at the junction of the lower uterine cavity and cervix to delineate whether the primary is within the endometrial cavity or is a primary cervical tumor. Also, in the metastatic setting, it is helpful in confirming the Mullerian origin.
So, and what is the concordance between a biopsy and the final histopathology specimen when you get? Do you repeat it again or?
Most of the time we do not repeat because the concordance is almost 100%.
Yes, so either you do it in the biopsy sample
Yes.
or the hysterectomy sample, so that is what is required. Dr. Ishita ma'am, I would like to ask you, what is the role of PET-CT in the present case?
So, in carcinoma endometrium, the major role of PET-CT is for metastatic workup as well as for looking at para-aortic lymph nodes. Because so many times you will have normal-sized lymph nodes which may harbor disease, and not so much in endometrium. Endometrium, it's mainly in looking at metastatic disease.
So in a uterine confined, normally we do not do unless and until we are really suspecting a
Suspecting
high-grade
a high-grade
serous or
serous,
that kind of a cancer. All right. So this is the patient, this was the PANIS. So sir, MIS or open surgery, what problems do you anticipate in both the routes for this patient?
I think this is a very difficult case. Whatever, whether you do a open surgery or MIS, laparoscopic or robotic, is going to be a difficult case. But my personal choice is go for MIS surgery.
Yes, sir.
That is, I think, much safer for the patient. And the complications are much less with MIS.
Yeah.
With MIS, I am doing laparoscopy. I don't have access to robotic, so I do laparoscopically.
Obviously, robotic, I mean.
Yeah, so but this patient had very bad chest. He had COPD, so that is why, in fact, lap was, we could not do a lap in this case. And then.
No, yes, I quite agree with that. In fact, I saw this when I was in Memorial. They would do a very nice paniculectomy, and I mean the plastic surgeons would come. After that, then the gynae oncologist, they would give a midline vertical, not a fan and steel. They would give a midline vertical, finish off all the surgery, your para-aortics, this, that, and the other, whatever they want to address, because many of these patients have high-grade tumors, though more common would be actually low-grade in them. With obesity and all that,
Yeah,
low
well-differentiated
grade,
tumors
yes,
are more
yes,
common.
Yes. Low grade is more common. They would do that, and subsequent to that, the plastic surgeon would come and take over and all this. And we tried this in 2-3 patients also when I was in Rajiv Gandhi, and मतलब one तो was very very bad. उसका वो heal ही नहीं हुआ. They kept on trying, their VAP, SHAV, this, that, and the other. And though she was quite active, and most of them, they jump around like you would think.
After panic. Yes. Yeah, because of the drainage and all.
Is also quite a morbid surgery. It's not as simple as it looks, as if they'll just take away all this, and this it doesn't really. Though in another patient she was quite okay. So I mean, very.
So this is a good option, paniculectomy and open surgery, but otherwise, yes.
morbid obese, I mean, your patient, these morbid obese do have bad chest and cardiac issues, and so they are also difficult cases for MIS.
For MIS also, exactly. So what about lymphadenectomy? We've been, yes, sir.
More than 65, comorbidities, bad chest,
Radiation.
anesthetic says patient will not survive on the table.
Radiation.
There's an option discussed for brachytherapy, radical brachytherapy for this patient. And we just need a cervical dilatation and paracervical block, that's it.
Yes, sir, absolutely correct. And in fact, we have.
And in fact, the series now show 92% local control rates, which is even more than actually surgery.
So, okay, we have got now multiple
I would
options.
agree with him. I think instead of embarking on a surgery, which is going to be very morbid,
Yeah.
and I think better to go for radiotherapy.
So, but we tried building up the patient. The patient we could manage to.
Not many radiation oncologists will even do Benki first, because the whole exercise, huge, poor access. We did try.
So, okay, so here we have multiple options. We have MIS if she's stabilized, or open surgery, or radical brachytherapy, as I said. So, okay, great. So, what if suppose surgery, lymphadenectomy, sentinel, or systematic advantages of sentinel that we've been discussing?
Yeah, I think we've discussed all about
Yes,
that.
about the sentinel notes.
In interest of time,
definitely.
we'll not
Yes.
go over that.
So now even for high risk, sentinel is the method of choice. And what if sentinel is not available, Annapurna ma'am? How do you decide the extent of whether you'll go for pelvic, whether you go for pelvic para-aortic? What is the
So we
extent
go
of
back to
systematic?
pre-sentinel era, basically, how we
Yes.
were trained. So we will look at the size of the tumor, we will look at the myoinvasion, we look at the tumor tumor histology, and then whether any neck cell involvement is there, cervix involvement is there, and then take a call for a grade of the tumor, and then take a call for doing pelvic nodes. If pelvic nodes grossly are on positive on scan, we will go for para-aortic also.
So exactly, so with the pre-sentinel era, so in case if it's a high-grade disease, deep myometrial invasion, so in that case we'll go for this. So however, we did the patient, we took her for an open surgery, and this was the final histopathology. There was cervical stromal invasion was also present. So she ultimately was upstaged to a FIGO stage 2A if we go for the recent current guidelines. So now coming back to the questioning of the radicality of stage 2, Dr. Shruti, Dr. Parimala, anyone can answer.
Here, a good pre-op MRI would be a very good modality to guide us how to plan our surgery. But in this case, looking at her morbid obesity, I don't know how much we'll be able to do type 2 or a good radical hysterectomy. But ideally, when a preoperative MRI tells us cervical stromal involvement is suspected, then a type 2 radical hysterectomy should be done. If not, but our main aim should be we get a negative margin.
Exactly. Dr. Parimala, any difference of opinion?
Not needed, actually.
I would look at my oncology team actually. Basically, I do preventive oncology, but I agree with her. Yeah.
Any
I think,
difference of
no, I
opinion?
think large paper was published this year, 700 cases. They found that whether you do a simple extrafacial TLH or radical hysterectomy, it makes no difference at all. Absolutely.
Anyway, cervical.
Especially in this kind of morbid procedures, patients, I think, should not do it.
Yes, so if you just have to ensure that your margins should be clear, and you can even if your TH also gets you good clear margins, you can just go for a simple TH rather than do a radical hysterectomy.
And already indication is there for RT. So
yeah, so
she'll
therefore
anyways
the free surgical margins is what we have to just aim at. So
We have
what
to see that pathologists don't call us and ask where are the margins, what you have done.
Yes, MIS stage 2 is feasible. Yes, if we. Okay.
For surgery, patient is fit for anesthesia, definitely is an option.
Yes, okay. And so finally, however, IHC was done in this case, and there was loss of MSH2, and it was mutant. So, sir, what is about the adjuvant treatment, Dr. Umesh?
Yeah, it's a big challenge in this case to give adjuvant EBRT. But there is a case where if patient is younger, irrespective of P53 mutated or not mutated, and if lymph nodes addressed, apart from extensive LSI, we can offer brachy in such patients. But in this patient, we would err on external beam adjuvant radiation.
So both EBRT and VBT, yes.
No VBT in this case.
No VBT,
No,
only
only external
EBRT.
beam radiation, no.
Why do you want to give external RT when I think you have option of giving just brachytherapy, which is much safer here because the cervical stroma is involved, but there is no LVSI. In the absence of LVSI, grade 1 tumor, brachytherapy also should be good enough.
So there is very less data in the literature where you have brachyolone for stage 2. There's only one retrospective study from MD Anderson, and I think from the other center, 65 patients only, where they gave brachy. So we are talking about the treatment based on only 65 patients, but the data is more robust for external beam.
For the external beam
But one thing we can do is, as radiation oncologist, we can radiate lesser amount of tissue. That's called mini pelvis radiation, which we usually practice. Yeah.
Okay, small pelvis radiation.
Sorry? Yeah. So in this case, I would go for small field radiation. My upper border would be at the lower end of sacroiliac joint. So it's only the pelvic peritoneum where the surgery has been done. So which would cover only the medial part of both your vessels on both the sides. So it should be good enough. Yes. So and plus very important is IMRT with IGRT is very important, so that the toxicity is less. Well, hypofractionation is still area of research. It's not standard of care in post-op setting.
The most important absolute indication for external RT is presence of LVSI. Cervical stoma involvement per se is not an absolute indication. You have an option of brachytherapy, like I said, but we don't have a very good robust data for that. So I think you should keep these options in mind.
Both the options in mind.
Yeah.
Okay, and what are the implications of MMR deficiency in this case? We have already discussed, but sir, just to summarize.
Yeah, I think in this case, she has got MMRD positive, but mutated, MSH2. I think.
MSH2, loss
Then you
of
must think
MSH2.
about Lynch syndrome, I think. This and she would require a counseling. Familial counseling is very, very important.
Yeah. And
More important is no chemo. More important is no chemo.
immunotherapy, if suppose if it comes later on, and also the prognosis also we can tell in for recurrence immuno is, and also we can also counsel them regarding the intermediate immune checkpoint inhibitors, pembrolizumab, and even prognosis also intermediate prognosis we can counsel them regarding the prognosis. That's it for cancer endometrium. I think I'll wind up, ma'am. Okay. Thank you so much. Thank you so much, ma'am. Thank you. Thank you all the panelists.
Thank you so much, ma'am. To proceed with our next speaker, I would like to call Dr. Rashmi Rekha Bora, ma'am, Senior Consultant, Department of Gynecology, Fortis Memorial Hospital, Institute, Gurgaon. Please, ma'am. Very good afternoon. I think we are running behind schedule, so I'll quickly go through the slides. This is a case from Department of Gynae Oncology, FMRI, Gurugram. Now, this is of a patient who's a Mrs. X, 49 years old, with no medical comorbidities. She had presented with the complaints of pain lower abdomen for 7 months along with indigestion. And on examination per abdomen, there was no ascites or clinically any mass felt. On per vaginal and rectal examination, she had a large mass in the pelvis, which was incorporating the uterus, which was approximately around 7 centimeters. The investigations done showed a CA125, which was high, 224, and 19.9, and CEA were normal. PET-CT had shown a large mass in the adnexal region, and there were deposits, peritoneal deposits in the POD and pelvis, and there was large upper abdominal disease. Basically, there was FDG avidity in the around the stomach, pylorus, and duodenum. Her upper GI endoscopy and colonoscopy were normal. We had got a BRCA1 and 2 done, which was negative. An ultrasound-guided omental biopsy was done, and it showed a papillary adenocarcinoma of the female genital tract. PAX8 was positive, P53 mutant, and WT1 was strong and diffuse positive. So these are the microscopic pictures where PAX8 is positive, WT1 is positive, and P53 mutant. Now, an impression of high-grade serous carcinoma endometrium, stage 3C, because a metastatic workup showed upper abdominal also. So now the question, next question is to the sir, ma'am, Rupinder ma'am and sir. Would you go ahead with the neoadjuvant chemotherapy or a... Okay. So we did go ahead, it was discussed in tumor board. We went ahead with neoadjuvant chemotherapy. Response evaluation was done, and 3
cycles of neoadjuvant, carboplatin, and paclitaxel, which she got 3 weekly. Now, we repeated her PET CT after the, I'll just show you the pictures. Oh, okay. The pre-chemo and the PET chemo, PET CT, there was an increase in the disease after neoadjuvant chemotherapy. The bulk of the disease in the upper abdomen increased, and there was negligible decrease in the abdominal ovarian masses, but the other increased. So an impression of early progressive disease was made. Now, in this setting, now my next question would be like, what would be your next line of management? Okay.
Can we add bevacizumab?
Yeah.
Bevacizumab.
That was done,
Yes.
and a high-grade carcinoma was confirmed.
We did evaluate again the biopsy slides, which was done in fMRI only. And they went and looked back at the slides and they said it is a high-grade serous again. So anybody for a change?
No,
What would your next management?
High-grade serous cancer, not responding to chemotherapy, obviously she's not going to do well. So only option I think I would consider is try and do surgery. If it is possible to do a complete debulking, then I think only something we can be done.
Yes.
So I think better go for surgery. Better do a diagnostic laparoscopy and then try to go for a surgery.
This kind of picture with no ascites with peritoneal disease, very unlikely for HGSOC that we see normally.
Yes.
So
this
the
is-
value of CA125 is also quite low, just
Yes,
224 with
225.
so much of peritoneal disease and extra abdominal, inside the disease uterus.
Yes, so this is what we also thought. And we went ahead with surgery this time. We did an interval surgical cytoreduction with modified posterior exenteration, rectosigmoid anastomosis, distal gastrectomy because there was a mass in the duodenum, first part, with gastrojejinostomy, jejunojejinostomy, diversion loop ileostomy to no gross residual disease we were able to achieve. And the final histopathology is something very different. Now we have disease everywhere, but this time the P53 was wild. WT1 positive, so an impression of low-grade serous carcinoma of the ovary was made. The slide and blocks were reviewed at Tata Memorial Hospital, which also showed low-grade serous carcinoma ovary. Now the question would be to Dr. Preeti, I mean, do we see such kind of discrepancy, or do we see such kind of cases when a high grade can go into a low grade?
Basically, we all know that low-grade and high-grade serous carcinomas are two totally different tumors with totally different molecular pathways. However, it's now a well-known and accepted fact that there are some tumors which are though less than, 2 to 3% of tumors, which can show a mixed low and high-grade component. The largest series is from the Mayo Clinic, which was published in 2019 in a pathology journal, where they examined 650 ovarian tumor cases, and out of which they found 450 high-grade serous carcinomas, 30 low-grade, and 20 cases were there which showed both low and high-grade features, and they call these as indeterminate for grading of the serous carcinoma. They further analyzed these 20 cases, and they found that they had P53 mutation was found in 4 of these cases. One case showed a KRAS mutation and one BRAF mutation. The remaining 14 cases do not show any of the mutations known in both the low and high-grade cancers. So they concluded that these are some totally different tumors with a totally different molecular pathways, and this needs to be further studied. So coming back to this case, I think this is one of those cases which showed both low and high-grade areas, and probably the high-grade component did respond to the chemotherapy, and what was left behind was the low-grade component. Yeah. No, like this was, the P53 was wild type in this case, on the second one, but the initial one was mutant. Yeah. Usually tumor signature doesn't change, but heterogeneity in the tumors, yes. Heterogeneous with both low and high grade areas. Yes.
Okay, and the next question would be, what would be the adjuvant treatment in this case? The adjuvant treatment to the house. It's open to anybody who want to.
I think low-grade serious cancer, I think the NCCN guidelines recommend chemotherapy. But in this case, we have seen that it is not responded to chemotherapy at all. And even our real-time experience says that chemotherapy is of no use. And again, one last study was published this year, which says that whether you give chemotherapy or not, low-grade chemotherapy survival is not altered. Okay, so I would not prefer chemotherapy again, but this is a different case. This is a component of high grade and low grade, both.
Yes, ma'am.
Yes. Because they say that in such tumors, if
The ER was 90%.
yeah, but if
PR
is
was
negative,
negative.
yeah, if PR is negative, then there's no point in giving them letrozole or anything. They do not do well. They do not respond. Yes.
ER is 90%.
ER is 20%.
ER is 90%. PR was negative.
Then she would respond to anastrozole.
Yes. Yes.
Can respond.
When they say that if the PR is negative, even though the ER may be positive, there's really no point in giving them anastrozole and all of that. Logically speaking, this tumor only should not be there.
ER 90%. If the ER was 20-30%, then they may not respond, but 90%.
Okay. So, I think because of lack of time, we'll not go ahead because this patient did recur also, but we'll not come to that part then. Ma'am, should we wind up here? Take care. Okay, thank you so much to all the panelists. Thank you, everybody.
Thank you so much to all my expert panel. Really, thank you. Thank you for every minute, and I feel gratitude in my heart.
So thank you all on behalf of the organizers. Here we wind up the session of the Gynec Onco at Fortis Cancer Summit, and a big applaud to all the speakers as well as all the panelists. And I think with this, thank you all. Can we all gather here? Just whosoever is there in the hall, just please come in the center just for a click, and then we just disperse.
Good afternoon, everyone. I would like to proceed with the next session. So we'd like to proceed with our next session of gastrointestinal oncology session. we have to start our next session, ma'am. Sorry, we are really sorry. So I would like to call. Sorry, ma'am. No, we are really sorry. We have to start our next session. I would like to call on the stage our session director for gastrointestinal oncology session, Dr. Rajat Bajaj sir, consultant department of medical oncology, Fortis Hospital, Noida. Dr. Manish Doshi sir, senior consultant department of surgical gastroenterology, Fortis Hospital, Bangalore. Dr. Ravindra BS, director and HOD department of gastroenterology, Fortis Hospital. I request sir to give brief introduction of our session. Please sir.
Dr. Rajat Bajaj, Dr. Ravindra. Okay, welcome to the GI oncology session. I'm Dr. Manish Joshi, a surgical gastroenterologist, and just to see this entire gamut of people here, the specialists here, the surgeons. How many of you are surgeons here? If you can raise your hands. Fantastic. Probably this is a peek into the future where surgery and the role of surgery is going to shrink further and further, and the medical onco and the radiation onco is probably going to be the mode, or the non-invasive treatments are going to be the mode. So let's try and look at the newer advances in GI oncology. We have interesting sessions on HCC, pancreatic nets. There are going to be discussions on pancreatic cancer, but we first begin with the robotic Whipples video demonstration because Dr. Rudra Prasad from Mohali, he has to catch a flight. I'll invite him first. I just want all the discussion to be in one direction. Whenever we talk to a patient and we say about counseling about any particular GI oncology treatment, for want of a better example, we end up like Russia trying to invade Ukraine and trying to come out in 2 weeks. And 2 weeks becomes 2 months, and 2 months becomes 2 years, and it keeps going on and on. So probably we'll look at specificity, we'll look at future trends, but I'll invite Dr. Dule to show his robotic Whipples video demonstration. And I'll invite the chairpersons, Dr. Dinesh Pendarkar, Dr. Sushma Agarwal. And Dr. Jeba Singh Joseph from Rela Hospital, Chennai. Dr. Anil Kamath, Department of Surgical Oncology, Apollo Hospital, if you can join us. Dr. Pawan Sagur from Kidwai Memorial, and Dr. Jitendra Rohila from Fortis Hospital, Mohali. And I'm sure Dr. Jagannath Dikshit and the rest of the people can also interpret at the end of the session.
Thank you very much, organizers and chairpersons and the faculty and delegates. So today's our topic of discussion is robotic Whipples, which are video demonstrations. So within a short period of time, it's very difficult to explain everything about Whipples procedure because it's such a complex surgical procedure, but I will try to explain the important steps within the short period of time. So our intense case was seen by a gastroenterologist who diagnosed the patient to have obstructive jaundice because of choledocholitis and cholelithiasis. So endoscopic biliary clearance and biliary stenting was performed, but however after 2 months patient again developed recurrent jaundice. So repeat endoscopy showed periampulated growth and biopsy showed adenocarcinoma. So once the disease was confirmed to be a localized disease, the patient was referred to us for surgery. plan is present for robotic Whipple's procedure. Normally, for this procedure, we place the patient supine with 20 to 30 degree head up so that the transverse colon and the greater omentum falls down. And the four robotics ports, this R1, which corresponds to the mid-clavicular line, which is a working port, and R2 is the camera port, just left of the umbilicus. And R3 is the working port, and R4 is also again working port. And the A1 is the 15 mm of 12 mm assistant ports, and A2 is the 5 mm assistant ports, which is optional. So I start my dissection by lifting the greater curvature of the stomach and dividing the greater omentum, gastrocoral ligament. I continue dissection till the hepatic flexure of the colon is taken down. So once the hepatic flexure of the colon is taken down, I clip the right gastrocoral trunk and divide it. So once this is done, so I open the lesser omentum and clip the right gastric artery and prepare the stomach to divide it. So the right gastrocolic artery is being divided, and after that I divide the stomach just near the entropyloric region. So once the stomach is divided, I create the tunnel behind the neck of the pancreas, between the pancreatic neck and the supramesenteric vessel vein, and which can be easily identified almost by following the gastrocolic trunk, or just remain left of the right gastrocolic trunk. And almost most of the time it is by someone's experience. So this is the trunk tunnel can be appreciated, and I put a gauze bridge. And once the trunk is made, by shift the dissection towards the superior border of the pancreas, just to isolate this common hepatic artery. We can see the common hepatic artery and the gastroduodenal artery, GDA. So at this point of time, I normally clip the GDA, but however there was some oozing, so I just put a gauze bridge here and shifted my dissection towards the coccygeal of duodenum. So we can see the IVC behind the D2. So once the coccygeal of duodenum is completed, I just continue to mobilize the proximal part of the jejunum, just pulling it up. You see the mesenteric region divided to prepare the jejunum, proximal jejunum to divide. So when the mobilization is completed, then I again came back to clip the gastroduodenal artery. We can see the appreciate proper hepatic artery and the common hepatic artery and GDA origin. So once it is clipped and divided. So once it is GDA is divided, then I continue with the transaction of the pancreas at the neck. So for pancreatic transaction, I use the monopolar scissor, and we can see the pancreatic duct. So when the pancreatic neck is transected, I go to continue with the division of the jejunum and division of mobilization of pancreatic ancillary process. We can see the pancreatic supramesenteric artery behind the supramesenteric vein. It's very important to remove completely the pancreatic ancillary process of pancreas for tumor-free margin. And the pancreatic head and neck is completely transected. Once this is done, I mobilize the gallbladder gallbladder is completely mobilized and there's a cystic duct and bile duct junction. So at this point of time, I divide the bile duct. Now we can see the loss of the sludge and debris coming out of the bile ducts, and there are stones in the bile duct also. Now once the bile duct is divided, now I'm preparing the pancreas stump for anastomosis. At this, one should not mobilize the pancreatic too much because it may devascularize, which may increase the post-operative pancreatic fistula. So normally I do the pancreatic resection in 2 layers, posterior continuous layer. I use 30 V-lock for the posterior layer. The posterior layer is being completed. I do the enterotomy for ductal mucosal anastomosis. Normally, the posterior layer of the ductal mucosal anastomosis, the sutures are placed and tied. And normally 6 to 8 sutures are sufficient according to the size of the pancreatic duct. Fortis anastomosis, I use 40 PDS sutures, monofilament. For anterior layer of the ductal mucosal anastomosis, I normally pre-place the sutures and later on all the sutures are tied after putting the PJ stent. The anterior layer is being tied and PJ stent is being placed. hepatic jejunostomy, which is done around 10 centimeter distal to the pancreatic jejunostomy side. And I use 40 Velux suture for hepatic jejunostomy. Yeah, yeah.
Can I have one or two questions from the audience if there are any? Since I have a question or a comment, Dr. Dole is one of the few surgeons in India who is running a successful robotic Whipples program. So for the beginners, what cases would you suggest to begin with for a robotic Whipples? How do you select your cases?
See, for beginners, I think periampullary carcinoma without biliary stenting, without cholangitis and small tumors is ideal. And if you are experienced enough in doing Whipples procedure, then any case you can pick up. Once you are familiar with the anatomy and everything.
Thank you, Dr. Dole. Very nice presentation of a complicated case, post-cholangitis. If there are no more questions, we can proceed to the next session.
Thank you very much.
So now we move on to the next session, that is harmonizing expertise, navigating HCC.
Sorry, ma'am. We actually made a little bit, for the convenience purpose, changes in the schedule of the. Please be seated. I would like to invite on the stage Dr. Bhavna Sirohi, Senior Consultant, Department of Medical Oncology, Raipur. Her topic of presentation is state of the art care in pancreatic cancer. Please, ma'am.
Good afternoon, everyone. Thank you to the organizing team for inviting me. So can you put my slides up? So I'm going to talk about state-of-the-art care in patients with pancreatic cancer. I have no interests to disclose. So looking at the treatment paradigm for patients, we have localized, and in localized pancreatic cancer, we have resectable, borderline resectable, and locally advanced. And I will just briefly touch upon this. I will mainly discuss systemic treatment options. And in patients with advanced pancreatic cancer, we have oligometastatic disease as well. And I will not touch upon that because the evidence is not robust there. And of course, the disseminated disease as well. Most of our patients with pancreatic cancer are elderly. Some of the key milestones that we have achieved over the years, this just shows the timeline. If you can see in localized and resectable pancreatic cancer, from median overall survival of 19 months, we have actually gone to 54.4 months by doing the state-of-the-art treatment, surgery, systemic treatment, and in some instances, radiotherapy as well. All of these have led to improvement in survival, and also in patients with advanced cancer, you can see that things have got better, but not as better as we would expect it to be. Gemcitabine remains the mainstay of treatment. This was the pivotal study which showed that it is better than 5-FU. Of course, this has not been compared with S1, which is now available in India, and all of us are using it quite frequently in our patients, which also is an amazing fluoropyrimidine. Adjuvant treatment over the last 3 decades, mainly the ASPECT trials and the CONCO trials, we know that the median overall survival stayed stuck at 28 months. But I think we had 2 studies in patients with advanced pancreatic cancer which showed a new standard of care, FOLFIRINOX, modified FOLFIRINOX, and gemcitabine nab-paclitaxel, published more than a decade ago. And we brought it into the adjuvant setting, the PRODIGE 24 trial, which was, I think, immediately after we came back from ASCO that year. This was one study which we implemented back in our clinic immediately, even before it was published, because to have a median overall survival of 54.4 months was absolutely amazing in our patients. The standard of care arm was gemcitabine. APACT trial was adjuvant nab-paclitaxel plus gemcitabine. This actually did not achieve its primary endpoint of better overall survival, but we know that this is an effective regimen. The studies were slightly different, and I won't get into the details because of paucity of time. So I think for adjuvant setting, FOLFIRINOX remains the standard of care. It doubled the disease-free survival. Advantage was seen in all patients. I keep getting asked in R1 resection pancreatic cancer. I think most of our patients have an R1 resection if you go back and look at the pathology. All these patients were included. Stage 1 patients were also included, and there was benefit seen in all of them. And none of these patients actually had radiotherapy. So I think adjuvant radiotherapy is not indicated in patients with pancreatic cancer. But again, it only works in patients who have a good performance status. And so I keep getting asked, if patients don't have a good PS, what would you give? I would suggest that we go with gemcitabine, capecitabine. Slightly nervous about giving gemcitabine nab-paclitaxel given that the study was negative. But again, that remains an attractive option, or gemcitabine alone as well. I will just briefly touch upon neoadjuvant in resectable pancreatic cancer. I was a huge proponent of it, and I just was on Twitter. I just saw Manish Bhandare tweeting about it, about one of the studies that I will talk about. So this study looked at the two most effective regimens, modified FOLFIRINOX and gemcitabine nab-paclitaxel, and their primary endpoint was a 2-year overall survival, which was more than 58%. And basically, this study showed that it did not meet its primary endpoint. And there was another study which was presented last year at ASCO, the NORPACT study, and which again randomized in patients with resectable pancreatic cancer into neoadjuvant FOLFIRINOX and surgery, and followed by adjuvant. So 60% of the patients had severe toxicity in this trial. I don't think they used modified FOLFIRINOX, which most of us use, where we actually remove the bolus 5-FU and slightly decrease the dose of oxaliplatin. The study was negative. In fact, patients who had upfront surgery did better. 30% of the patients did not undergo surgery, and I think the argument on Twitter that was going on was that probably these patients should never have undergone surgery. So, and again, there is Dr. Srikhande, who's again arguing for upfront surgery. And I think right now, the way things stand, patients with resectable pancreatic cancer, they should go for upfront surgery, even though we say that, pancreatic cancer is a systemic disease. So patients who are not candidates for modified FOLFIRINOX, 6 months of gem or gemcitabine, capecitabine alone can be considered. Ongoing trend is neoadjuvant chemotherapy in borderline resectable and locally advanced patients with pancreatic cancer. But again, if you feel that the patient is resectable upfront, should undergo surgery. Coming on to patients with advanced pancreatic cancer, again, very briefly, these are the two main regimens, which showed that the overall survival used to be 6 months for patients with metastatic pancreatic cancer. With FOLFIRINOX, it touched 11.1 months. So again, this was very exciting, and we brought that into the adjuvant setting. But there are a lot of toxicities attached to it. But again, as medical oncologists, we have become better at managing the toxicity by modifying the dose of FOLFIRINOX that was used in this pivotal clinical trial. There's a new regimen on the block now. This was presented at GI ASCO as well by Dr. Eileen O'Reilly's group. And this is basically replacing irinotecan and FOLFIRINOX with nanoliposomal irinotecan. And also they've reduced the dose of oxaliplatin from 85 milligrams per meter square to 60 milligrams per meter square, and showed that this is quite efficacious. This was a positive trial with a median overall survival of 11.1 months, which was the benchmark set by FOLFIRINOX, and better overall survival and better disease-free survival as well. So I think this is a very good option, but liposomal irinotecan is very expensive. So for most of our patients, I would think FOLFIRINOX is a very good option. For maintenance treatment, olaparib for patients with germline BRCA mutation or even PALB2 mutation now, patients who have had a platinum-sensitive germline BRCA positive pancreatic cancer, this should be considered, though I must point out that there was no overall survival benefit seen with olaparib, and olaparib is a very expensive and a very toxic drug. If you look at the fatigue, 60% of the patients are not able to actually have a good quality of life. They are tired all the time, nausea, diarrhea, anorexia, and of course the red blood cell transfusions. All of these are real world issues. And most of our patients actually, in my experience, don't get on to olaparib because by the time you get them to 16 weeks of platinum, they have started progressing, quite a few of them. Looking onto the expanding targetable mutations in patients with pancreatic cancer, first line, of course, we have BRCA1, 2, and PALB2. But in second line, I think the KRAS wild type story is really expanding in a nice way because we have drugs, sotorasib, adagrasib, against KRAS G12C and G12D mutations. And in wild type KRAS, you have other fusions, the NTRK, NRG1, HER2, BRAF. So all of these open up the avenue for precision oncology. And of course, we do MSI testing in most of our patients. And if the MSI is high, which is about 1% of patients, I think I've had only one patient who's had an MSI high pancreatic cancer on all these years. So again, this KRAS story is quite interesting, but I would suggest that when you do an NGS in your patients, very important you go back to it and also discuss it in a molecular MDT. We have a molecular MDT every Friday from 5 to 6, and any of you who wants to join in is most welcome to send cases. We have expertise from all over the globe in that MDT, and of course from India as well. Immunotherapy has not done very well in patients with pancreatic cancer. Of course, we have one or two patients we've treated with immunotherapy who are PDL1, very high CPS score, or MSI high, or a tumor mutational burden which is in 70s or 80s. So those are the patients who will respond very well to immunotherapy. But majority of our patients, because of the various reasons, dense fibrotic stroma and the microenvironment that pancreatic cancer has, do not respond very well to immunotherapy. So I just wanted to show this paper. This was published just this week. And I was listening to the AI talk in the Precision Oncology platform. I actually, when I see a mutation before the molecular tumor board, put it on ChatGPT. And I get amazing answers back as to, what should be tried. So this is, I think, the future, because we do need biomarkers to guide treatment decision-making. They looked at the blood and tissue sample. This is CEDAR-Senai study, 74 patients with pancreatic cancer. And using AI modeling, they were able to predict pancreatic cancer survival. So I think this is where we are heading towards. And I think from India as well, we need to generate this kind of data for our patients. Should not forget supportive care. Exercise, very, very important in all cancers, and it mitigates distress, fatigue, everything, muscle loss. Pancreatic enzyme replacement therapy, you must not forget, especially when you have patients with advanced pancreatic cancer who keep on losing weight, but their cancer is responding. You need to do a stool elastase test, or just simple questions like stool floating, and start pancreatic enzyme replacement therapy. Primary thromboprophylaxis, I have started using this because I've had, over the years, patients presenting with sudden PE or suddenly dropping dead, getting up in the morning, going to the washroom. It should be considered in patients with advanced pancreatic cancer. And with the NOACs, I think we can start them on lower dose. Effective pain control, very important. So I think I've discussed most of this. You must do germline and somatic testing in all patients with pancreatic cancer, especially germline, not only for the family's genetic predisposition, but also you have a treatment avenue available. I would encourage you to enroll patients in clinical trials. Thank you.
Thank you, Bhavna.
Many of our patients present with obstructive jaundice, and some get PPDD, some get stanting done. So the bilirubin gradually goes down. It has been a stunted done, so there's some amount of cholangitis which is there. How early you start FOLFIRINOX in a metastatic PA cancer?
So as long as I see a downward trend and patient has no fever, And I would do a CRP also or a Procal in that patient. And if there is a downward trend, if the bilirubin goes below 5, that's when I usually start. And irinotecan I would add in the second cycle. I would start with Folfox and then add irinotecan in the second cycle. In the So BRCA, and I would suggest doing PALB2 as well, because there is data to show that it works in PALB2 mutations as well. So BRCA1, 2 and PALB2. D. So that story is still evolving, and there are some experts globally who are doing a lot of work on it. And I tend to tap into them. And some of these drugs are available on compassionate use as well. So we were able to get it for one of our patients. And I think, if you have a patient with that, you must discuss it with your colleagues around the country and see whether you can get access to compassionate use drug. So it's part of the NGS profiling. So I have no clue. You have to ask a molecular pathologist. So there is an association that has been talked about, but again, it does not have any clinical implication for us to, use it in the clinic. So that's why the story I have not discussed here.
So I think we have to stop this session, and any questions can be asked to Dr. Bhavna later on. And we move on to the next session, and I invite Dr. Ankur back.
Sorry, ma'am. To start with our next session, I would like to call on the chair, Dr. Dinesh Pendharkar, sir, Director and Senior Consultant, Department of Medical Oncology. And Sushma ma'am is with us, Dr. Sushma Agrawal, Professor, Department of Radiotherapy. I would like to call Dr. Ankur Bhal, sir, to moderate our session on harmonizing expertise navigation HCC with a multidisciplinary edge.
Thank you. And may I call my esteemed panelist, Dr. Vijay Shetty. Vijay is a medical oncologist from Chennai. Dr. Sridhar PS. Dr. Sridhar PS. Yes, sir. Sridhar is a radiation oncologist. Dr. Pramod Kumar. Pramod is a hepatologist and is a liver transplant physician as well. Dr. Srinivas BG. He's not here. And Dr. Vinayak Makka. So we have a radiation oncologist, we have two medical oncologists, a radiation oncologist and a hepatologist. So we have esteemed surgeons with us. So a tumor board is formed. Okay. And we have a nuclear physician, madam, also sitting with us. So Dr. Ishita Sen is here. We have Saurabh Arora, intervention radiologist also. So yeah. So these are my disclaimers. I'm contracted by Roche. So objective of this panel discussion, which is just 10 minutes, is to see and understand patient journey, and does patient journey impact its survival in a particular hospital or not, the rationale behind taking each therapy, and when to exactly switch from loco-regional to systemic therapy, because at times hepatocellular cancer is not advanced, but whatever localized is not small also. So we have to take a decision, and we will touch upon etiology, outcome of HCC, whether it changes our treatment decision in the era of immunotherapy and the era of TKI. So Dr. Maka, since you come from a academic institution, which is Manipal, how does a journey of a hepatocellular cancer is there in your institute? Like if a patient of hepatocellular comes to the compound of hospital, who will navigate him where? with all conflicts of interest which you are aware of?
So I think in our center, usually gastro is a main referral for hepatocellular carcinoma, and two people are involved along with gastroenterologist, us, as well as intervention radiologist. So we don't have MDT where we have all three of together sit and discuss. So usually it comes to inoperable or patient who cannot be eligible for local therapy to us. So they have already decided before. So very rarely when we found some patients who come to us with the imaging defined criteria. Otherwise it's that's it.
No, if a patient comes to me with a hepatocellular cancer, everything is being done.
Yeah.
AFP done, they have a lesion in the caudate lobe, one lesion in the fourth lobe, portal vein is thrombosed, and I take the scan and run to Dr. Ishita, and then Dr. Ishita calls Saurabh. So there's no physical tumor board in a hospital every time available for everybody, but yes, hepatocellular is a disease where I think I have to use my bus, 11 number bus, go to this station, call him, go to this station. Whosoever is senior, junior, we have to acknowledge that as well and come to a conclusion within 10-15 minutes that what is the further plan for this patient. I suppose it is happening in each and every hospital.
Yes.
So, hepatocellular cancer is a multi-collaborative effort, and wrong decisions, not wrong decision, but not an appropriate decision, the sequences, which is very important in hepatocellular cancer, at what time probably the load is so less at times in a hospital that one has to learn what other is doing so that they can come to any summit like this and tell their experience. So medical oncologist, I don't think is the main man here. Gastroenterologist, yes. Hepatologist, yes. Intervention radiologist, very, very important. Radiation oncologist, a general surgeon, intervention radiologist, and a nuclear physician. They all are important members to just set the stage, because my scoring, my child book scoring, their MELD scoring, the criteria of resectability, if a liver surgeon is not there, for him it is operable, and somebody's have to stop him and somebody has to push him for all these things. So a multidisciplinary system is required for the best outcome of patient of hepatocellular cancer. So start with the patient, a 60-year-old, history of hypertension, diabetes, coronary heart disease, and alcohol-related cirrhosis for 5 years, Mr. X. And he was diagnosed with HCC, 6 centimeter mass in segment 5 and segment 8 on a triphasic CT. So Dr. Pramod, so CLDs, your OPD is filled with CLDs. So he was diagnosed with alcoholic liver disease cirrhosis 5 years back in 2018, and now he has segment 6 and segment 8, segment 5th and segment 8 CT scan showing mass. So how often you must have told him about HCC, and or how often hepatologist tells about HCC when the OPD is filled with cirrhosis, ascites and all?
We do discuss with the patient when they first come to us with decompensated CLD, or in fact any viral related compensated cirrhotic patients also. We usually educate regarding the HCC screening with them, like 6-monthly AFP and ultra. Yeah.
6-monthly AFP and an ultrasound
abdomen. And if the patient has any NASH related cirrhotic, and if he is obese, we are tend to get an MRI 6-monthly depending on the.
Okay, so you're not getting once a year CT scan for such patients?
Usually no. Again, depends on the AFP value. Okay. If it is on upward trend, and usually then only we get triphasic.
The guideline says ultrasound, or the guideline says CT scan?
Again, depends on the expertise available at the hospital. If patient is obese, ultrasound sonologist likely to miss any small lesion. In that cases only usually get a cross-sectional imaging.
Okay.
Not in all patients.
So panel, any panelists want to comment on this? Is ultrasound okay to be done, or once a year CT scan should be done for a cirrhotic patient for a good surveillance?
So CT will be more sensitive in picking up, but again, having said that, how many of the patients will be willing for getting a CT done very often? So realistically, we would want to get a CT, but I think a patient usually tends to went towards getting an ultrasound, which is more convenient to get it done. So, but like my co-panelist said, if the AFP is on the rising trend, we'll probably want to get a CT done rather than ultrasound.
Okay. Usually we tend to get baseline cross-sectional imaging when the first present to us. Then we follow up with ultrasound.
So, so investigations for this patient, like a triphasic CT scan has been done. Anything else would you like to do? Any biopsy?
Usually no.
Alpha fetoprotein is 1500. So I express the question, who are the patient of HCC in which you would recommend biopsy? What are those features on radiology by which a biopsy would be considered for such patients?
Usually if the tumor is not characteristic in the imaging and any atypical in the imaging ways, then only.
To PIVCA, then if you don't have access to PIVCA, then definitely a biopsy.
So you want to basically cholangiocarcinoma is in your mind. Mixed variety of HCC or cholangiocarcinoma is mind. There's some scalloping of the diaphragm. So then we should do the biopsy. You want to do a biopsy for any NGS testing or any?
So So basically, now there's a lot of data coming in where if you have a baseline FGFR mutation or a CDNK2A amplification, so the combination of IO and bevacizumab may not do as well.
Yes.
So in those kind of scenarios, but we are not doing it as of now. But I think we are aware of it, and maybe we should get it done.
So I just to be differ here. So as an oncologist, that is what you are discussed is a classical indications or a book descriptions what you have done. I think everybody who practices oncology knows about that. So I'm a radiation oncologist and a cybernetic specialist. So each patients require some intervention in terms of like biopsy. We usually put a fiducials. That time, all patients we insist that biopsy is to be considered, and including the PET CT scan in this particular case is the one what I would prefer to get it done. So, and there is no contraindications to biopsy.
So I'm emphasizing on biopsy because what we have been learning that no biopsy is required in hepatocellular because alpha fetoprotein is secreted. It's changing. It's changing because to know a biomarker, it was fixed. Ideas were fixed because we had only one drug which was sorafenib. Now we have options of TKI, options of IO with targeted therapy and dual IO therapy as well. So, and the nature of HCC is also different. In hepatitis C and B, CLD is something different. CLD of an alcohol is something different. CLD of NASH is something different. So, and these patients, we know from the Nature publication that NASH and alcoholic liver cirrhosis does not have that immune surveillance. And you're spending the cost of one cycle of atezo-bev is close to 4 lakh rupees. And if it doesn't work post 3 cycles, so the biomarkers are there, even a simple biomarker, beta-catenin, calretenin, the ratio, these are all lymphocyte depleted, lymphocyte rich. These are various pathologies of hepatocellular cancer, which can at least tell that this is a cold tumor and this is a hot tumor. So how to choose IO and TKI or how to choose a combination is an important for these patients because they will die. They will die in 10-15 months. You want me to stop? I can. You are not even started. But I can take 2-3 minutes more. I'll straight away come to a point. Okay, so my question to panelists, my question to Dr. Sridhar is.
Can you just go back?
I'm just stopping. Just discuss this because this is a multicentric HCC, all the lobes, small lesion, and the portal vein thrombose with ascites.
So here actually the hepatocellular carcinoma is a VIPGAR, like you have an extremes. The roadmap has to be very clear and what actually you want to achieve. So it is a curative intent or a non-curative intent. So portal vein thrombosis, one, and you have given me a picture of a miliary pattern.
Yes.
Definitely there is no role of SBRT in this case because I prefer an systemic treatment upfront. Ascites is a non-metastatic ascites, is nothing to do with.
You want to waive SBRT to the portal vein, my question is this.
No, not in this case of a multiple lesions which is there in the.
So tell me
right
a
now.
case where.
So where, it's simple example, the number matters here, up to 5 lesions, even in a multicentric, or any lesions up to 5 centimeter, or a single lesion up to 10 centimeters, as a clear-cut indication for SBRT, liver-directed therapy. Portal vein thrombosis may be of a different stage by itself. One is bridging for the transplant, treat the primary and the portal venous PVTT, so that you have a time to do a transplant whenever it is required. So any of this borderline up to locally advanced HCCs, your aim should be liver transplant in the future. So that's a curative intent. Any patients which is non-curative intent, for a local disease, definitely an addition of systemic treatment along with the multiple sessions or PVTT or a local disease SBRT is possible. That is the second indication what I am talking.
So doesn't portal vein thrombus makes a contraindication for transplant?
So that was in the past. Any transplant surgeons? So no, at what time?
No, I'm not talking about MPV, main portal vein. It's a
So per se it's such. So in a downstream of after 6 months to 1 year, there is no disease left, but we may get to the stage.
The concept.
So that is another thing. In a case of liver disease, there is only liver-directed therapy. If it's successful, it should be checked every 3 to 6 months to go to a curative intent.
Okay. So two more questions. So we have three medical oncologists with us. NASH, metastatic treatment of choice. Child book A.
So I would give IO plus BEV, but again there's data supporting use of lenvatinib in that. So patient who cannot afford lenvatinib.
Both are category 1.
Yeah.
So how will you choose? What is in your mind?
So in my mind, IO plus BEV, Atezo-BEV, because that has shown a longer median PFS of 19 months in the trial, IAM-BRAVE trial. So I would give IO-BEV, and if the patient is a candidate for transplant, that can be used as a bridge for transplant. You can always keep transplant in the back of your mind. If you are planning, that can be one way to look at it. Otherwise, if a patient cannot afford that, I would start with lenvatinib.
Dr. Manga, hepatitis C related.
So viral thing we prefer IO thing, but most of the patients are very practical, like not academic discussion, but they prefer to use lenvatinib or both them are equal, as you say, category 1. There is a school of thought that viral induced carcinogens are more receptive to related, but I have not seen my personal experience. In fact, I have not seen less of viral hepatitis positive. It's not a most common practice, that is what I see. Most of them are viral marker negative.
Okay. Yeah, please.
Just one point. Dr. Sridhar is a major proponent of SBRT. But if you look at the guidelines, still any tumor which is more than 9 centimeters, the first line of therapy is still a tear, which is considered. In a smaller tumor, a case, and in a larger tumor, a tear. So liver-directed therapy, whether it is case or tear, still has got a very high evidence of getting a good progression-free survival. In fact, in some cases, even as a bridging to transplant in patients with large tumors. So I think we are not talking about liver-directed therapy enough because we are kind of moving to SBRT, right? But I think there is still a lot of scope for doing this.
No doubt about that. See, what I'm trying to tell you is liver-directed therapy, whichever is available, is not. I prefer one line of treatment. So that is, it is not like that one part, no, you don't want to see the jury. It is already there. So what we want to take it is the one what we is always.
have time? She doesn't have time. I'm so sorry. I mean, this discussion should have been a half an hour or a 40 minutes discussion, but whatever we discussed was still worthy. Thank you so much. Thank you so much.
We are extremely sorry, sir. Thank you so much to be here, and I would like to proceed with our next session. There is a debate. I would like to call Gaina ma'am on the stage, Consultant Department of Nuclear Medicine, Fortis Hospital, Bangalore, to moderate the session.
Good afternoon. For short of time, I'll just sweep through. So the debate what we are having today is an interesting one. It is pancreatic neuroendocrine tumor. How do we treat? Whether it is peptide receptor radionuclide therapy versus systemic therapy. To debate on for PRRT, we have our own nuclear medicine physician, Dr. Randir Mantri from Hyderabad. And to debate on systemic therapy, we have Dr. Bhavesh Parekh from Ahmedabad. And I would like to invite the subject matter experts, Dr. Durgatosh Pandey, Dr. Mansi Shah, and Dr. Jitendra Rohila, to come on the stage, please, for the discussion.
Good afternoon. At the outset, I thank Dr. Ishita Madam and Dr. Gayana for inviting me here. And I know I am between your lunch and this thing. So I'll see that less of academy and more of fun is there in this. But I'll make my point and it should be clear. PRRT is for metastatic, I don't know why it's not. Yeah, PRRT for metastatic NETs. NET is not a disease, it's a spectrum from non-functional NET PET, neuroendocrine tumor, NET PET 1 to non-functional neuroendocrine carcinoma, which is NET PET score 5. So all my discussion will be based on NET PET score, that is somatostatin receptor avidity and FDG avidity. PRRT versus systemic therapy in NETs is not this, that is Rana and Prabhas fighting or Duryodhana and Bhima fighting. It is the other way around. Both medical oncologists, that is Rana and Prabhas, both fighting against, what do you call him, and that is the neuroendocrine tumor. So it is together we fight. It is not a fight between each other. But today they asked me to fight for this, so let me fight for that. So it is not an individual. Now first, I know you all people know how PRRT acts, but let me show for if there are any new ones to make it simplified. In 20 seconds, I will show you these are the neuroendocrine tumor cells. Octreotide analogs go and bind to the neuroendocrine tumor cells. So they are bound there, and there is a bifunctional chelating agent. That is a bifunctional chelating agent. There is a bifunctional chelating agent, and then the role of nuclear medicine physician comes. We will attach the bifunctional chelating agent either with lutetium or actinium based on affordability, availability, and patient hematological reserve. So once lutetium and actinium go there, it will burn the neuroendocrine tumor cells by DNA double-strand breaks. Oh, sorry. So now that was PRRT. So I will not go into all these things. I will see why NCCN is recommending. NCCN, don't read the guidelines, read the evidence blocks. If you read the evidence blocks, then there will be no confusion. But once you read the guidelines, there will be many category 1, many category 2, many category 3. You score it properly. And this is efficacy, whether it is highly effective or palliative, whether it is safe or highly toxic, that is more grade 3 and grade 4 toxic, it is highly toxic. That is CTCA scoring. And this quality of evidence, whether it is well-designed trials or case reports. I don't want to talk on case reports. Based on case report, I can treat any cancer with PSMA, and one of the patient will respond with PSMA. It is not that way. I can treat any cancer with sandostatin, and one of them will respond out of 1,000. So I don't want to rely on case reports. As if there are any students, only talk about phase 3 trials or meta-analysis. Consultants and senior consultants, you can talk up to phase 2. So I believe I am a student. I'll talk only on phase 3 trials. And consistency of evidence, it should be highly consistent, and it is not anecdotal evidence. It should be highly consistent. Due to lack of time, I am rushing through the slides. And affordability, yes, it should be affordable. The affordability is again a relative thing. What is affordable in India is different from what is affordable in US. In India, few things are affordable and few things are costly. In US and UK, some things are not affordable. So now coming to the topic proper. Metastatic inoperable pancreatic neuroendocrine tumors. What we have, the first line therapy, their preferred regimens are octreotide and lanreotide. And for progressive disease, we have other options like everolimus, sunitinib, PRRT, temozolomide and capecitabine. For want of time, I will not go for the other recommended regimens like Folfox, Kepiox, and Evodose octreotide, Evodose lanreotide, and belzutifan. This is HIF-1 alpha inhibitor. So, but for many years, streptozocin, I think if you can go and read better trial, I don't know why NCCN did not look into streptozocin at all. This is the first alkylating agent which was used for neuroendocrine tumors. It is shown better study, shows some better results, better trial shows some better results along with bevacizumab. But present if the alkylating agent used in neuroendocrine tumors is temozolomide. These are the signaling pathways in NET. mTOR is a central regulator of growth, mammalian target of rapamycin, activated with loss of tumor suppressor genes P10, NF1 and tuberous sclerosis gene. And this once mTOR is activated, it activates HIF-1 alpha and there will be angiogenesis. It activates the protein synthesis, it activates the growth and proliferation. The negative feedback mechanism is through somatostatin receptors. The other way of stimulating the phosphoinositol 3 kinase pathway is through insulin growth factor 1 and VEGF1. These are all stimulants, but this is the inhibitor. So we are concentrating on this. Medical oncologists are concentrating on this pathway. This pathway blocks the phosphoinositol 3 kinase. Once the somatostatin receptors is there, it has an anti-proliferative effect. It has inhibition of cell cycle, inhibition of growth factors, and repro-apoptotic genes. System effect, indirect anti-proliferative, inhibition of growth factor and tropic hormones, inhibition of angiogenesis, and immune system modulation. So coming to octreotide, what is the score out of 25? It is 16, but it is overrated. The reason is there is no definite benefit in overall survival. The efficacy is 3. Even if you show overall survival benefit or not, the NCCN has taken it as 3. That is my problem. So I would have given it as 2 because there is no definite benefit in overall survival. And NETTER trial now in first line also, NETTER 2, if you have seen the NETTER 2 news, it is clear that as first line treatment, Lutathera or lutetium dotatate improves the significantly reduces disease progression, improves PFS and improves overall survival. Lanreotide, the score ESCA, that is efficacy, safety, quality of evidence, consistency of evidence and affordability. Clarinet and Clarinet Fort are the 2 trials, and they do the prolongation of progression-free survival at 24 months. Only 65% in lanreotide had PFS and 33%, but there was no significant definite improvement in quality of life. You can ask me, lanreotide is a somatostatin alone, why there was no improvement in quality of life? Because there was increase in diarrhea. Clarinet Fort, that is lanreotide 120 milligrams in 14 days, reduced dosing, provided meaningful progression-free survival, but there was no definite increase in overall survival or there was no partial responses. Now come to everolimus. The no problem with efficacy or safety scoring of this thing, but problem with consistency of evidence. Radiant 2, the Radiant 1, 2, 3, 4 are the studies which say everolimus is good in metastatic non-functional neuroendocrine tumors of pancreas. All origin pancreas also is there. Consistency of evidence is debatable because Radiant 2 study shows no improvement in overall survival. Actually, even for adjusting for the crossover, there was no improvement in overall survival. Efficacy is not proven in functioning pancreatic neuroendocrine tumors. So, everolimus, there is no improvement in overall survival. There is no evidence for functioning neuroendocrine tumors. and there are significant side effects. You don't want to treat some patient, and instead of one disease, you make the patient other disease. The patients will have hyperglycemia, fatigue, stomatitis, and tolerability in Indian population is questionable. 10 milligrams per oral daily, many patients are not tolerating everolimus. And sunitinib, yes, I don't have major complaints, but the objective response rate was very less, in 9.3%. Continuous, that is 37.5 milligrams orally. Then PRRT with lutetium dotatate, they have given scoring of only 15 out of 25. Efficacy and consistency, I accept. Many don't understand why the safety is in question. See, you see this white box. If you see the white box, it's fine. But there is a slight gray area. That is myelodysplastic syndrome. The myelodysplastic syndrome, if you have a white curtain and one small black dot, you are concentrating on the black dot, not on the white this thing. Lutetium dotatate is very much safer, and carcinoid cancers, if it is there, can be managed with telotristat in abroad, but it is very rare. We don't regularly see carcinoid cases. And temozolomide and cabazitaxel, the period progression-free survival was 14.4 months with temozolomide versus 22.7 months was for Captem. So I Captem is good, but still the PFS was much better with lutetium dotatate than Captem. Let's come to the debate proper. Why PRRT? Why not? Why PRRT? I'll say. This is a nuclear medicine physician. The people who are crying are the nephrons and normal cells. They are amino acids. We are protecting the kidneys, and this is the nephrons. So the NET cells are gone. So it is PRRT is better. Whereas what happens with give me a second, and what happens with systemic therapy is it cannot protect the normal cells. The normal cellular toxicity is, I don't know. Give me a moment.
Get the point that systemic therapy was there. The PRRT not working.
No, why?
Because the results not working.
No, give me a minute. I'll finish in one last two slides. Yeah. I was rushing through because of lack of time, but still, I prepared for only 10 minutes, not for. What is happening with the system is the problem, not me. The everolimus and Captem, normal organs also are equally affected. So logic explains, but evidence reaffirms. We have to wait. There is compete trial and compose trial. Compete trial compares PRRT with everolimus. Compose trials compares PRRT with Captem, everolimus, or Folfox, whichever the tumor board decides. So the classification is there. It is not one size doesn't fit all. Pancreatic NET not single shade. We have to see whether it is FDG negative, SSTR positive, then lutetium dotatate. FDG positive, SSTR negative, chemotherapy and targeted therapy. And find the size and see if fitting is proper. Active surveillance with octreotide, belzutifan if HIF1 alpha in positive patients, PRRT in metastatic NET with low NET-PET score, liver-directed therapy in liver-only metastasis, mTAR inhibitors, sunitinib, streptozocin is gone, but I still say if chemo has to be given, streptozocin bevacizumab do well, temozolomide, Captem. One size does not fit all. Tumor board discussion, individualize the treatment, but when we have to choose one, it is PRRT.
For his point on systemic therapy in metastatic PNETs? Thank you, sir.
I think after this debate, like नरेंद्र मोदी को 2024 का इलेक्शन लड़ना चाहिए कि नहीं लड़ना चाहिए, डायरेक्ट थर्ड टर्म दे देते हैं. सो अगेन माय पॉइंट इज कि शायद ऑडियंस में जो लोग बैठे हैं या जो भी पैनलिस्ट है, शायद जिसकी जितनी भी स्लाइड थी उसमें ज़्यादातर एवरोलिमस दिखाई दे रहा था या कैप्टन दिखाई दे रहा था, पीआरआरटी कम दिखाई दे रहा था. सो ओवरऑल माय अगेन डिबेट इज आई एम वेरी मच फॉर कीमोथेरेपी, फॉर pancreatic NET, and again this is very important slides. मेरे कलीग ने भी बहुत सारे स्लाइड बताई, बहुत सारी वीडियो दिखाई. मैं भी कुछ ना कुछ स्लाइड दिखाता हूँ. वीडियो तो नहीं है क्योंकि वो शायद वर्क नहीं करता है. क्लिनिकल ट्रायल के रिजल्ट में है ना, जो दिखाई देता है वो इंटरप्रेट करना बहुत मुश्किल होता है. लगता है कि दोनों ट्रैक साथ जा रहा है, लेकिन कई बार वो कंफ्यूज हो जाते हैं. जैसे मेरे कलीग ने बोला, बहुत सारी मेडिसिन है, स्टेप्टोजोसिन, सुनिटिनिब, एवरोलिमस, लेनोलिट्राइड, सुरुफिनल. So most of the things is, the most important part is the optimal treatment sequence. हमें किस तरह से जाना चाहिए. कई सारी टॉक हो रही है कि gradually this NET, the patients of NET, the importance is the optimal sequence. क्योंकि वो patient शायद लंबा behave कर रहा है या लंबा जा रहा है, तो आप कौन सा एजेंट पहले यूज करते हो, कौन सा एजेंट बाद में यूज करते हो, that is most important part. So again, there are so many randomized trials and recent trials, again TAM versus CAPTAM, and again in PAN, especially in pancreatic neuroendocrine tumors, this is very important. There are so many trials, and again the PRRT, they have all is a retrospective data, no prospective data. Yes, I will come to that NETA trial also. This is the Radiant 3 trials for everolimus versus placebo. Again, sunitinib. Again, this is a very wonderful new trial, that is phase 3 study. Again, for surufatinib versus placebo. And the optimal sequence. आप कौन सा कलर कहाँ पे यूज करते हो, मिडल जो पार्ट है, कई बार हम कंफ्यूज हो जाते हैं. सो मिडल पार्ट हमें यूज करना है. Again, this trial, again phase 3 trial of again 2 treatment sequence in pan-NET, either everolimus followed by chemotherapy versus chemotherapy followed by everolimus. Again, this phase 2 trial, again, that is comparative dotatate versus sunitinib in pan-nucleotide. So finally, the ESMO guidelines or advanced pancreatic neuroendocrine tumors, where the PRRT is after the systemic therapy, not anywhere before this. So optimal sequence, again, my colleague also same thing tells, compete trial and compost trials, and again the importance is the benefit versus risk. So as far as a good clinician, a good medical oncologist, as my colleague also saw the first slides of Ravan, and I will also send the last slide of the Ram, that's Ram Lalla Mandir or Ayodhya Mandir. The benefit is also very important versus risk, and the toxicity is also very important. The toxicity, whenever there is a toxicity, you should consider that again, the bone marrow toxicity generally is manageable except MDS, that is in PRRT. That is also very important. So beware of toxicities. यहाँ पे इतनी सारी रिंग है, उसमें only एक रिंग वेडिंग रिंग है, बाकी की all सब रिंग और peace of mind disturbed by the first one. और most important, हमें बैलेंस करना चाहिए between mom and wife. So again, very important. So finally, my take-home message is that we should understand the various biology and various, and I also mentioned this NETA trial, where again, the improves the time to quality of life deterioration in patient with mid-gut neuroendocrine tumor that is progressive to SSA. And there are some prognostic versus predictive markers. We should also understand that whether we are able to at present any biomarkers in NET, the answer is no. There are some prognostic markers, but we does not know. As my also colleagues tells me, there are some subsets where might be everolimus is better, where some of the subset where PRRT is better. So finally, my conclusion is we should carefully balance efficacy
versus toxicity and quality of life issue in each patient in the context of tumor and patient features, treatment goals, predictive versus prognostic markers, treatment complexity and expertise of the team. इंडिया में जितने भी सेंटर है, कितने सेंटर में पीआरआरटी कर सकते हैं और कितने सेंटर में मेडिकल ऑन्कोलॉजिस्ट कीमोथेरेपी दे सकते हैं. Convenience, cost, access and reimbursement issues is also very much important in treating neuroendocrine tumors. Finally, if you succeed, every mistake becomes legendary. This is my conclusion. The way to go, दोनों को साथ में बैठ के चाय पी लेनी चाहिए. Thank you very much.
Thank you, sir. Very nice deliberation. I would give some Dr. Mantri also for some counter comments, and then we conclude.
Sir is saying there is no availability of biomarker. I have two biomarkers, gallium dotatate and SSTR PET. There are many molecules, many alpha particle therapy, many prospective studies, but I did not put all of them because many are phase 2. As to talk about phase 2 studies, I am not experienced enough. I am talking only of phase 3, that's why I put NETR. And I don't, sir has also shown some phase 2 trials. Coming to the biomarkers, if SSTR positive, FDG negative, please go with sandostatin and PRRT. I will prefer first line PRRT, but if your reimbursement is a problem, go for sandostatin followed by PRRT. If SSTR positive, FDG mildly positive, still PRRT. If SSTR and FDG both positive, then Captem plus PRRT or PRRT followed by Captem or together. That is a tumor board decision, because some medical oncologists are not happy with sequential PRRT and some are followed at sequential, some are with concurrent. I go with concurrent, but most of the people are comfortable with sequential chemo PRRT. And if it is clearly FDG positive and SSTR negative, there is no role of PRRT at all. So the biomarkers are SSTR and FDG. You use the NetPET score, and based on NetPET score, decide. But if SSTR positive, FDG negative, no role of medical oncology. It is sandostatin plus PRRT.
Any comments from the experts?
Actually, the debate here is confined to the well-differentiated. That is where the debate lies. NEC we are not concerned. NEC because it is outside the realms of this. Now, in well-differentiated NETs, one factor which we must consider is that these are patients who go on for a comparatively long time, and therefore sequencing of therapy, as he said, becomes important. It's not to say that one therapy does not work better than the other therapy. Maybe the therapy which we consider in the end works the best, but because the patient continues for a longer period of time, we generally tend to give the octreotide treatment and then see if whenever there is a progression, then we go for the PRRT. That's the point. I believe the debate would have been even more controversial and energetic if you had included the surgical options here. Because, again, well-differentiated neuroendocrine tumors, it is extremely difficult for a non-hepatobiliary surgeon to come to a conclusion that this is not resectable. We have gone and resected multiple lesions in the liver, with the lung and a soft tissue in the thorax in the same sitting, and these patients continue to do well. Now, that is a separate debate because this is not confined to this. The point is not that. The point is whether the question that whether it is surgically amenable does not come. So the patient is deemed to be surgically not amenable without actually discussing with the relevant people. That is that problem which comes. And that's the same problem which comes in HCC also. The last time this thing was being discussed. So several times we go and see this, that a patient who has been deemed as unresectable because of child-pook criteria or the size of the tumor, etc., actually is resectable. So yes, it is with relevant people. Tumor board with relevant people is more important.
Sir, we are here not touching touching upon the subject of resectable pancreatic. No, that is completely ruled out. We are not talking about Ki-65 index more than 55%.
Just
We are
touch
not
that
talking
topic
about
because that talk was not there.
Yeah.
For unresectable topics, yes. The debate is within the NET grade 1, 2, 3. That is well
What
differentiated.
we are trying to make the point is, with the NETTER trial 1 results out and NETTER trial 2 results, which we are expecting in next year, it has been discussed in ASCO meeting, and the results are promising. The frontline upfront lutetium dotatate therapy in well-differentiated neuroendocrine tumor has shown overall survival benefit as well as PFS benefit of almost more than 18 months compared to LAR arm alone. So with this data, can we not consider giving a patient first line PRRT if patient is affordable and if patient is in a setup where patient is
So that setup is also very important. How many nuclear physicians, like we had in Ahmedabad, Gujarat, we had suppose 5 centers in Ahmedabad where we are having a nuclear physician specialist.
But if
Out
we are
of
in
that, how many are giving PRRT?
if we are in an ideal world where the patient has access to all the treatment and cost is not a forbidding
Madam,
factor,
you are
then
right.
would it-
In an ideal world, you may be right. But again, those trial results, I would temper with the word. We should go back and look at what is a lead time bias. Now, are the results, once again, are the results better in an upfront PRRT because of the lead time bias? That issue has to be looked at. And I have a suspicion that lead time bias plays a major role in those diseases in which the patients go for a longer time.
Correct. If that is the logic applied, lead time bias should be applied for all chemotherapy.
It should be.
That is a big, then if you go open parallel and you cannot, you can say, leave the patient of T2 lesion of breast, do nothing. How many of the medical oncologists will accept? Because there can be a lead time bias.
For want of time, let's have lunch together instead of coffee, and probably we'll all agree and disagree on something, but ultimately we will do the best which is good for the patient. Thank you.
Thank you, everyone. For the next session, I would like to call Dr. Jeba Singh Joseph, Madurai, Dr. Jitendra Rohila from Mohali, Dr. Anil Kamath from Bangalore, and Dr. Pavan Sugur to chair the session. I would like to call Dr. Rakesh Sharma from Dr. Rakesh Sharma, Consultant, Department of Medical Oncology. Max Super Speciality Hospitals, New Delhi, to start his session.
Good afternoon, everyone.
There are some technical issues. So we'll start with the next session, next topic, interventional radiological management of hepatocellular carcinoma, by speaker Dr. Saurabh Kumar, Additional Director, Department of Interventional Radiology, Fortis Hospital, Gurgaon.
Good afternoon, everyone. I will be talking about the role of interventional radiology in the management of SCC. hepatocellular carcinoma, as we all know, is the most common primary liver cancer, and the common risk factors are chronic hepatitis B and C infection, and now the NASH cirrhosis is coming up. The mainstream curative options is still, for early stage disease, still resection and transplantation. However, in substantial number of patients, the patient is ineligible for surgery, or the disease is in the intermediate stage or the advanced stage. So in these cases, various percutaneous minimal invasive image-guided therapies are provided by the intervention radiology, which will be discussed further. So the local regional therapies can be divided into percutaneous ablative therapies or transarterial therapies, and transarterial therapies consist of TACE and TARE. The BCLC staging divides the SSC patient into the 5 stages. So in the early stage, when the lesion is less than 3 centimeter or up till there are 3 lesions, so ablation is preferred either through the radiofrequency or microwave ablation. In the intermediate stage, when the disease is multinodular, then the TACE is preferred. And in the advanced stage, or when there is malignant portal vein thrombus, TARE is preferred. So coming to the local ablative therapies, there are minimal invasive techniques which preserve the uninvolved liver parenchyma, have few systemic side effects, and are a viable alternative to the surgery. So ablation started with the chemical ablation in the mid-80s and now has come to the non-thermal ablation like IRE, also known as irreversible electroporation. But the most commonly used thermal ablation techniques are still radiofrequency and microwave ablation. So coming to the case, we can see this is the ultrasound image showing right lobe lesion, right lobe SCC. So in this we did less than 3 centimeter in size. We did percutaneous radiofrequency ablation. This is the probe entering into the lesion. And in the subsequent images, we can see echogenic clot formation around whole of the lesion, suggestive of complete tumor ablation. Sometimes the lesion is very close to the subcapsular location, close to the intercostal vessels. In these cases, to prevent any injury to the underlying intercostal vessels, we can create an artificial selenoma with pictorial insertion in the perihepatic space, and we can do further percutaneous CT-guided radiofrequency ablation of the lesion. So sometimes we have to do combination therapy, like in this case, there is a right lobe SCC. We did TACE in this patient. So in this, the first image, we can see the lipidol, hyperdense lipidol can be seen along the middle margin, but the lateral margin is show lipidol defect. So in this case, we do a CT-guided radiofrequency ablation in the second setting of the lipidol defect to get complete tumor necrosis. Like in this, we can see there is complete tumor necrosis. The middle is the lipidol, hyperdense lipidol of the TACE, and lateral is the necrosis secondary to RFA with air within it. This is another case. In this, we did TACE, but the patient follow-up has recurrence along the middle aspect. But the problem is that we did a second angiography, but we couldn't able to reach the hepatic artery supplying the middle part. So we planned the radiofrequency ablation in the CT-guided. But for this ablation, we have to traverse the lung parenchyma and the diaphragm both. So in this, under CT guidance, a probe was inserted through the lung, through the diaphragm into the lesion. So we follow-up scan showing complete tumor ablation on the middle aspect. So when the lesion is larger, more than 3 centimeters in size and very close to the vessels, like in this case, we can see the lesion is very close to the middle hepatic vein. So in these cases, there is heat sink effect, and there is incomplete ablation along the vascular margin of the lesion. So to negate this, microwave ablation has come up, which uses electromagnetic energy. So if the lesion size is more than 3 centimeters and it's close to the main vessel, the preferred technique now is microwave ablation. So in this image, this is the MRI images. We can see the arrow pointing toward a lesion closely abutting the right portal vein and the IVC. This is the lesion showing washout on the venous phase. So we did microwave ablation. We inserted a probe. The technique of the RF and microwave are same. We have to insert probe under the guidance of C2 and ultrasound. We can see a echogenic cloud covering whole of the lesion. And in the follow-up, we can see complete tumor necrosis. This is a hyperdense complete tumor necrosis was there in the follow-up MRI. Sometimes the lesions are very small, like there is 1.5 centimeter SCC in a child A or B status patient, and the lesions are not seen on the ultrasound or plain scan, and only seen on the arterial phase. So in these cases, we do a lipidol CT in which we selectively cannulate the right hepatic artery in the region of the tumor and inject lipidol. So the lipidol will get preferentially administered in the SCC as compared to the normal adjacent surrounding liver parenchyma, and then we ablate we get the lipidol as a guidance, and we ablate it under the CT guidance, like this in this case. So in the follow-up scan, we get complete tumor ablation. So in very small SCC, a TACE cannot be done because of vessels are very small. So there is non-selective cannulation, and the normal hepatic parenchyma will be exposed more. So in these cases, like 1.5 centimeter, we always prefer ablation only. So coming to transarterial chemoembolization, TACE, which is the preferred method for unresectable SCC or intermediate stage SCC, and is the most common bridging therapy. Basically, it's a twin procedure consisting of intra-arterial administration of the drugs followed by embolization of the feeding artery. So it's based on the concept like the tumor is supplied by the hepatic artery while the normal liver parenchyma is supplied by both the hepatic artery and the portal vein. So we go in selectively into the tumor artery, either selective or super selective, inject the chemotherapeutic agent and embolize the vessels. The embolization causes increase in the prolonged dwelling time of the chemotherapeutic agent and minimize the systemic side effects. So the main indication is nodular SCC more than 3 centimeters in size, well encapsulated or multinodular SCC. The contraindication are cells child C or malignant main portal vein thrombosis, or if the LFT liver function tests are not good, bilirubin more than 3. So the most commonly used agent are doxorubicin or epirubicin, which is seen. The combination of epirubicin, doxorubicin plus lipidol is generally seen in the conventional TACE, but now the DCB or drug-eluting bead TACE has come up. So I will show one case. This is the right lobe SCC. We can see a washout and a smooth capsule around the lesion. This is a MRI T2 weighted image showing hyperintense SCC in the right lobe segment 5-6. So we did an angiography. This is the hepatic artery, right hepatic artery. We selectively cannulate the artery supplying the tumor. We inject the chemotherapeutic agent within and followed by the embolization of the vessel. So this is the follow-up scan. There is gradual homogeneous lipidol deposition and gradual decrease in the size of the lesion. This is another case, right lobe SCC. This is a CT image showing one artery entering into the lesion. We selectively hook with the angiographic microcatheter. We selectively hook that artery, inject that mixture of epirubicin and lipidol. These all are conventional TACE, and followed by the MRI image showing complete tumor necrosis. This is a follow-up image. The follow-up should be done at the 3 months, 6 months, 1 year, 3 years, and 5 years. This is the normal protocol we follow. So this is the post-TACE 1 year image showing complete tumor necrosis and decrease in size of lesion. But at the 18 months follow-up, we see a nodule developing along the medial aspect of the lesion. So there is SCC recurrence. So in this case, instead of ablation, we did a second session of TACE in which we, by angiographically, we selectively hook that artery. And this is a follow-up scan 6 months after the second session of TACE, showing complete tumor necrosis and gradual reduction in the size of the lesion. So sometimes the tumor is very large, so it gets supply from the extrahepatic supply. So this is the first TACE we did for the hepatic artery supply. Now follow-up scan showing recurrence along the medial, residual tumor along the medial aspect of the lesion. So we did a renal angiography and we get a branch, basically adrenal artery, inferior adrenal artery, which is supplying the tumor. So we selectively hook the adrenal artery and we see complete lipidol deposition suggestive of complete tumoral coverage in this case. So these all cases are of conventional TACE. Now the DCB drug-eluting bead TACE has come up, which shows maximized drug delivery and has long-lasting effect with less of systemic toxicity and post-embolization syndrome. Just 5 minutes. So this is a case of the DCB TACE in which we this is the right lobe tumor, complete angiography showing homogeneous blush followed by complete hemorrhagic necrosis after the DCB. So there are instances when there is spontaneous SCC rupture. In this case also, transarterial chemoembolization and embolotherapy is preferred. Like in this is multifocal SCC with hemoperitoneum. We did angiography, there we see the active extravasation. So TACE was done in this case. So coming to transarterial radioembolization, it is selectively injecting the radioembolic agent into the tumor, and it does not modify the arterial blood flow. Hence, it's associated with a better hepatic tolerance. So it is similar to TACE, but instead of chemotherapeutic agent, we inject the radioembolic agent into it. So though initially it started with iodine and rhenium, now the preferred agent is Y90, and the most common indication is SCC with main portal vein thrombosis, and but it has been tried also in the advanced SCC. Just few minutes. So the contraindication are increased lung shunting and inadequate liver reserve. So it's divided into basically two parts, tier 1 and tier 2. Tier 1 is the arterial embolism. We embolize the extrahepatic supply, do the lung shunt fraction, and calculate the tumor to liver uptake. And in the second, we administer dose. So this is the right lobe SCC. We selectively hook. There is also associated malignant portal vein thrombus. So when we did tear, this is the post-tier tier 2 scan. We see the deposition into the main portal vein. So the malignant portal vein thrombus can also be treated with tear in some cases. So, we can see the homogeneous multifocal tumors on the right side, and similar post-tear images showing homogeneous deposition along the every nodule of the. So we did lobar tear in this. This is the baseline. We did tear in the. This is the baseline scan showing SCC more than 10 centimeters with portal vein thrombus. This is a follow-up 3-month post-tear. There is complete tumor necrosis. Sometimes now we can combine tear with tears like. For intrahepatic branches, we do tear, but we can see there are defect on the posterior aspect of the lesion. So we did the angiography, inferior adrenal artery supplying. So all the 4 hepatic artery branches supplying the tumor was negated by tear, and the posterior branch was negated by lipidol TACE. So now in advanced SCC, the combination of immunotherapy and tear has come up, and there are many studies combining the immune checkpoint inhibitors with the tear, and combination of tear with PD-1 agents. But if we are combining tear with immunotherapy, the tear has to be done first, followed by immunotherapy, not the vice versa. So this is the data at fMRI we have done in the last 3 years. We have done around 25 cases of ablation. We have shifted to microwave completely from RFA, and we have done around 110 cases of TACEs and 75 cases of Y90 tear, in which the 40 are with the protocol which we follow is for SCC with malignant portal vein thrombosis, it tear for the SCC and SBRT for the malignant portal vein thrombus. So take home, there are minimal invasive techniques have developed which can be done in an image guidance and have faster recovery, and they have led to a major breakthrough in the management of both unresectable SCC and also in the tumor downstaging. Thank you.
Thank you, Dr. Saurabh, for an enlightening talk on role of intervention in WBC. We can take 1 or 2 questions from the audience.
In colonic, yeah, less than 3 as we do radio frequency ablation. In the lymph nodes, we haven't tried.
What is your size cutoff for TACE?
So TACE is like protocol which for less than 3 centimeter ablate, 3 to 5 we do combined therapy, more than 5 we do TACE. We have done TACE in 7 centimeter and up to 10 centimeter, but in one session the tumor coverage is not good. So if the tumor is more than 7 centimeter, 2 sessions of TACE is almost required. Now we have recently did tear in large SCC. So in one session we can do ablate whole of the 10 centimeter lesion. So tear is very good in large lesion, especially more than 7 centimeter.
Any untoward side effects of liver failure post-TACE?
Post-TACE
larger lesions?
In child, like we don't do in child C. If we do in late child B, there is in few cases we have slight liver decompensation, but it depends upon if you are going selectively into the tumor or if it's lobar. When it's selectively into the tumor, there will be no decompensation, but when it's proximal, then there's always a slight decompensation is there.
Thank you.
Okay, thank you.
For the next topic, I would like to call Dr. Ramchandra C., lead consultant surgical oncologist, Mallige Hospital, Bangalore, ex-director and professor, Department of Surgical Oncology, Kidwai, Memorial Institute of Oncology, Bengaluru, to speak of role of lymphadenectomy in carcinoma stomach.
Thank you. Hardly any audience. I think it's lunchtime. Thank the organizers and thank you the chairperson. Ladies and gentlemen, carcinoma stomach is called as, they see the king of men of death. I think you can go back and see the Bailey and Love, still there, the prize. You see, overall, 10,89,000 people were diagnosed and 70% people die in the same year. So overall, the prognosis has not improved over a period of time. In spite of many advances in surgery, chemotherapy, immunotherapy, radiotherapy, everything. Most of the randomized studies were done in an era where the chemotherapy was not utilized, radiotherapy was not utilized, immunotherapy is not developed at all, including Dutch trial. The anatomical subtypes in this is mainly the proximal gastric cancer and distal gastric cancer. Distal gastric cancer is supposed to carry the better prognosis compared to proximal gastric cancer because of the anatomical constraint, where the disease most of the time presents with advanced disease, and majority of the patients develop with stage 3 or stage 4 disease. The risk factors are obesity, gastrointestinal reflux disease, smoking combined with alcohol is the root cause in proximal gastric cancer, whereas H. pylori, diet, and of course smoke also is a cause for distal gastric cancer. North America, I think we all know about North America. Basically, the disease is very slow growing, carries a better prognosis compared to the Asian part of the stomach cancer. In Asian part, mainly it is Japan, Korea, China. This province, the gastric cancer is very well known and very commonly seen, and even the advances, many advances are mainly invented in this province of the Asia. The clinical course in the North American disease is very slow growing, basically because they use most of the frozen food, the deep freeze food, where the incidence of gastric cancer is low and basically is less aggressive compared to the Asian part. The incidence remains stable in North American part and the other side of the world, whereas the Asian part, it is decreasing. Prognosis is very poor in the Western part, but it is improving in the Asian part. Curative surgery, of course, any surgery, most important thing is the en bloc resection of nodes should be included. The curative surgery includes the standard gastrectomy also. I'll tell you what are the types of gastrectomies. So gastrectomy with proximal 3 centimeter margin, now there is a revised margin also. For a proliferative disease, even 3 centimeter margin is enough. Whereas distally, you cannot give more than 2 centimeters. If you give more than 2 centimeters, you end up with resection of pancreas. So majority of the time, we end up with 2/3 gastrectomy with a stomach D2 dissection is standard, but many times it is not possible. Then you call what is known as a non-standard gastrectomy or a non-curative gastrectomy. A non-standard gastrectomy, many times you do a gastrectomy with inadequate nodal dissection. Whereas in non-curative gastrectomy, palliative surgery, suppose for bleeding, obstruction, anything for that matter, any of these complications can be handled. Whereas reduction surgery can be anything. Even if there is a liver metastasis with obstruction, you remove this. Palliation can be anything. You can remove anything as long as there is no morbidity, mortality, it's still acceptable. The surgery for primary could be proximal gastrectomy, distal gastrectomy, total gastrectomy. And lymphadenectomy is D1, D2 only. D3 is almost obsolete now. We don't do. Reconstruction is another part where loop jejunum is being used, a row and loop, or a loop gastrojejunectomy can be done. These are all various types of reconstruction. In expansile tumors, the Borman's type of classification is still holds good, and it's been very much applicable now. Infiltrative disease, proximal always give minimum of 5 centimeters unstretched mucosa from the edge of the tumor, whereas expansional tumors you can still get away with 3 centimeter margin. These are all various lymph node dissection. When we talk about lymph node dissection, Japanese type of lymph node dissection don't mix with TNM staging. TNM is totally different, PNHS is totally different. When we talk about Japanese lymph node dissection, it is called PNHS staging system. Don't confuse for the TNM staging system at all. D1 is removal of N1. D2 is removal of N2. What is N1? What is N2? As per the Japanese definition, any node which is less than 3 centimeters from the primary tumor is N1. So in the N1 group, there are 6 regional nodes are identified. You have a pointer? Pointer there. You see the right cardiac is 1, left cardiac is 2, lesser curvature is 3, greater curvature is 4, suprapyloric is 5, and infrapyloric is 6. This is N1. N2 is what? along the distribution of the celiac nodes, branches of the celiac nodes. Left gastric, 7, common hepatic is 8, celiac trunk is 9. Then comes the splenic. Number 10 is splenic hilum, 11 is along the splenic artery. So, part of it, so the left side of the porta hepatis is 12, and 13 is the root of mesentery, 14 is the metalcholic vessels, and the 15 is around the mesentery, and the 16 is para-aortic nodes. So, you have to stop at the porta hepatis level. Porta hepatis is not routinely dissected, it is not part of D2 dissection. Whereas, many times we dissect the left side of the bile duct, where it includes in the D2 dissection, where you go along the common hepatic, where a branch of hepatic artery goes and the gastroduodenal comes down. In that curvature, you take out few nodes along the 12 region, that is the gastrohepatic ligament. Many times in D1 dissection, we end up removing the 7 nodes because you ligate the left gastric vessel at the root of the mesentery, root of the celiac trunk. So, you take out the left gastric vessels. Although left gastric comes under N2, we routinely remove in D1 dissection. The extent of nodal dissection. When you do a total gastrectomy, you remove from number 1 to 11 completely, and the left side of the number 12. Whereas in proximal gastrectomy, distal gastrectomy, you decide on table what has to be removed. The Japanese concept is removal of one nodal basin more than involved region increases local regional control. It means, what do you mean? When N1 is involved, you remove N2. So this is called as absolutely curative. When N1 is involved, you do only D1, remove only N1 level, it is called as relatively curative. So if you want a better cure rate, go one region above and remove the node. The Western concept is more of a staging workup, but today they are also slowly accepting regional nodes has to be addressed, and they are also accepting slowly with D2 dissection. There are many trials come up, Dutch trial, UK MRC trial, Italian trial, Taiwan trial. In this, one trial stands up above all except the Japanese and Korean trials today. The Dutch trial, this is the eye-opener trial over a period of time. Initially, the Dutch trial also had a lot of morbidity, mortality, not much of survival benefit at the end of 5 years. But over a period of 15 years, at the end of 15 years, there was a 10% benefit from D2 dissection. But when I read in depth about the Dutch trial, there are a lot of pitfalls, a lot of lacunae. UK trial, MRC trial was abandoned because it was the mortality, morbidity very high, and most of the trials have done distal pancreas and spleen removal. Dutch trial, over a period of 4 years, 89 to 93, the sample size was 996. 285 received palliative treatment, and only 711 were taken for randomization. It means to say D1 dissection 380, D2 dissection is 330. Distal pancreatectomy, splenectomy is not done in all cases. Was done in all cases where D2 dissection was done. In this, if you see carefully, I was just going through, out of 711 cases, 511 cases died in the same year, which nobody commented. T1 were 183 patients, T2 were 333 patients. Was there a requirement for D2 dissection in T1 case? If you had not done a D2 dissection for T1 case, probably you would have saved these patients, which nobody comments. Surgery was done by most inexperienced surgeons. You know how many have done? Most of the time, one surgery in a year. Today, my resident in Kidwai, they do at least about, before leaving, they do 10 surgeries in 1 year. So, today, most of these trials where the surgeons do about 80 to 90 or even 100 cases per year in a high volume center. If there is not a high volume center, please don't do randomized study. There was no adjuvant therapy, although those days was available, no adjuvant therapy or no neoadjuvant therapy was used those days. Today it is available. There was no PET scan or there was no laparoscopy was done in any of these cases because 47 cases were rejected at the time of surgery because they had liver mets peritoneal deposit. If you had done a PET scan or a laparoscopy, you would have avoided these 47 cases. 47 cases did not leave the hospital, means immediate post-op death. Will you accept this? It is not correct. 398 patients actually died out of 711 cases in the same few months after surgery. Spleen and pancreatectomy, we talk so much about this. We do Whipple procedure. How many leaks we see? Mean to say everybody is dying like this? It means to say the pancreas content has not been taken care of properly. If you take care of the pancreas content, probably you can save a lot of patients, number one. Number two, spleen removal, of course, immunity comes on, but not to an extent of mortality. How many times we remove spleen today? It is not true. Today, of course, we have pneumococcal vaccine. Even otherwise, in a general hospital, if you don't give also, they can still save. Median duration of hospital stay was 14 days to 17 days. Today, most of D2 dissection stay for about a week's time, approximately 1 2 days, 3 days, this at that time. D1 dissection, there was 94 patients had complication, including serious complication. D1 dissection, 94 patient complication was a very high number. How do you accept this? D2 dissection, 142 cases had serious complications. You cannot accept this. The hospital death in D1 was 15. Hospital death rate in D2 was 32. So, with all this, probably if we take, probably it is not a well-conducted randomized study. Today, the only place where they can do a good randomized study is only 3 countries, Japan, Korea, and China, where the number is so high, and they are the only one who are replicating good results today. Most of the other places, the number is so small, you cannot do a randomized study. If you have, at least you should be able to do a minimum of 10 to 15 cases, 20 cases. Today we have Naga study. I think how many people are part of Naga study, you don't know. Pondicherry, our fellow Prashant is doing, where the chemotherapy, of course, is being used, and upfront surgery also is possible there. Again, we see we took in a high volume center like us almost 4 months to enroll 1 case. I see in about almost 12 cases in the last 2 months, I've operated only 1 case. 11 cases are not operable. So 75 to 80% cases in this province comes to stage 3, stage 4, and very poor performance status where they cannot tolerate any treatment. In this 11 or 12 cases, I have given chemotherapy for only about 2 cases or 3 cases, I think. Remaining were only sent for palliation. So ladies and gentlemen, still today, there is no randomized study available as far as the D2 dissection is concerned. You see these 711 cases, D1 was morbidity is 25 and D2 is 43. Mortality was 4 year, 10 there. This is immediate. The 5-year survival was, of course, not much of a difference in that study. Of course, 15 years and 21 years follow-up, they showed almost 10% benefit. 15-year study, they showed almost 10% benefit, but how many cases were alive at the end of the day? Like there is a North Korean, the Journal of Pancreas, where they've seen about 39,000 cases of pancreas in 1 year. At the end of the day, there are only 3 patients alive in 1 year. So all remaining have died in same year. The meta-analysis, there were many trials, including South African DENT study. Again, the number is so small, but it was not followed for a long time. With a good standard study, wherein you have UK MRC trial, Medical Research Council study. Again, it has not contributed much, not followed for a long time. They have abandoned that. And there was a person who was supervising these studies everywhere. And the most important thing in these cases is the inexperience of the patient and few number of patients and the infrequency of surgeons operating. You should be able to do at least weekly 3, 4 or 5 cases. It's not possible. That's possible only in 3 countries, Japan, China and Korea. The meta-analysis again showed here, wherever the splenectomy and distal pancreatectomy is not done, the survival is better with D2 dissection. You can see the diamond. Proximal gastrectomy, of course, proximal gastrectomy, I don't know how many students are here, there's hardly any crowd. So proximal gastrectomy, most of the time we convert into total gastrectomy because bile reflux is an issue. Many times patients have poor quality of life. If you are doing a proximal gastrectomy, you should be able to do an anti-reflux procedure. So that procedure we need to learn and do it, not everybody can do. One. Number 2, many times we convert into a total gastrectomy. It is easy to do, easy to reconstruct also, and easy to clear the nodes. The gastric bed is one of the most complicated systems. Most important thing is the lesser curvature, the third layer of the momentum from colon to pancreas, inferior border. The third layer reflects on the pancreas, it's called the starch fascia. Then it goes on the common hepatic and celiac trunk. Then it goes merges with the crust of the diaphragm. So on the right side is the gastroduodenal artery, left side is the spleen, below is the third layer of momentum going up to the crust of the diaphragm. This area, entire nodal regions, including fat, fascia, whatever, except the vessels and pancreas tissue, don't leave anything. You should clear this. This is very much important in gastric cancer surgery because surgery plays the only role for cure. Otherwise, as we said, 80-90% of the people die in the same year. The Japanese have suggested splenectomy and tail of the pancreas removal for only two reasons. One is a greater curvature tumor, it's a little advanced tumor because it drains into splenic hilum. Many times the nodes are so bulky, you cannot save the spleen. The other one is direct invasion of the tail of the pancreas or splenic hilum. We should remove the spleen. Otherwise, there is no indication for spleen and pancreas removal. Spleen preserving D2 dissection, of course, it's very much possible. Including laparoscopy, we can do it. The current standard of care is advanced cancer. It is advanced cancer also it is possible to do. Another thing, slowly, because of the poor prognosis, we went on searching for reasons. This is one of the studies where more number of nodes are harvested, so better the survival is. Whenever they are harvested, minimum of 10 nodes more than what is expected, there is a 7.6% improvement in survival. If you see T3, where they were dissected more number of nodes, there was a 10% of 10.9% improved in survival. So more number of nodes, again this is a controversy. Why I am saying, because as I am describing the gastric bed, you are not going to leave anything there, including the fat, the nodes, including the fascia covering the pancreas should be removed completely. So in this provision, whenever they removed more number of, the yield is more, the survival is better. So there is a necessity of at least minimum 25 nodes should be harvested. So slowly one by one is coming up now. So one is number of nodes is coming up. There was no decision on how many numbers should be removed. Like how many numbers should be removed in breast cancer? Till today there is no thing. As good as even 6 nodes, 8 nodes are positive. Today with lymphoscintigraphy, even 2 nodes, 3 nodes, we decide about the therapy for the axilla. We follow the NSABP B04 and B06. Are we following today? No. So it's evolving. So here, many times, people are coming forward with the other suggestions. The SEER data suggests the advanced cancers who had more than 15 for N2 nodes and more than 20 for N3 nodes examined had a better survival. So lymph node number is equally important as extent of lymphadenectomy. Is there an advantage of doing an extended lymph node dissection beyond D2? You can do in a selected patients, in a selected group of patients, but whereas if you see end of the day, there is no added advantage. There is no survival benefit. And as it is, I told Dutch trial, one surgeon is to do one case in a year. How do you expect him to give a good result? Here, if you are handling para-aortic region nodes and intra-aortocaval group nodes, you should be really careful, you should be well trained. Many times complications are because of inexperience of the surgeons in Dutch trial. A lot of patients, Nidhi was not there that time. 511 patients died in the same year out of 711 cases in Dutch trial. That is because I felt lack of experience and lack of probably a formulated good randomized study. So here again, although there is a 25% 5-year survival among them, but I strongly condemn removal of the para-aortic nodes. Whereas instead you can use the role of neoadjuvant therapy or adjuvant therapy. Now there is a very effective chemotherapy is available, although it's not curable. Surgery remains the only mode of treatment for cure. This is our Indian scenario. This was done very recently in 2010. Of course, this is an era where PET scan is available, chemotherapy is available, wherever required, utilize chemotherapy. And whenever possible, you try to utilize chemotherapy because reduce your burden. Doing advanced extended resection, it is a mess. It is putting our own feet into the mouth, especially stomach cancer. So the Japanese group of Gastric Cancer Society has suggested T1 lesion only you can do D1 dissection. T1. D1 plus includes group 7 removal. Of course, you ligate the left gastric at the root of the celiac artery, definitely you're going to remove left gastric groove. Whereas anything above T1, anything which is N plus should and must do D2 dissection. D3, there is no benefit in doing D3. No, don't dissect beyond 12 group. Stop at 12 left side only. Don't remove full group of, that's the porta hepatis node. And mesentery, the root of the colic vessels and the paratic node dissection is condemned. So ladies and gentlemen, distal pancreas and spleen preserving D2 lymphadenectomy is the current standard of care, of course. But wherever required, if you do a pancreatic dissection, please secure it properly. In many a times, D2 dissection, the patients were put on Foley's catheter drainage for abscess formation because pancreas is one of the dangerous organs you have to handle with very, very care. Lot of care you have to give in pancreas. Most of the time, I felt the pancreatic end was not properly handled. They used probably some energy source and left it. You have to secure the duct leak properly. If you secure it, many times nothing will happen. When Whipple surgery can give a good result, why with the tail pancreas you cannot secure? It means to say not much care was given. Splenectomy you do, give pneumococcal vaccine. Not all patients are going to die, not all patients are going to have immunocompromise. D2 dissection is safe provided you trained well. Know your anatomy properly and define the anatomy properly and learn the technique of harvesting the nodes and stripping the fascia. Strong evidence to suggest D2 gastrectomy associated with lower roco-regional recurrence. Gastric cancer related deaths should be performed by a trained and experienced surgeon. This is again and again I stress. Even I had a problem probably 30 years back when I learned my D2 dissection. It was really difficult to learn. There is no role of extended lymph node dissection. Splenectomy is indicated when station 10 is involved. That is, that's the splenic hilum is involved. Contiguous with the greater curvature, contiguous with the omentum, where there's a mass formed, you cannot save the spleen and remove. You rather take out, secure it properly. Neoadjuvant chemotherapy and adjuvant chemotherapy should be tailor-made as per the merits. So now it is available, there's a PET scan available, there's a laparoscopy available, there's chemotherapy available, there's effective chemotherapy available. Please utilize everything. Most important thing is this patient should walk home. So as of now, not many randomized studies have proved the role of lymphadenectomy, especially D2 dissection. Including D2 dissection is a failure. Dutch study, in my opinion. Probably a high volume center like Japan, Korea, China, they should do at least have a minimum of few thousand cases in each group. Then you assess. Like doing a D2 dissection for a T1 lesion and killing the patient, are we justified? 511 patients dying within a matter of few months after surgery, out of 711. Where is the question of proving, advanced survival advantage? I think we are trying to extrapolate. So, ladies and gentlemen, thank you very much.
Thank you, sir, for the enlightening talk. We can have one or two questions from the audience.
I know, sir. Tell me.
Small doubt, sir. You would have seen many cases post-neoadjuvant chemotherapy. Sometimes patients have bulky nodal disease near the left gastric vessels. So post-chemo, because of the vasculoplastic reaction, everything gets stuck and the anatomy is not clear in that region. Such cases, what recommend?
Most important thing is there should
No response of the nodal disease at the left gastric vessel. So such cases, dissection itself carries some risk. Sometimes we proceed and get away, we get secure ligature. Sometimes it may be, there may be residual disease adherent to the vessels and margin may be involved. So such cases, many cases you would have seen.
You are right.
So,
Many times it happens.
yes, sir.
See, most important thing is you create a plane from the superior border of pancreas. Secure the celiac artery all round. If you have difficulty, there is something called a seize principle in oncology. This is mainly followed in parotid surgery. Seize principle is something where when you are not able to move further, shift to different field. Come back later.
Yes.
There also you find it difficult, come back to this field. So here you dissect all round, then come to the exact origin of the left gastric artery, where you leave about at least 1 or 2 centimeters above the aorta, then ligate it properly. You have to ligate it with secured sutures. It is possible. It has happened to all of us. And beyond that also, it goes towards the hiatus of the diaphragm. So there again, you have to strip the fascia or the crust on either side.
Thank you, sir. Very nice presentation.
Sir, What's your take on performing a pancreatic duodenectomy, either for bulky nodes or a distal margin or direct infiltration of
It's an
pancreas?
excellent question. I think, I did mention in the past. See, basically what happens, stomach is basically acid mucosa. Whereas at the duodenal sphincter, below the duodenal sphincter is alkaline mucosa. So anything it is, adenocarcinoma is very, very aggressive because it comes in acid mucosa. Whereas same thing in duodenum, it carries excellent prognosis because it's alkaline mucosa. So whenever there is a spread from stomach to the duodenum, it is not through mucosal, it is through serosal. So you cannot give more than 2 centimeters for a distal gastric cancer. So here if you want to give, it is direct invasion of the serosa and infiltrating muscular layer and mucosa. If that is the case, if the only area where that is infiltrated, by giving margin you're going to save this patient, it's worth doing it probably, provided the patient is fit, young, disease, no other disease anywhere else, you can still do a Whipple's procedure along with the radical gastrectomy. Thank you.
So also, sir definitely mentioned all is about training, training and training. I sincerely want to thank sir, who's the ex-director of the largest institute in the country, oncology-centric institute, the Kidway Institute. Thanks so much, sir, for coming today.
Thank you so much, sir, for sharing your experience. The last talk for today is about newer updates in the management of first-line BTC by Dr. Rakesh Sharma, consultant, Department of Medical Oncology, Max Super Speciality Hospital, New Delhi.
Good afternoon, everyone. So I will keep my presentation short. I will not keep you long. So a brief about epidemiology of biliary tract cancer. About 32,000 new cases are diagnosed every year. About 90% of the cases are diagnosed in advanced unresectable stage, and with best of the care, the median overall survival is less than 1 year. So current management, before the era of immuno-oncology, standard management was chemotherapy, gemcitabine with platinum combination, either cisplatin or oxaliplatin. Gemox is more or less equivalent to Gemcis in metastatic or advanced unresectable biliary tract cancer. It has been proved from study from AIMS only. So this is the NCCN guidelines, which preferred regimen is gemcitabine with cisplatin. We can change cisplatin with oxaliplatin also. Other regimen which can be used in first line are Folfox, particularly in cases with obstructive jaundice. So immunotherapy in first line advanced BTC. I will be discussing briefly about Topaz 1 trial. In this trial, locally advanced biliary tract cancer, including intrahepatic cholangio, extrahepatic cholangio, gallbladder cancer were included, and randomized to durvalumab plus chemotherapy versus placebo with chemotherapy, followed by durvalumab maintenance in durvalumab arm, with primary endpoint being overall survival. So the baseline characteristics were well matched, although there were high prevalence of cholangiocarcinoma in this trial as compared to gallbladder cancer, which is more common in Indian strata. So this trial met its primary endpoint with superior overall survival with durvalumab addition of 12.9 months versus 11.3 months, and 24-month overall survival was around 24% versus 11%. So the benefit was observed across all group in subgroup analysis, although there was less benefit in gallbladder cancer as compared to cholangiocarcinoma, with median PFS being 7.2 months versus 5.7 months. So the overall response rate was also high versus chemotherapy alone, 25% versus 18%. And this is a very important slide. Patients who were responding to the immunotherapy combination, the overall survival was also better. 24 months overall survival with durvalumab in responder patient. Responders were CR or partial response. It was 40.6% as compared to the median overall 24 months overall survival, which was 24%. The addition of immunotherapy with chemotherapy does not add on to any toxicity. More or less similar adverse events were noticed, but immunogenic side effects were more with durvalumab combination. As per the NCC and latest guidelines, durvalumab addition with gemcitabine and cisplatin being the category 1 recommendation for advanced metastatic biliary tract cancer. So before the era of immuno-oncology, chemotherapy was the first line, but now with the addition of durvalumab, it is now the current standard first line management of metastatic biliary tract cancer. So in conclusion, this combination should be the first line management of biliary tract cancer irrespective of any biomarker, and it is approved by DGCI also for the management of first line metastatic biliary tract cancer. So a brief about Keynote 966 trial also. This trial used pembrolizumab instead of durvalumab. Also in this trial, gemcitabine maintenance was used along with pembrolizumab maintenance, and this trial also met its primary endpoint, overall survival. It was around 12.7 months versus 10.9 months. Similarly, 2-year OS was similar to Topaz trial, 25%. Median PFS was also more or less same, with overall response rate being 29%. A brief about TAB study, which was recently published by TMH. In this trial, first line trastuzumab was added with gemcitabine and cisplatin in HER2 positive metastatic biliary tract cancer. In this trial, this is a phase 2 single arm trial. Comparison was done with historical PFS and OS and historical patient. No comparator arm was there in this trial. About 118 HER2 positive patients were screened and 90 were enrolled. Majority were gallbladder cancer, which is more common in India. And median PFS was 7 months. 6-month PFS rate was 75.6 months, so which is very high as compared to the historical standard. It is around 60%, and response rates were 55%. Even in the Topaz and Keynote trial, the response rates were less than 30%. So with this, I will conclude my discussion. The take-home messages will be, particularly in cholangiocarcinoma, I think immunotherapy combination should be the first choice. In gallbladder cancer, if the HER2 is positive, then I think trastuzumab should be added instead of immunotherapy. But the question will remain whether to add immunotherapy with trastuzumab, which they tried in gastric G-junction tumor, which showed higher response rate, but although it does not translate it into the better overall survival. That will be a question for future trial to answer.
Thank you, Dr. Rakesh. We can take 1 or 2 questions from the audience if there are any. If I may ask, what is your protocol for giving neoadjuvant chemotherapy in locally advanced gallbladder cancers? So what regimen you use and how is the response rates?
So it depends on the performance status. There is a phase 2 trial from AIMS in which modified FOLFIRINOX was used. About 29 patients were enrolled and conversion rate was around 44%. So preference is based on the age and performance status. If it is good, modified FOLFIRINOX, otherwise cisplatin or oxaliplatin combination can be used for new adjuvant approach. Thank you.
Invariably end up with some form of jaundice and
Yes.
biliary tract obstruction, and then they become ineligible for chemo invariably after the jaundice sets in. Do you think as soon as we diagnose cholangio or gallbladder, given that the overall survival is so low, do you think we can just prophylactically put off a stent to get more time?
If you go with any invasive procedure, it will have its own complication. That can also lead to cholangitis. So I think it should be done as needed, not prophylactic.
Thank you, sir.
Actually, that was the subgroup analysis. There is no separate trial for that, and overall response rates were not segregated in that trial. But as per the subgroup analysis, responses are very poor in gallbladder cancer. In general practice also, gallbladder cancer does not respond that well to immunotherapy. But yes, if you add, in particularly HER2 positive patient, if you add trastuzumab with immunotherapy, I feel responses should improve. As it has been shown in Keynote Trial 811 in G junction tumor, response rate increased by 20% by addition of trastuzumab to immunotherapy. But this is a question of research.
So if patient present with case of bilirubin 4, so he is unfit for gemcitabine. Just I will take it. So in that case, can we try with trastuzumab plus immunotherapy?
With bilirubin 4, I think we can use chemotherapy by reducing the dose.
Just discussion wise.
Yeah.
So if patient is unfit for chemotherapy,
Hmm.
can we try with trastuzumab plus immunotherapy?
Without chemotherapy, response rates are not that good. Some form of chemotherapy should be used to downgrade the tumor.
Thank you so much, sir. I would like to thank my chairperson over here. And we are really sorry for the inconvenience caused because of the entire session on the behalf of Fortis Cancer Summit. So here we conclude our session for the day. Thank you so much, sir.